for inguinal hernia can be extended to the ventral hernias as well. We all are aware that about the classification of the European Hernia Society for primary ventral hernias. So the hernias are classified as small, medium or large depending upon the size. It can be epigastric, umbilical, spigelian or lumbar. Now some very important steps. Actually this Etep ventral hernia, this is something very complex. You need to understand the surface anatomy as well as the layers of abdominal wall very intricately, so before you start proceeding towards performing these procedures. So surface marking, first and foremost important is surface marking, whereby what's important that we take the patient and we mark the subcostal lines are marked, the linea semilunaris is marked, the hernial defect is marked, and we plan the procedure accordingly so that we respect the lines and the layers. Now, next important step that I want to convey is the patient positioning. The patient is placed supine, the table is bent both at the head end and at the foot end, so that what happens is table is angulated actually. What happens is this lengthens the abdomen, and once we are placing the ports horizontal, it does not, these ports do not come in line with the bony prominences. The next important step in Etep is the access port. Mostly we make access in left subcostal region. A 10 mm incision is made, and there are various types, various methods by which we can make the access. One of the access methods is open, which is very commonly used. Another is if you have a VisiPort, then you can use a VisiPort for this. If you have balloon, whether indigenous or tailor-made balloons, they can be used to create this space once we start with our first port. The next step in Etep is crossover. And believe me, this is the most important and determining step of Etep. Once crossover is done, you are almost sure that you are through with this procedure. If during the crossover time, you go into a wrong plane, you go into intraperitoneal plane, or you go into a plane high or a plane low, then the procedure is probably lost. Some important signs which we will be discussing with the video also is the lamppost sign and the volcano sign. Then next step is closing the peritoneal, posterior rectus sheath and anterior myofascial closure. And the last step is mesh placement, which does not need any fixation as you are placing the mesh in the posterior compartment. Now, very important concept is that due consideration must be given to lines, layers and spaces. They say that some lines are not to be crossed. And this is very important once you are performing a procedure like Etep. You need to know the lines which need not to be crossed. That's why we mark the surface anatomy before performing the surgery. The layers are important. You must be knowing each and every layer very intricately. The spaces are important. Every space is important. You cannot venture a space up, a space down, a space right, a space left. So I'm presenting a brief video of Etep, whereby we have started. I have just tried to cut short this video because of paucity of time, whereby we have created an access which has been done by an open method, and you can see that we are dissecting into the retromuscular space. You can see that on the floor is the posterior rectus sheath, and you can see that with only blunt dissection using the camera, you can advance and you can go along a plane. So what happens is we try to create, first of all, we try to create a space for placement of second port and the third port so that we can perform the dissection. So once those things are done, once the second port is done, the third port is done, we will first go into this, down into the space of Bogros. And after that, there is the step that is crossover. Now, just to cut this video short, I have directly gone into the crossover, and you can see that that the crossover, it's very, as I told you, that this is the rate limiting step of this procedure. It is very important that this crossover, during this crossover, we should be, once we are cutting, we should be sure that there should be at least some cuff of, some distance from the linea alba, and we should not be cutting directly upon the linea alba. At least what is recommended is that at least we should be 5 millimeters below the linea alba, so that we are sure that we have not damaged the linea alba. So this is most important and rate limiting step of our procedure, that we are cutting just below, at least 4 to 5 mm below the posterior, linea alba. So once the crossover on one side is done, what we have to do is that we try to go into the same plane and go into the retromuscular space of the opposite side. You can appreciate, can you see the muscles on the other side, on the roof? That is the retromuscular space on the opposite side. Now, there are other methods also how we can achieve this retromuscular space on other side. We can place the ports on the contralateral side and achieve a retromuscular space. Now, we have to, once the retromuscular space on opposite side has been reached, what we have to ensure that we have to create space which is enough for placement of mesh. And again, here comes the point that I have already talked about, is the lamp post sign. We have already surface marked this linea semilunaris. We have to try to be within the limits of linea semilunaris and not cross it. Important sign is lamp post sign, where the neurovascular bundles are entering, and we must try to preserve them and not damage the neurovascular bundles. So once enough space is created on the contralateral side, what we come towards the hernial defect. And here comes the volcano sign. You can appreciate, it just looks like a volcano. So now we are directly approaching the hernia, whereby very intricately, very gently, you have to try to reduce the contents along with the posterior rectus sheath. So once this is done, sometimes for this step, it's very important that preoperatively we know that there is no gut as the content of this hernia. That can be done by doing a CT scan preoperatively, or that can be done by doing a diagnostic lab before we start with the procedure of Etep. So here you can see that we have just taken down the hernia. We have taken down the contents. Then after that comes then the mesh placement. After we have repaired the anterior and posterior facial layers, the mesh placement, the mesh does not need fixation, as I have already told that this is the posterior compartment, and the pressure itself suffices the mesh to stay in place. Now this is the paper from the word from horse's mouth, Igor Blansky. They have published a paper, a novel approach using the enhanced view, totally extraperitoneal technique for laparoscopic retromuscular hernia repair. There have been many papers on this, and there is evidence enough that the initial as well as long-term results with Etep Stopa is very heartening. The rates of recurrence are low, and complication rates are less as well in all the papers that I have quoted and all the papers that we have come across in the literature. Thank you.
Thank you, Irfan. I think the session started late. These are short lectures. Better we finish within time. One question would be allowed from the audience, if any. Any questions from audience? Okay.
In the meantime, I'll just come.
Hello.
Excellent video, Dr. Irfan,
Thank you, sir.
and good presentation.
Thank
I would
you.
like to ask, crossing over is the most difficult point, as you suggested.
Yes.
So, for a beginner, what will you suggest?
So as I have already told that, I have also tried many a times, and during crossover, we don't actually know whether we are going in the right plane or not. And we see that we are just inside the peritoneum. So the better would be that we would try to create a retromuscular space on the other side as well. Then try to meet the two planes. That's what I have already told, sir.
No, crossing over from top or from below, both ways possible. Which one
Both.
is easier?
No, sir. I'm saying that both way it is technically difficult aspect of this procedure. There are only two ways of crossover. One is the superior crossover, one is the inferior crossover. But both ways, what happens is once you are initially starting with these procedures, what happens is that mostly you find yourself that while doing the crossover, you are intraperitoneal, and you have to change the procedure. You have to switch over. You have to think of other thing, maybe a IPOM plus or something. You have to change the procedure. So the better method initially would be that once we have created a retromuscular space on one side, we would just put another trocar on another side, retromuscular, then inflate it and create a retromuscular space on that side as well. And then try to join these two. That will be easier.
Thank you. That's a very good point you have given.
Thank you, sir.
Okay.
Hi, Irfan Gordon. Good morning. This was a very nice presentation. I really enjoyed it. I just want to ask, sometimes we face issues, especially when we started doing Etep, the rupture of the linea semilunaris. Have you encountered any such thing, and how did you manage? Thank you.
Sorry, sir. Can you repeat, sir, please?
One of the issues we face, especially early, is the rupture of linea semilunaris. Okay. Have you faced it any time in your cases, and how did you manage it?
No, sir, not so far. And what I understand from your question is that we have to actually mark the lines initially. As I have already told that we do surface marking before we start with the procedure. And the average, we know that linea semilunaris is average 6 to 8 centimeters from the midline. So we mark grossly according to that. There can be variations. As what I can understand, probably you are asking that there can be variations. Linea semilunaris in some patients can be as close as 3 centimeters. In some patients, it can be as far as 12 centimeters. But we take it as average as 6 or 7 centimeters. We mark the semilunar line. So far, we have not, faced any difficulty with that.
Thank you, Irfan.
Thank you, sir.
Thank you. So we go to the next lecture by Dr. Imran Abdullah Khan. He will speak on endoscopic TAR, top-down approach. How I do it.
है नहीं, ये दूसरी प्रेजेंटेशन है, मेरा नहीं है प्रेजेंटेशन फोल्डर का है.
Any technical issues? Please start.
फोल्डर का फोल्डर प्रेजेंटेशन फोल्डर. Good morning, everyone. Greetings from Pars Hospital. I am Dr. Imran. I will be discussing Etep endoscopic TAR top-down approach. So there is nothing to disclose. Indications of indications of component separation or transverse abdominis releases in ventral hernias. If defect is less than 7 centimeter, we don't need component separation. But if it is between 7 to 10 centimeter, then we measure the hernia width with the rectus muscle abdominis width ratio. So if ratio is less than 2, component separation is not required. But if it's more than or equal to 2, we need component separation for facilitation of the posterior facial closure. And if it is more than 10 centimeter, then it also facilitates the anterior facial closure. So this chart shows the how much facial advancement we get with the transverse abdominis release. If we see the maximum unilateral anterior advancement with the transverse abdominis release, it is about 5.5 centimeter in the superior 1/3 and about 9.9 centimeter in the inferior 1/3. But if we see the maximal posterior unilateral advancement, it is 6.9 centimeter in the superior 1/3 and 11.2 centimeter in the inferior 1/3. This diagram shows the anatomy of the anterior abdominal wall, rectus muscle wrapped by the rectus sheath anteriorly, posteriorly, the external oblique aponeurosis and the anterior limb of the internal oblique aponeurosis inserting anteriorly, and the posterior limb of the internal oblique aponeurosis and transverse abdominis inserting posteriorly. This is above the arcuate line. Below arcuate line, all the insertions go anteriorly. This diagram shows the relation of the neurovascular bundle with the internal oblique and the transverse abdominis muscles. The neurovascular bundle penetrates the posterior lamella of the internal oblique and innervates the rectus muscle. This is actually the TAR plane where we have to go. We go into the retrorectus space, divide the posterior lamella of the internal oblique medial to the neurovascular bundle, identify the transverse abdominis muscle, divide the transverse abdominis muscle and go into the pre-peritoneal plane. This shows the patient positioning during the transverse abdominis release. Patient is supine, table is extended, surgeon on the left side of the patient and monitor on the opposite side. Patient moves, once we do the crossover, we move to the head end of the patient. This is the port position. A port is the first initial port that we put by open technique, 10 mm port, and then we start the retromuscular dissection. Then we put the port B and port C under vision. Port B is 10 mm and port C is 5 mm. Port D is 5 mm also. So this is the video showing the retromuscular dissection in the left retrorectus space. Using the same technique as we do in TP repair. The to and fro motion of the camera dissects the retrorectus space along with the Nemo. Our aim is here only to create a space. Don't do a lot of dissection, because if there is bleed, it will be difficult to control. The ports are placed. You can guide them by placing the needle. But once ports are placed, our camera is shifted to port B and we start crossover using our hand, the working instruments to port A and port C. We have to open enough posterior rectus sheath medially and we should be about 5 mm away from the linea alba. And you can use your left hand to push down the posterior rectus sheath and the peritoneum and be as close to the linea alba as possible, but do not penetrate the linea alba. So here we have to be sure that we don't perforate the peritoneum. If we do that, then there will be the pneumoperitoneum difficult to control. So once we cross over opposite side, we identify the rectus abdominis muscle and posterior rectus sheath and divide it. Enter the right retrorectus space and try to enlarge it. Here we should keep one thing in mind, that we don't go more beyond the more than 5 mm beyond the linea alba, otherwise we'll be making the differential of the PRS. This dissection is for placement of the right hand working port. We join the both retrorectus spaces, reduce the hernia content, close the PRS and then close the anterior defect and the linea alba. So laterally we should dissect as lateral as possible, just medial to the neurovascular bundles. We should not divide the neurovascular bundles. After this is done, then we put the right hand working port and then surgeon moves to the head end side and completes the procedure. Now if we need to do TAR, we identify the posterior lamella of the internal oblique muscle in the subcostal region, divide it and then underlying identify the transverse abdominis muscle, hook it and divide it bit by bit. Here we should keep one thing in mind, we should not perforate the posterior peritoneal transversalis facial layer. So once we come lower down, the muscular part becomes the aponeurotic part and here is the transition zone. It is very difficult to dissect here and we should not lose plane here. We should be at least 5 mm away from the linear similars in order to prevent the linear similars injury that will lead to the disruption in the post-op period. So we should be slow, we should be gentle enough to dissect here, find the good plane and then start dissection. We can aid this dissection with the use of the gauze piece to dissect lateral to the linear similars and then identify the plane and dissect it. This way we can prevent the linear similars injury as well as get the nice plane for the dissection. So once you have dissected the this area, then lower down it is the TAPP plane. It is very easy to dissect. You can see we have gained enough length by the division of the transverse abdominis muscle only. Now we start retromuscular dissection. We use it by using the hook simultaneously along with the blend dissection. Hook helps us in dissecting the posterior transverse abdominis fascia layer as well as the peritoneum from the abdominis muscle, and this blend dissection helps us in prevent the oozing and dissection also. We should always start our dissection from the easier place first and then go to the difficult places. During this dissection, the direction of our hook should be anterior and superior rather than posterior and inferior to prevent any injury to the underlying structures. So lower down, sometimes the fat is very much adherent to the flap, so we have to divide it, dissect it in order to gain enough space laterally for the adequate placement of the mesh and proper approximation of the BRS complex. One of these, some areas are done, then difficult areas we dissect slowly, gently, we combine the blunt and sharp dissection, and once we reach the retroperitoneal fat, you can go as lateral as possible up to the psoas muscle. And you can see that by just the this TAR, we have gained enough length, this posterior flap is crossing the midline. So after that, the posterior flaps are approximate with 20 PDS suture. Anterior defect as well as the linear alba is approximate to 1 number PBT, and the dissected space is measured and mesh is placed according to the size of the dissected space. Thank you.
Thank you, Dr. Imran, for an excellent video and presentation. Flawless presentation.
Thank you, sir.
And now topic is open for discussion. Anybody who wants to comment, or one question is allowed.
I think Imran has been one of our students. He has made us proud. And looking at the dissection he does, these procedures take ages together to understand. I compliment him.
Thank
Keep
you
on
so
doing
much,
the
sir.
good work. We are proud of you.
Thank you so much, sir. It is because of my teachers, you, other teachers who has taught me throughout my life. I am very much indebted to you all. Thank you, sir.
Thank you, Dr. Imran. Next speaker is Dr. Mudassir
Shahdar.
N. Shadar. He is a consultant surgeon in the J&K Health Services. He will be speaking on a strange event during Etep inguinal hernia repair. So we would love to listen what is that strange event.
I'll do it. Yeah, large excuse me. Good morning, everyone. Good morning, chairpersons. At the outset, I'd like to thank the organizers for giving me an opportunity to speak in this session. I'll be speaking on a strange event which happened during an Etep inguinal and gave some lessons. So, case is a 36-year-old male who had a BMI of 23, had a bilateral inguinal hernia, which was direct, reducible, uncomplicated. There was no known comorbidity in this patient and no previous surgical history, and I had planned him for a bilateral Etep. Though I could have done any procedure like TEP, but it was one of the first procedures, so I chose bilateral ETP. These are the standard markings. I chose a left upper axis, This is the port site markings, which you can see. I chose an open technique to enter the retrorectus space where you can see the posterior rectus sheath, which is being seen. And I'm doing a camera dissection with a 30-degree camera. This is followed by placement of the first trocar at the level of linea semilunaris. And my dissection continues as I plan to go down into the pelvis and then do a crossover on the opposite side. These are the initial few steps. I am using a very low profile instrument as a hook. Opening up the cobweb space here. Once I was doing this dissection, I was just 15 minutes into the procedure. It was just 15 minutes. And what happened, that my anesthetist asked me to stop. So what had happened was he noticed that there was a sinus tachycardia, hypertension, fall in the oxygen saturation to about 80%. There was a rise in the end-tidal carbon dioxide. It went up to 58. And on examination, I saw once I removed the drapes, there was a crepitus in the abdomen, just up to the neck and face. So patient had developed a surgical emphysema. So steps that were taken, I immediately desufflated the carbon dioxide. Surgery was stopped for about 14 minutes. Ventilatory settings we modified. There was a rapid improvement and patient was stabilized. And we did an intra-op X-ray which showed a subcutaneous emphysema, which you can see on the X-ray, but was without a pneumothorax. So on a 4-point scale, it was a massive surgical emphysema extending up to the chest, neck and face. So I decided to convert into a TAPP. So this is the bilateral TAPP. Once you go in, you see the defects there. These are the both direct defects you can see. And I'm opening up the peritoneum on the right side, doing a conventional TAPP as we do it. This is the direct hernia which you can see, and the pseudo-sac part which I am dissecting there. The other option was to convert to an open procedure, but I choose a TAPP. On the left side, you can see I'm just opening on the left side, and you can see a wider space inside because there's already the space created during an ETP procedure. So it was quite an cakewalk, an easy one on the left side. This was followed by placement of the meshes as we conventionally do in case of TAPPs. Followed by the peritoneal closure with V-lock sutures. So hernia was taken care on both sides. Okay, so outcome of the patient, we did an ABG in the post-op, it was normal. Patient was extubated 10 minutes after the procedure. Subcutaneous emphysema resolved spontaneously within 24 hours and we discharged the patient after 2 days. So why did it happen? So possibilities were a tight skin seal, a gap between the rectus sheath and the trocar, which I used because I used a conventional trocar, it was during my initial cases, the manipulation of the instruments within the tight skin. Elevated carbon dioxide, which I had kept at around 15 millimeter of mercury. As I mentioned, a conventional trocar was used and made a vertical incision in the rectus sheath, and surgical drapes which were covering the body, and I couldn't examine initially, so that it happened. So trocars where the initial tissue seal is loose and the skin seal is tight, carbon dioxide does leak into the tissues. And ideally placed trocars, it should seal the skin and the fascia as shown in the diagrams. If there is a too small a skin incision, it does not allow the trocar to go. And if there is a thick subcutaneous fat, does not allow trocar bone to reach the fascial incision. So what about the literature? What do we see what the literature says? There is a paucity of literature on this topic. It is common in extraperitoneal repairs, probably underreported because it is usually unnoticed. It comes to the light only when it attains some significant proportions. And it is usually not noticed by surgeons, but by the staff. It would be noticed by the anesthetist or your technical staff. It is usually harmless as long as hypercapnia will develop. And there are case reports which show that there are potentially life-threatening complications which can happen like pneumothorax, pneumopericardium, pneumomechanical displacement of the endotracheal tube. There are very few case reports which you will find in the surgical literature. One of the series which showed a reason being an longer operating time, which in my case was not there. It happened just 15 minutes after the procedure, a high end-tidal carbon dioxide, and there's one series, one case report from Safdarjung Hospital. They had shown that there were some factors which you can prevent, like they also noticed that increased operating time, and few more here and there. So what is the lesson that I learned from this? Lesson that I learned was that carbon dioxide-induced surgical emphysema is more common in extraperitoneal repairs. And like yesterday Dr. Bhatia sir showed, now optical trocars obviate this problem. Once you put an optical trocar, so there is no gap. Now use Hassan or conical trocars to achieve this tight fascial seal, and horizontal incision the rectus sheath is preferred because it doesn't open up much. The vertical, once you manipulate with the instruments, the vertical incision may open up in the sheath. And you keep carbon dioxide insufficient pressures low to about 10 to 12 without compromising the ease of the operation. The surgical emphysema may be a pointer of complications and one has to be vigilant. Everyone, the surgeon, the anesthetist, and the staff. So what is the aim of this presentation is to increase the awareness, to improve the patient's safety and to encourage further reporting of these cases and related events. Thank you very much, and please share similar experiences if you have any.
Thank you, Dr. Mudassir. It's a very rare event.
Yeah.
In the initial stages when we started ETAP or TP, especially I am more fond of TP, so we used to have because of poor quality of trocars.
Yeah.
Now the quality of trocars has improved. So
Correct.
we see it very rarely. So it's good you shared with everyone. Now topic is open for discussion. Any question, any comment, please shoot.
Yeah.
Mike.
Yeah.
Are very correct, but despite all the efforts, still in the elderly,
Yeah.
you will still see
Okay.
because of the skin laxity.
Yes.
And somehow the trocar, the fixation of the trocar can never be adequate in the elderly patients. 70 plus, whatever efforts you take, some amount of surgical
So the emphysema will be there.
does occur, yes. But very good presentation.
Thank you. Thank you.
Thank you, Dr. Vandana. It's a good point. Thank you, Dr. Mudassir.
Thank you very much. Thank you. I appreciate it.
So, the next speaker is Dr. John Mohammad Rathar, he Department of Surgery, GMC Handwada. He will speak on transabdominal preperitoneal repair in a case of large left-sided inguinal hernia with a lipoma of cord.
So, respected chairpersons, my dear colleagues, I bring greetings to you from Department of Surgery, GMC Handwada. That's okay. So, I'll be presenting a case of TAPP for a complete inguinal hernia with a lipoma of the cord. So, this was a 50-year-old male who presented with a progressively increasing swelling in the left groin area. So we did an ultrasound that showed a reducible inguinal hernia with bowel and omentum as content. Now this is the intra-abdominal laparoscopic view of the hernial defect. You can see the hernia going deep into the left hemiscrotum. And this was the hernia of the left side. So I had to stand on the right side of the patient for better ergonomics. So the dissection starts as usually by being in the correct plane, raising the flap between the two layers of the fascia transversalis. You can use any energy source of your choice. I'm using a monopolar hook. You can use a scissors or a harmonic device, whatever is available to you. Now, avoid going more anterior towards the muscle because that will lead to a bloody field and spoil your dissection. If you go more close to the flap will be thin, there will be buttonholing. It will require a lot of effort and time to close at the end of the procedure. Now, you need to gain some length and walk over this flap for a certain distance to have adequate space for doing the medial dissection first, which is the rule in any type of laparoscopic inguinal hernia surgery. You are aiming to go to the lighthouse or the Cooper's ligament or the pubic symphysis, and once you reach there, you want to go 2 to 3 centimeters below and to the opposite side to have adequate space for the placement of the mesh and adequate medial coverage of the defect. Now, the little part of the dissection is a little tricky because of the close approximation of the peritoneal flap with the fascia transversalis. It's easy to lose way in this part of dissection. You can go into the wrong planes, but with experience and time, you will be able to you'll be able to do this dissection rather easily and navigate through the tissues. So once we're done with the little part of the dissection, the most important part of hernial surgery comes. That is the reduction of the hernial sac back into the intra-abdominal cavity. Now, important in this step is to identify the correct tissues and use adequate amount of traction and counter traction for completion of this step. Now, we had a large direct hernia, so I needed to peel off the serosac from the sac as I progressed with this dissection. Go circumferentially around it, you can see a large bulky sac loaded with pre-peritoneal fat. Now, this is the important part of dissection, but once done correctly, it is very gratifying and joyful to watch it. I hope you appreciate the pseudosac being peeled off. And as we progress to the completion of the step, you will see the sac coming back into the abdomen as the pseudosac goes back into the hernia. So then we'll shift our focus to the small indirect hernial sac that needs to be dissected off the cord structures. Again, circumferential dissection is the key here. You want to separate the sac from the vas and the gonadal vessels. There will be adhesions that need to be identified correctly and divided without causing any damage to those two important structures. And slowly you will see the vas and the gonadal vessel coming into the view. Now, as you proceed in this dissection, you will see the vas and the gonadal vessel separating from each other like the two limbs of a triangle going to the base that's formed by the reflected part of the peritoneum. Now, that will form the triangle of the doom. And the extent of your dissection is when you see the vas turning medially. Now, at this point of our dissection, I did see a large lipoma that was sitting in the cord area with a lead point going to the deep ring. Now, there is every chance that this lipoma is going to herniate through that deep ring into the groin area, leading to a false sense of recurrence and swelling. So, I decided to get rid of it. Now, remember, at this point of dissection, you're working on the triangle of doom with the major external iliac artery and vein dancing under your feet. So, any wrong turn at this point will be a dead end. So, you have to be careful, and you can use the energy device of your choice. You can use a harmonic if you want to be more safe, but with experience, you can use a hook as well. So, we're almost finishing this part of dissection. You can see a vessel going to the lipoma that we will knock off. So now the triangle of doom is clear to you, and you can see the pulsating external iliac artery in front of you. So the left out part of the little dissection has to be done maintaining the fat planes over the nerves. Now you can see the flap has been completely raised. Now it's time to deploy the half roll mesh into the pre-peritoneal space that has been created for it. The half roll, to make the mesh easily manageable and easy to handle, you want to use the open part of the mesh for the inferior and the medial coverage of the defect. This part of this procedure is a little bit tricky. You will need to make few adjustments for the placement of the mesh. Just make sure that it covers the myofactorial orifice and the mesh is centered around the defect. You can see the corpus through the mesh here. So this hernia was predominantly direct, so I need to transfix this huge direct serosac with the anterior abdominal wall to reduce the formation of seromas in the post-op period that are a source of lot of anxiety in such patients. So once you're happy with the position of the mesh, you need to fix it. So we fix it at the corpus with the tacking device. And the holding suture will come out, and this is the time for unrolling and deployment of the mesh. Now it's very important that the mesh looks very comfortable in its place. There are no unnecessary wrinkles, dimples, or any points of any traction. Because if the mesh looks good, only then it's placed good. Our seniors usually say eyes don't lie. So you see it with your eyes. If you are happy, then the mesh is also happy. So then you'll need to fix it if you want at some safe places for better reassurance. And I fix it on the upper outer edge. And we had a little fogging issue that we managed by drawing the camera at the end of the procedure. Now it is time to cover the mesh with a flap. I'm using a tacking device. You can use a suture as well. There's no difference. You can see flap is really very, I think it's a good flap. And I think that should be the last tacker, and the flap is covering it completely. So this is it. So to recap, this was a defect I started with and at the start, and this is what I achieved. So I was pretty happy with my result. I hope you too are. Appreciate you for listening to me. Thanks to the organizing committee for inviting me here. Any questions or queries, I'll be happy to answer. Thank you.
Thank you, Dr. John Mohammad Rathar. Beautifully explained and excellent presentation. Now the topic is open for discussion. Any question from the audience?
Things where you made your dissection very difficult for yourself. The first thing is, once you pull this cord structures, pull them medially, you will get a better view. You were pulling them laterally. Number two, once you were dissecting the lipoma, you started from the peritoneal aspect. Start from the distal end, it will become so easy, and you don't need a cord tree for that. Your iliac vein was too near. It was too, it's too. Right. Number three, now if you wanted to deal with the defect, excellent. Why put the mesh? Why not deal with the defect, then put the mesh? Again, it became very difficult. These very small things save you around 10 to 15 minutes of time, less of stress. It's not a question, it's just a comment. Excellent dissection. Thank you very much.
Thank you, sir. Thank you for your comments.
Oh, excuse me, I'll not put this question to John. This question will be to Professor Iqbal, again to comment on. Would you really label this much of fat in the core as a lipoma and try to dissect it out, or you can leave it as such? It gives a false impression of recurrence after you've dealt with it. If it pouts out, I think that was okay. Only it should have been towards the peritoneal side. We started from here. That was the only thing. Thank you.
I think we can leave the lipoma inside after proper dissection. Thank you.
Thank you, sir.
Thank you.
Okay. Next.
Next, I call upon Dr. Vijay Kumar, Department of Surgery, JIPMER, Puducherry. Please start.
Good morning. Compared to other lab videos, I am talking about open hernia repair. So I am Vijay Kumar, Associate Professor, Department of Surgery, JIPMER, Puducherry. I am going to talk about my study titled Comparison Between Sutures, N-butyl to cyanoacrylate and self-gripping mesh in open inguinal hernia repair. It's a multi-arm randomized control trial. So gold standard for hernia treatment is Liechtenstein Neoplasty. There is no doubt about that. The problem is chronic groin pain. So this pain is lost even after 5 years of surgery. It's affecting the quality of life of patient. So even though many factors are responsible for that, that most important factor is fixation of mesh. That's why we have done this study to compare the suture fixation with non-fixation like glue and self-gripping mesh altogether. So primary objective is to assess the efficacy between all the three techniques, especially reducing the postoperative pain during elective unilateral hernia repair. The secondary objective were to compare the short-term outcomes, whatever the outcomes happened within 3 months, like numbness, hematoma, seroma, and length of hospital stay. And the second objective is to compare the long-term outcomes that happened after 3 months, like chronic pain and recurrence. Also, we analyze the cost effectiveness between 3 groups. So basically, this is a prospective double-blinded multi-arm randomized control trial. It was done last year. And the study include all the unilateral uncomplicated inguinal hernia for elective repair. The study safely excluded patient with recurrent hernia, joint hernia with loss of domain, and also chronic pain due to any other disorders. So we calculated sample size. We expected a minimum difference of VAS score 1 between these 3 techniques, and the standard deviation of 1.2 VAS score and power of 80. The final sample size was calculated as 93, 31 in each group. These are the preoperative parameters like baseline parameters and intraoperative parameters like length of operation, time for mesh fixation. The postoperative parameter, postoperative VAS score and post-op day 0, 6th hourly, 12th hourly, post-op day 1 and day 2, and at the time of patient discharge. And wound infection, incidence of hematoma, seroma, everything we noted. And follow-up parameters, we followed 6 months, like parameters like chronic pain recurrence rate, early recurrence rate, we analyzed. So once the patient fulfilling the inclusion criteria, the patient were randomized before explanation. So there are 3 groups. One group is suture group. As usual, we use suture with the standard places and standard technique. Instead of suture, in the second group, we used N-butyl 2-cyanoacrylate glue. It came with the 1 ml, so we can fix it to 15 points. And the third group, we used a self-gripping mesh. So after that, we evaluated all the patients. These are baseline parameter between all the 3 groups. So all the age, BMI, reducibility, and the laterality, everything is comparable between all the 3 groups. This is a comparison of requirement rescue analgesia. Before that, I will tell you, we will follow the standard analgesia care in the post-op day 0. If patient having a VAS score more than 4, then we follow the rescue analgesia. It's nothing but initially we will give ketorolac first dose, and it's not settled, we will follow second dose. Then also it's settled, then we'll give morphine. So this is the rescue analgesia. You can see this self-gripping group, only 9 patients have rescue analgesia. That to 1 dose of ketorolac. This is very less compared to other 2 groups. When compared to chronic pain that happened after 6 months of surgery, 3 months in chronic pain, only 2 patients had chronic pain in self-gripping mesh compared to other 2 groups. This was very less and statistically significant also. That pain also very mild. This is a VAS score, the entire duration that self-gripping mesh very less compared to other 2 groups. These are other post-operative parameters among the study groups, mean fixation time, mean duration of surgery, blood loss, hospital stay, and everything is less in self-gripping mesh, but that the cost is very high in self-gripping mesh, almost 3,500 rupees for a self-gripping mesh. So finally, the self-gripping mesh has a least duration of hospital stay, least duration of surgery, and least pain relief. So only problem is the highest cost. We have a lot of limitations. This is a single center study, and the quality of life in patient undergoing in different methods of fixation was not considered, and other complications like numbness, discomfort were not taken into the account, and less sample size. And another critical aspect of this fixation is the cost. And we followed for 6 months only early recurrence. And there is inter-surgeon variation also exist between the operative technique, because we have a lot of junior resident, senior resident, consultant level, so that variation is exist. So this study concluded that Lichtenstein repair, that self-gripping mesh is tolerated well compared to other sutures and glue. However, the choice of mesh fixation seems to be a minor impact on long-term outcome in difference of pain. Based on this study reports, now we are doing another study and same technique in the laparoscope. Etep we are doing. One group is fixation, 3-point fixation. In another group, glue and self-gripping mesh. And these are the material we used in butyl cyanide glue. That's the glue. Actually, this is at intramural funded project. We got 2 lakhs rupees for this project, and we got this mesh, self-gripping mesh, and the glue also. The PGRMC certificate and ethics certificate, and this intramural fund details, 2 lakhs rupees, and CTR registration. Thank you.
Thank you, Dr. Vijay Kumar. You have opened a new Pandora box. Use of cyanoacrylate in especially laparoscopic surgery. We used initially, but we were not very happy. I don't know what is any senior faculty who has used can comment. Dr. Vandana Soni, any comments on the use of cyanoacrylate in laparoscopic surgery?
Cyanoacrylate, that glue itself, when we've used it on the skin for port closure, has not been very, I mean, I don't like the look, feel of it, and I would not prefer to use it inside a patient's tissue. Although you are leaving a foreign body, but the mesh that you're using is supposed to be biocompatible, non-reactive. The fibrotic response it induces is ingrowth of tissues into the mesh. It becomes part of the wall. But that cyanoacrylate that you're putting in there, you know, is it doesn't create a good mental picture. I mean, that was what I would say. The glue has been tried and abandoned at several centers all over the world. So it's a good study. Still, it is certainly not my choice.
Same here, ma'am.
Yeah.
Thank you very much.
So in our experience in pediatric patients, so we have it in the hospital supply, but the problem is if you use it on the epithelial surfaces, it may work well, but in wet surfaces it has hardly any advantage, and it makes the tissues so messy. Rather, theoretically, it disturbs the normal natural healing or the chemotaxis of the tissues inside if you use it. So that is why we also don't like it, except for using superficially on epithelial surfaces. Thank you.
Any other comment, please? Thank you, Dr. Vijay Kumar. We will wait for your response once you complete your study in laparoscopy.
So just a small comment. Because when we carry a wrong name of the procedure, so don't forget to add T in the name of the procedure. Licht. Thank you.
Okay, thank you. Thank you very much.
Hello.
Thank you, esteemed speakers and chairpersons. We'll conclude session 1, and I'd like to request Dr. Vandana Soni to kindly come on the stage and felicitate the speakers and the chairpersons. Our first speaker of the day, Dr. Irfan Nazir.
Were you resident? जो photo में. Can we call someone? इनके photo आते नहीं.
Dr. Imran Abdullah Khan.
Staying in Panchkula.
Dr. Mudassir Shadar. Dr. John Mohammad Rathir. Dr. Vijay Kumar. And now the chairpersons. Dr. Ravinder Kumar. Professor Dr. Subhash Chawla. Professor Dr. Shakil Ahmed Mir. Professor Dr. Abdul Rashid Kumar. Thank you so much, ma'am. Thank you so much. Now for session 2, we'd like to invite the chairpersons on the stage, please. Professor Dr. Atul Mishra. Professor Dr. Ashish Ahuja. Professor Dr. Altaf Kausa. Professor Dr. Hina Bashir. Professor Dr. Mushtaq Chalku. And Professor Dr. R.K. Shrungu.
Morning.
Thank you. Thank you for not coming. Over to the chairpersons, please.
अंडा करेगा तो जल्दी हो जाएगा सर देखिए फ्यूचर प्रेसिडेंट सुबह जो फोटो ले लीजिए बाद में काम आएगा ओहो देखो ऊपर वाला नया प्रोफेशन है ये गणेश नेक्स्ट में डाल दियो
Over to the chairpersons, please.
देखो हम सो जाएंगे हम बता दे रहे सब कुछ अच्छा है सड़क के अंदर हम बता रहे हैं आपको देख लो
डोलो if you want. नहीं नहीं अभी तो फिलहाल अभी डोलो की दरकार है. डोले शोले.
Hello.
Sorry,
Good morning, everybody. I think the hall is getting swollen up, and we are with the second session of today's program. I welcome you all on behalf of my co-chairpersons, and we're starting without wasting further time. I would call the first speaker of this session. It's Dr. Harbinder Singh Bali, is an associate professor from Department of Surgery. He's going to tell us about a novel approach for inguinal hernia. Dr. Harbinder.
हाँ ये 17 जम्मू से. मैंने आपको
Good morning, everybody. Greetings from my Karambhumi to my Janambhumi. And topic for today is a combined TAP. It's a novel approach in inguinal hernias. Just a deviation from the normal TAP surgery. Especially, I would have liked more PGs and resistance to be in the hall because most of my things are for these PGs and residents. So, combined, so laparoscopic hernia repair, this is an effective alternative to open mesh repair we know from years together. And TAP and TAP are the two commonly used repairs for inguinal hernias. So, but these procedures, they require unique skill and understanding of the unfamiliar anatomy, the endoanatomy, which is not taught to us during our first prof. So, when I was a senior resident, the thing was whether to start with TAP or TAP. But our teachers used to tell us, better to go for TAP. The reason being, myself, my Dr. Chungu used to tell me, you always start, and he made me start from TAP. So, because TAP, in comparison to TAP, you are familiar with the anatomy and it's technically easier. So, this is a concept of 5 triangles. This is the endoanatomy. The PGs should learn this thing. The whole inguinal area is divided into 5 triangles by inguinal ligament, inferior epigastric artery, and the vast deferens and spermatic vessels. So you see the place where the direct hernia is medial to the inferior epigastric artery, indirect is lateral to the inferior epigastric artery, and lower medial will be the femoral hernia, and middle one will be the triangle of doom, and the lateral will be the triangle of pain. So you see conventional TAP requires this access to the peritoneal cavity, creation of pneumoperitoneum. Most of the people, it was demonstrated beautifully yesterday by our surgeons from this college and outside. The TAP everything, and you reduce the hernia, separate cord and placement of the mesh, and including the peritoneum, whether you use tackers or sutures. So here I am going to talk about the hybrid TAP technique. So this is just an aberration, just a deviation. It's not that what there are some centers which are doing both TAP and TAP to make this procedure more stronger. But here is just a simple deviation. What we do. This is most of my today's with these pics only. We are making a supraglottic incision just above the umbilicus. So after this, you are direct entry. Whether you want to go with a Versnier or you want to go with a direct with the port. The choice is yours. So once you are inside the peritoneal cavity, as we do with conventional TAP, and you create a pressure of about 12 to 14 mm, then you make a small 5 mm infra-umbilical incision. You retract the subcutaneous tissue, then divide the rectus sheath, make an opening in the muscle, and just push this, whether you want a Venice needle or a scope, which is placed pre-peritoneally. You will see, I'll show a brief video afterwards. You will see there's just this has been, the peritoneum has been raised here. It will be under the guidance. You are inside the peritoneal cavity and still you can just, it will guide you. The inside camera will guide you for the pre-peritoneal placement of the trocar. And after that, you inflate the pre-peritoneal space to about 10 mm. So there are, you are having the pneumoperitoneum and pneumopreperitoneum also. So what will happen? This is the placement. Then you just put the lateral ports, and then this is the peritoneum flap which has been raised, what you are seeing from inside. So to make it simpler for the students, this is I will show you a very simple diagram. So this you see, this is just an hole. This is just, you see, this is a gut inside the peritoneal cavity. And you see this is the blue one is the abdominal wall, and below this is a this is the peritoneum. So after pushing this camera inside the peritoneal cavity, then you put this second Varus needle or the second 5 mm port, and you inflate this space. Once you inflate the space, what will happen? You see, you appreciate this thing. Just peritoneum is just moved below, so there a space has been created between the peritoneum and the muscles. So once the gas is insufflated, the peritoneum separates and the alveolar fixation muscles are dissected, and peritoneum becomes quite easy. Then rest of the dissection is carried as we do in conventional TAP surgery. That is, starting just about the inguinal ring. One of the speakers just showed you the conventional TAP. That's what we do, whether we use a monopolar cautery or a scissors. You start just above the deep inguinal ring, and after separating the peritoneum, the underlying structures, sac, dissected, separated from the cord, structures are restored back in indirect hernia. Indirect hernia will restrict the pre-vesical space and sac pulled from the hernia orifice. So this is after creating the space, we place the mesh over the inguinal floor and taking down on the Cooper's ligamental dorsal aspect of restless lumen with tackers, and the peritoneum is closed with help of tackers, or you can use the barb structures or 3-0 polyglactin. This is being closed, and suction rate put in, cured, trocars are taken out, and wound is closed with 2-0 sutures. And intraoperative patient were assessed for surgical complications, operating time, and procedural amount of analgesic used. Still, we had done 42 patients in the last 13 months. We are still continuing with the study. We have to do at least 50 patients, and the operating time ranged from 45 minutes to 78 with a mean of 52.69 minutes. Rain was put in all patients to know the amount of rain. It was 5 to 15 ml at one removed on the first POD. So post-operative pain was assessed by VAS score, and most of the patients had mild pain requiring diclofenac the first 24 hours. And all the patients were discharged the next day. So complications, we till date we had 5 cases of seroma which were managed conservatively, and in two of our patients we got the mesh got infected, for which the mesh was explanted by local method.
We have 10 minutes each.
This is small, very small video. You just see this thing. This is just a small video demonstrating that under the this intraperitoneal camera, you can just move your this trocar without rupturing the peritoneum and inflate this area. And once the whole area is inflated at the pressure of 10 mm, so after that we dissect, and the dissection will become easy. The first period. Okay. Under your own control. So take home advantage of the technique is easy dissection, very easy. Last time I demonstrated We did that study on with the Tumis and TAP, which was also very easy. And think these are things which the beginners should take up, as they will have a good hold over this thing. And once they start their careers as laparoscopic hernia surgery, they will are going to appreciate this thing. Thanks.
Thank you, Dr. Aravindan. I just had a small query and a feeling looking back when we create a space in the extraperitoneal.
Yes.
So what happens that you create a boggy swelling because the gas gets into the space and then getting into the abdomen, going to that area becomes difficult for dissection. How would you manage that part?
So the thing is, once we achieve the pressure of 10 mm within the preperitoneal space, and you start incising the peritoneum, it beautifully falls down, and the dissection becomes very easy that time.
The concept arose from the fact that we used to do a Tumis and TAP to facilitate the newcomers to raise a flap in TAP. So we went through certain reports that they do this to insufflate the preperitoneal space. It may look good to people, but then we are toying with the idea of going on doing some cases, and one of the postgraduates is given this topic for her thesis.
Thank you. If there are any further questions, we go ahead with the second speaker.
Should we activate this procedure for the younger generation?
I think Dr. Trungu will make a comment on it.
I don't exactly know whether we should give this one, but Tumis and TAP we used to give to the pressures so that the space is easily created and it's easy for them to lift the flap. But we went a step ahead because we had gone through a report. In fact, a couple of reports appearing in favor of this. Whether it should be given to the newcomers or not, or beginners or not, is like debatable.
I think, thank you.
Thanks, sir.
I think
Could we request Dr. Vandana to please come to the desk to deliver her paper, please?
Altaf experience, mas tu barabar chu, ijaz mein likhe de, ina ji di to sahi, nahi kari bas. Manchu.
Okay. Just a second. अभी मेरा वो नहीं लगाया है ना?
They know it. But are you? İmçana aise said bir şey anlatsa imkaş.
A very good morning, respected Chairperson, sir. Thank you, Dr. Atri, and the entire team for inviting me for this wonderful event. Delighted to see these academic goings on here at GMC. I'm Dr. Vandana Soni, and I'm from New Delhi. I work at Max Super Speciality Hospital, Saket. We have been doing the extraperitoneal repair. In fact, my team was one of the pioneers that started this in '96. And what I'm going to share with you are some of the lessons that we have learned and some of our practices which has borne us well throughout these decades. This is my case mix disclosure. About 23% of our cases are hernia cases, and of these, nearly 72% are groin hernias. I have no conflict of interest for this.
Madam, I think
I'm not audible?
Now it's clear.
Is better now?
The distance between you and the...
Okay. Is this all right? Okay, so just to begin with, in the preoperative preparation, apart from the working up of the patient, one thing that we are sensitive about is the post-op urinary retention, because a lot of our patients may go into that, and for that there are certain practices that we've adopted. One of them is to ask the patient to empty the bladder just before wheeling the patient into surgery, restricting the intraoperative fluids, as well as catheterization in patients where there are a situation which is likely either to prolong surgery or lead to urinary retention. The reported incidence is about 5.9 to 38%. Other than that, of course, the alpha blockers should be employed in patients who have symptoms of prostatism, early ambulation, and avoid using narcotic analgesia. This is the operative room layout. Patient lies supine with the hands, the upper limbs adducted. The assistant and the operating surgeon stand on opposite sides of the patient, scrub nurse next to the operating surgeon. Monitor is at the foot end of the patient. These are the two port site placements which are the options in operating. One is the midline 3, where both sides can be done, and there are surgeons who prefer to create the preperitoneal space before inserting the lateral trocars for triangulation of trocars. Access is something I think you've seen yesterday in several of the surgeries which were demonstrated. You place the 3 ports, you mark them. The first initial access port is intraumbilical on one side of the midline. Incising that, you reach the anterior rectus sheath. In the midline, all the layers fuse, so your incision should be lateral to the midline. Anterior rectus sheath is divided horizontally. The rectus abdominis underlying it is retracted laterally, and you see the posterior rectus sheath. This is the area where you can gently with the finger create enough space to introduce your balloon trocar. This balloon trocar is then advanced at an angle towards the symphysis pubis. I'll be telling you how the indigenous balloon trocar is made because the commercially available is significantly expensive. Having created, you insert the Hassan's trocar with a flange to make it airtight. Now this is the balloon dissection. This is the 2 devices there. One is commercial, one is the indigenous one. This is how it is made. 2 fingers of a size 8 glove are mounted on a suction cannula and fixed individually. This provides this balloon sufficient strength to hold about 100 to 150 cc of fluid without bursting. This is the space. You go parallel to the rectus abdominis muscle, and just below the arcuate line is the distensible area because you have the peritoneum previously, which is a very elastic layer. The dissection in TEP proceeds medial to lateral, and to create the entire space which defines your myoperitoneal orifice, these are the steps. 1, you define the symphysis pubis and clear the pubic tubercle and the Cooper's ligament just lateral to it. You visualize the Hasselbalch's area, which is defined by the rectus abdominis muscle on the roof, the lateral margin of that, the inferior epigastric laterally, and the pecten pubis distally. You drop the bladder at least 2 centimeters off from the Cooper's ligament to create the space of residues for the inferior margin of your mesh. Visualize medial to the external iliac vein. That's where your obturator foramen lies, and in the elderly several times you may actually find a small hernia there. Parietalise all the cord structures to about 5 centimeters distal to the deep inguinal ring, or till the point where the vas turns medially. That gives sufficient length for the unrolled portion of your mesh to lie comfortably against the cord structures. Reduce all cord lipomas. There was a presentation just before this. So cord lipomas will give an unsatisfactory outcome for the patient because they may feel that they still have the hernia in situ. And then you dissect laterally up to the anterior superior iliac spine, which marks the lateral limit of your dissection. The last important point is that fixation should always be above the iliopubic tract, and the minimum size of the mesh should be a large mesh. Horizontally, the mesh size should be about 15 centimeters because there's going to be a midline overlap that ensures that you completely cover the myoperitoneal orifice from the medial edge to the anterior superior iliac spine, and vertically it should be about 10 to 12 centimeters because that is adequate length for the mesh to cover from the retropubic area to the preperitoneal area. For large direct hernias, a point to be noted is that reducing the pseudo sac or the fascia transversalis and tacking it either to the Cooper's ligament or anteriorly to the rectus abdominis ensures that the chances of seroma that much less and a better cosmetic outcome for the patient. There is, of course, a well-defined evidence which says that a direct sac should be inverted. There is a grade B recommendation. And alternatively, you can actually close the direct defect also if there is sufficient laxity, although the evidence is grade D, the recommendation is a grade D, because it may not be possible in all patients. In case of a large indirect sac, there should be not too much of an attempt to try to dissect the sac completely, because dissecting a complete indirect sac traumatizes your cord structures that much more, and chances of injury to the cord structures increases. So once you are able to dissect the sac of the cord structures, it should be ligated and divided, leaving the distal sac in situ. Provided the division should be such that the mouth of the distal sac is not too narrow to avoid a seroma formation. Size of the mesh should be relatively large so that the chances of moving in that area are less. The mesh preparation you must have seen earlier also. The unrolled part of the mesh is about 5 centimeters and there are 2 fixation points. For smaller hernias, there should be a minimum of 2 centimeter overlap. For hernias which are larger, at least a 4 to 5 centimeter overlap with a 4 centimeter overlap in the midline. There should always be an adequate retropubic space, and the inferior dissection is critical, and catheterization of the bladder. That's the problem that occurs if you haven't catheterized or if the bladder is not empty. The inferior margin of the mesh tends to roll up, and desufflation should always be done under vision. Early mobilization and early return to normal activities ensures a smooth recovery. So this is a step-by-step presentation. You also saw it live yesterday. You put in the first access is direct, then the first port is under vision. And after creating the space, you put in the second port. This is the dissection of the lateral or entering into the space of Bogros laterally. Again, the dissection is towards the roof. This is reduction of the direct sac. You can see that the inferior epigastric is lying lateral to it. And that is the white line, the pseudo sac and the sac being dissected off. Again, this is an avascular plane, and minimal use of any energy source is required here. So that defines, that's the Cooper's ligament, that's a large direct defect, and the cord structures, inferior epigastric vessel there. And like I said, inversion of the pseudo sac. So in a large sac like this, even if there has been any minimal oozing or no hemostasis is good, yet they tend to collect a seroma there. So inversion ensures a good cosmetic outcome too. Am I done? I can just stop here. Yeah. So this is, of course, the indirect sac. Again, this is something that you saw yesterday. Once the space of Bogros has been reached and dissected out, you can see that is the transversus abdominis, the horizontal fibers of the tendon, the cord structures, the fascia transversalis being pushed back, and then the cord structures being dissected off the sac. Again, you can see here the margin of the sac which is defined. So once you have isolated it from the cord structures, you can simply ligate it and divide it and paratalize the structures. I think we can just skip this. So this is the myopectineal orifice, completely defined. My cursor is not working. So midline pubic bone, the Cooper's ligament, the direct area, deep ring, the triangle of Doom, and laterally the iliopubic tract. So the take-home messages: creation of pre-peritoneal space, balloon dissection, telescope dissection, whatever you want. And of course, just prior to my presentation, the pneumo dissection, which was defined, are all equally effective in creating a working space. Dissection is medial to lateral. Landmarks to be visualized to ensure that you have performed an adequate dissection are the pubic bone, the Cooper's ligament, inferior epigastric vessels, cord structures, the myopectineal, or they mark the myopectineal orifice boundaries. And of course, the fascia over the psoas muscle should be kept intact. There should be adequate dissection to prevent any uprolling of the mesh. The mesh size should be at least 15 by 10. Early return to normal activities can be safely recommended. Thank you. Thank you, and apologies for overshooting my time.
Thank you, Dr. Mann. That was a wonderful educative presentation, especially meant for the ones who want to or need to start the procedure, and was so well specified. There is a comment from Dr. Chalko.
Thank you, madam. You joined us.
Thank you.
And Shungu sir has given this an excellent demonstration. But just for the heck of a comment is with me, which I believe we need to take a comment from the house also, because as of now, around 2012, if we go back to the literature, we got the high definition things came into the market, and we believed that we could go directly now into the 2 layers of fascia transfer cells. It is just a possibility, and it can be done. You know it that you have an anterior vascular space and posterior layer of the fascia transfer cells and the peritoneum. So that is the true space of depth. Because if you enter with the balloon, this is my feeling, you are probably going blindly, you are not entering the true space of depth. If you go to the anterior vascular space, you will do depth, but it will be bloody. The muscle will be very red, fleshy. You must have seen this, it happens. So, but the telescopic technique, Phillips technique, what they call as, going just, it happens 2 centimeters below the umbilicus. It separates, fascia transfer separates. They would believe it is a bilaminar, now Japanese again say it is 4 laminar. Layered structure. We could not see and make it assess it because we did not have high definition camera. As of now, it is possible to enter into the true space of depth, which many surgeons have a faith. That's why they stop making the balloon dissections. They go under vision. They enter the true space of depth, where there is only white and white. As said, white is always right. And you enjoy the non-bloody dissection of. This is my faith, and this is many people advocate making the space by telescopic dissection, because it is possible with telescopic dissection to enter in the space of, true space of depth. This is my feeling about that. I don't know what is the consensus of the house about that. Thank you.
No, I don't doubt your experience, sir, and I'm sure if this can be reported, then the comparisons can be made. As of now, what evidence says, and that is a grade A evidence, that using a balloon creates an adequate and safe preperitoneal space.
Any questions, comments from the audience? If there are none, we'll go to the next presentation. Thank you, ma'am.
Thank you, ma'am. May I call upon the next speaker, that is Dr. Arun Prasad from Apollo, New Delhi. He'll be speaking on robotic TAR for ventral hernias. Dr. Arun.
Slide moving. Yeah, this one, no? Okay. Thank you. Firstly, congratulations to all the organizers and HSI for organizing such a wonderful meeting in Srinagar. We've all thoroughly enjoyed the conference as well as the hospitality. My topic is on robotic hernia surgery by the TAPP technique. So before we move on to the videos which I'll be showing, there are these 3 spaces which are there, which define our ventral hernia surgery. There is the preperitoneal space. On the top, the falciform ligament, as you saw yesterday in the various surgeries for crossover, and down below is the other space which we have been familiar after having done all the inguinal hernia surgery. Apart from this, there is a retrorectal space.
So this lies behind the rectus from linea alba to linea semilunaris. And other than that, we have what is known as a pre-transversalis space, which moves beyond the linea semilunaris right to the corner. So these are the three spaces we keep in mind when we do our ventral hernia surgery, whether laparoscopic, Etep or robotic. And the mesh can be placed in these various planes. So to start with, I will show you a video of a robotic TAPP. Now this is something which is very good for primary hernias. And what you can see, I have marked with the needles the point from where I will be raising my flap. So we enter the pre-peritoneal space. Now robotically, this is much easier than doing it laparoscopically. I don't say that can't be done laparoscopic, but with robotic, with the presence of our instruments which move in 360 degrees and articulate at 90 degrees, it becomes so much easier to create the space. So we have reduced the hernia, and then we go on to the opposite side, again lying in the pre-peritoneal space. This is relatively easy to do when we are talking about primary hernias. In incisional hernias, you can have difficulty. This is a divarication which is then being closed. We've sutured the divarication. And in primary hernias, I would recommend a TAPP approach, whether we are doing laparoscopic or robotic, for the simple reason that we have preserved our muscles, we have preserved the retrorectus space, we have not disturbed anything, and just putting the mesh pre-peritoneal would be a very good option. So we have closed the defect and we are going to place the mesh. So before placing the mesh, we are measuring the size of the space which we have created. So about 15 centimeter is the size of the scale. So this is close to 30. And again, the mesh is being introduced. Once we put in the mesh, then we are going to have the option of either suturing the mesh corners or putting a glue there or tacking it or even leaving it there. Because if you've got the mesh of the exact size as the peritoneal flap, you don't need to do anything. There's no place for the mesh to go. Then we close the flap after this. Then further moving down to the TAM, we can approach in the phalansteal line. And so this is the robotic TAM for a ventral hernia. So that's the robot, and we are now looking from below upwards. So the left retrorectus space is being created now. Then the central pre-peritoneal space. And again the right retrorectal space. So advantage of doing transabdominal is that you see everything right from the beginning. So chances of injury to linea alba or linea semilunaris or any of the vessels become much less because you are going transperitoneal and you are seeing everything. Once we have made the three spaces, then we split the PRS there. The hernias are reduced. And again, we are moving right up to the almost till the Zifi. So now the needle has been introduced and we are going to close the divarication. Here what we do is we turn the telescope 180 degrees. We take it to manual and confuse the robot by telling right and left on the opposite side. And what you see right now is the roof which is at the bottom, and it makes the suturing that much easy, especially when you are suturing a long line. So now this is it appears as if the suturing is on the floor, but it was the roof. The buttonholes are then closed. And again, after measuring, the appropriate size of mesh is put. So we have the two retrorectal spaces on either side. We have the pre-peritoneal space in the center, and we are able to put this retrorectus transabdominally, and the approach is from the suprapubic, the phalansteal line. At the end, after closure, then we close the flap. Then we have a patient here with a subcostal hernia after an open cholecystectomy. And here again, we would be doing a robotic TAR and approaching it from below upwards. So we mark the port sites. That's the large hernia there. Telescope and the two robotic arms. Now the subcostal hernia is being reduced. Now here what is important is that when we create the retrorectus space, we are going to go down right up to the diaphragm. Centrally, we have reached the preperitoneal space. As opposed to Etep approach, I find this much safer because your spaces are right in front of you and the crossover is right under vision. So neurovascular bundle. Now the robotics, we have the availability of ICG on your fingertips. You just click and you can see the ICG component. When you are moving up, the sag gets reduced. And here the dissection has been left there and we are doing a unilateral TAR here. Good thing about TAR in upper abdomen is you get a nice fleshy muscle there. The diaphragm is exposed, so you have the fibers at right angles. That is how you identify the diaphragm versus the transverses. They both lie at right angles. And then both the spaces are joined. So the three spaces picture which I showed you in the beginning is the most crucial thing to remember when we are doing AWR. So then the defects have been closed. And like the earlier videos, I'm running short of time, we will be putting the mesh and then closing the flap. Now we also have options of doing this from both sides. So here what we are doing is, now this is the table being split. I'll just show the beginning and then move on. So we go from one side, see the retrorectus space of the opposite side, and close to the linea alba, we bring a flap down. So this is a flap, retrorectus flap being brought down from the opposite side. Then we will go to the other side. So there will be 3 trocars here, 3 there, and bring the flap down of this side. Once both the flaps are down, then you are able to do the repair. This is useful for large incisional hernias, large divarications with hernias. And where we want to do a bilateral TAR release. Let's see if I can move it. Sorry, fast forwarding option is not there. So I'll just show the change to the other side and then move on. Yes, so when we move on to the other side, when the flap comes down, these ports will become extraperitoneal. And that's the opposite side TAR release. Okay, I'm running out of time, so I'll skip this. This is for a parastomal hernia, again very similar thing which we did. So just to conclude, why robotic AWR? So larger and more complex hernia repairs can be done, and we have seen experts doing complex hernias yesterday. So what happens is, endoscopically and by open technique, a lot of experts are able to do complicated surgeries. But when it comes to an average surgeon, most people find it very difficult to do, say, an Etep in a recurrent ventral hernia. So there the robot, what it does, it makes that surgery simple. So it raises the standard of an average surgeon to match the skills of Sarfraz and Praveen and Rajesh and Vandana. So it raises the standard of an average surgeon, and an average surgeon is able to do more complex surgeries which they are reluctant to do laparoscopic or endoscopic. So that's the biggest advantage which we have with the robot. Wider visualization is there, 3D binocular vision is there. The articulating wristed movements makes it very easy to do all the suturing. So you're not worried about the buttonholes because you know you'll quickly suture them, or your junior who's learning, you'll give it to him, okay, fine, good training for you, suture these holes. And the ease of dissection and suturing, which is the hallmark of any robotic surgery. Thank you very much. Greetings from Apollo Hospital. If there are any questions, I'll be happy to answer.
I thank you very much for wonderful. Are there any chances of post AWR robotic surgery port site hernias?
Port site hernias. See, the chances are the same as any minimal access surgery. The robotic ports are 8 millimeter. Sometimes we put a 12 mm port, especially when you have to put in large meshes. Then we do what is known as a cannula in a cannula. All 12 mm ports have to be closed. Even the 8 mm ports, you know, depending upon various musculature of people, sometimes you feel that, you know, the gap is there, then you have to close.
Any questions from the audience, please, or any comments from the audience?
Thank you, sir.
Thank you.
Thank you very much.
That was a wonderful presentation, Dr. Arun Prasad. So the future seems to have arrived with robotics. I now invite Professor Dr. Ejaz Malik from the Department of Surgery, SKIM, Srinagar. He's going to present management of mesh infections.
A very good morning to all of you. First of all, I thank the organizers for inviting me here, and thank Professor Iqbal and Professor Atri in particular, who have made this event possible here. Being from a referral center, we usually get a lot many complex hernias and the complications that have occurred in hernia management, and they lined up with us. Because in literature also, you must have seen, we have kinds of hernia surgery here. Once a complication occurs in a hernia, usually the person tries to go to some other person as compared to the primary person. I thought it's better to delineate something about the mesh hernia infections and their management. Everyone knows here, according to the guideline, hernia is to be repaired with a mesh. Since AWR is the commonest procedure being carried out world over, it becomes the standard of care for hernia management. Now, implantation of any foreign body like a mesh is always associated with some complications like seroma formation, migration, infection, and even fistula formation. There is a propensity of developing complication in open as well as laparoscopic repairs. In open, it is little more higher, 10%, whereas in laparoscopy, it is about 3%. Now, since it leads to a lot of patient morbidity and prolonged and repeated hospitalization, it can take over the increased cost of patient and resources. This is one of the patients I've seen last week in my OPD, where 3 surgeries have been performed. First a laparoscopic, then second open, then third open, still draining sinuses, and we are intending to do a CT scan and further manage this patient. We need to know the risk factors that can cause these. The most important risk factors are the obesity, whether you do an emergency or a routine surgery, or you carry out a long operative procedure, and open and minimal access approach. You must be seeing in this, there are possibilities of explanting the mesh hernia, which has been infected in superficial, deep, as well as in organ space involvements. There is little higher explantation rate in case of ventral as compared to the umbilical and inguinal hernias. Now, these are evidence-based facts that hospital readmissions occur in VHR, usually with a complication rate of around 29 to 66%. In a meta-analysis where they have found a combined mesh infection rate of 7.2%. There has been a correlation found between preventable risk factors and wound complications. These can occur, I have told you about the open as well as minimal access approach, little less in laparoscopic one. There are usually classical signs of inflammation that occur with hernia mesh infection initially that is evident, and generalized symptoms can also occur in them. This can take a toll on their psychological behavior as well. Especially you are taking the patient for a long time, you're trying to manage it conservatively, try to do the salvage techniques and other things. Unfortunately, little data exists in literature and there are no profound guidelines where how to manage these. Usually they follow up with some other surgeon that I have already told you. First step approach of most of the surgeons is mesh salvagation, which is true. You could do local washes, debridements, and use wax systems and put antibiotic. Give little time, 2 to 3 months. But the data to support management of mesh salvage is again limited. There are different studies that I have shown here, but with monofilament polyester meshes, it is the highest. And long-term studies have shown poor results with mesh salvage. And ultimately, most of these patients may need an explantation. The technique, how to do it, most important is once you are carrying out a mesh explantation, first of all, preoperatively try to optimize these patients. They are run down, they have many psychological problems, there may be nutritional problems. You need to do a preoperative CT scan in order to know the anatomy and the presence of sinuses, fistulas, and others. And do an elliptical laparotomy incision, or you can have even a laparoscopic approach if it is mandatory for groin hernias to remove the mesh. Then you may have to localize the fistula area, and that is the most difficult one to be dealt with last of all. And primary closure usually is avoided, usually secondary closures are taken into account, or you can do a primary closure with a biological mesh, not a synthetic mesh. Eventually, most of these patients who you see that salvage technique is not possible, you might have to do an explantation. It is a difficult technique because it's again a retained foreign body where you have all signs of inflammation and recurrent inflammation. Propensity matched analysis in evidence-based literature shows high rate of post-operative morbidity in these patients. And the rule is that you remove entire mesh, all sutures, all tacks, and other foreign material that is associated with this infected mesh. These are the various figures that show the explantations. You need to have an avoidance of wound complications in these patients. Preoperative optimization and wound closure is an important issue, and delayed primary closures are usually favored by most of the surgeons to have the best outcome. There is still a debate ongoing whether you should do a multi-stage or a single stage, but majority of people have seen they are in favor of a multi-stage approach because this is an infected area. You need not to put a synthetic mesh there. You can do it later on. Some people, yes, in literature have found a single stage, but always use a biological mesh there. There are some key points that have been learned over time that despite advances in surgical technique, this remains an important complication of hernia repair. We have to understand, and we don't have guidelines. So most of the things what a person tries to do is on the experience of the surgeon, what he has gained over time. The risk factors, in addition, I have already dealt. It's best to have tobacco cessation in these patients, few weeks. Have diabetes management. Most of the comorbid conditions are associated with these patients. Weight loss is an important factor that can tell you about the outcome of the patient. In minimal invasive techniques, most of the senior colleagues must be doing perforated sparing, skin and subcutaneous tissue mobilization and incisional wound management has been found to be having the best results. But the most important is you have to stick to the basic principles of surgery. have strict asepsis, meticulous hemostasis, delicate tissue handling. Now, what is the take-home message from this presentation? Initial attempts should be tried for the medical management. Most of the surgeons here must have seen a seroma occurring after mesh. And it is a practice with some people, I don't know why, to aspirate these seromas. Which should be never done, never attempted. And everybody tries to just do the over-investigation, try to do the skin CT scan initially just to see. Please do not do these things. Give some time for nature to act, maybe up to 3 months. Then decide what is to be done next. Yes, conservative management, if it fails, you may have to do an mesh explantation. Again, consider abdominal wall reinforcement with non-synthetic meshes and delayed primary wound closure. There are some colleagues who are dealing in higher centers with having maximum volume. You should take their opinion also into view. You can take other radiologists, plastic surgeons also into consideration and select the proper mesh. This is a case report in literature. I have found one surgeon. He got a fall from a height 13 meters 10 years ago. There was a large incisional hernia and 4 to 5 hospitalization occurred. This was hospitalization 1, 2, 3, and 4. And ultimately, overall treatment spanned over 56 months and involved multiple surgeries, hospitalizations, and complications. And despite extensive treatment, ultimately, the patient did not benefit significantly and was given a stoma without any hernia management. There are some erroneous actions that a person does during hernioplasty which should be known by the hernia surgeon and should be avoided in order to have the best outcome. So in the gist, complications in hernia surgery can occur like a seroma, simple seroma formation up to a classical mass infection, a recurrence or a neuralgia. One has to introspect and see how proper pre-op optimization of these patients, know the risk factors and avoid them, have a proper prevention, and then decide a mass explantation. Thank you very much for patient hearing.
That was a very nice presentation, Dr. Ejaz.
Thank you.
Have you seen any mesh infections occurring years after surgery in your clinical practice?
Oh yes, even 12 years.
12 years.
Yes, previous surgeries done 12 years back, mesh getting infected. Yes, there are reports in literature also. Mesh replacement has been done 8, 10, 15 years ago, and now.
Morbidity and mortality the same or differently?
About?
In the infections occurring years after the surgery.
Nobody knows actually what is the mechanism, but ultimately what you are placing in the body, like you see, you do in joint, you place some processes. You do an intraocular lens, that's a processes. You use a mesh in the body, again, it's a processes. We do lot many hernia mesh placements in VMRs, triple descent, triple compartment syndromes, and even diaphragmatic hernias we do. We place meshes there, but complications can sometimes occur.
Thank you so much.
With the permission of the chairpersons. Dr. Ejaz, can I have a question?
Oh, sure.
Dr. Ejaz here.
From a different guy. Sure. Yes, from a different guy, because I being an orthopedist.
Sure.
You see, like us, you may be having the same threats of biofilms. Do you have kind of, it is any role of antibiotic impregnating meshes?
You see, what you usually do, you try to do culture sensitivity. Most of the times, I'll tell you what happens. Primarily, there is staph and strep, but sometimes you can have anaerobes, or you can have bacteroids, or you can have even atypical mycobacteria. That have been noted.
What I mean to say is that, is there any role of antibiotic impregnated meshes that would prevent?
Biological meshes are always.
Well, in some studies, people have said that infection rate may go down, but I don't think there are cardiac stents impregnated with antibiotics. Everything is impregnated with antibiotics. Sutures are impregnated with antibiotics. But actually, the literature available in is very less. So you cannot comment on that, whether they are really beneficial or not. It is just a presumption. I'll use an antibiotic solution with something, probably the infection rate will be less.
Thank you, Dr. Ejaz. I just had one point to make, which we are all apprehensive about.
Yes.
Getting into TAP, these meshes, explantations, most of us must have. This is the very dirty outcome of a pleasant journey. which no surgeon wants to handle. Thank you for touching this part. It's a debate. But my worry is, we all of us are into now RS, TAR, putting 30 by 30 and this whole abdomen with a mesh. And God save us, because I had one encounter removing this mesh. Believe me, I went to the literature, could not find any concrete, no trials, no comparative studies.
That's what I'm telling you. There are no guidelines still.
Yeah. So what happened that I don't know what is the take of the house, because most of us now are into this job, putting these huge meshes, and nightmare comes with remove what incision to make, how to explant this mesh, what is the future outcome of this patient. This is, I mean, a big dilemma. So if we could have any experiences, Dr. Sarfraz is here, you could tell.
Just a minute before Dr. Sarfraz, I would like to make a comment. Professor Ejaz, wonderful presentation. Being head of the department of a prestigious institute, this was expected from you. And what you touched is the reality.
Right.
What we have is always the bright side, and we always hide our results.
Unfortunately, being a reference center, we come across these patients, and that's why I try to highlight that.
Thank you for coming here and bringing to notice of this house that mesh infections is a reality.
Oh, yes.
And the most important factor is the prevention.
Absolutely.
You go by the standard techniques to prevent infection. I think it can be lessened. It can be lessened to a reasonable degree. It's not going to be zero, but sir, thank you again, sir. A wonderful presentation.
Thank you very much. Thanks a lot.
Professor Chobe sir wants to, because I believe that we need to have.
I have
guidelines
learned
for this.
hernia from Gangaram Center, Professor Chobe, Dr. Vandana. I don't know whether they remember. It was 2004. Once I did a hernia fellowship. We had Dr.
Well, it's a very interesting presentation. What I would say, just comment. First of all, I will be telling that no surgeon should do hernia surgery unless they have a absolutely proper sterilization system. I will be talking.
Mike, sir.
COPES in particular, laparoscopic COPES.
Yeah, is it better?
Trocar.
Hello? Yeah, this is better. I think that should be first. The sterilization has to be given importance whenever there is implantation. Next question, in our experience, we have seen conservation in laparoscopic hernia operation. Conservation doesn't work. By and large, you have to remove the mesh. Earlier, you remove the mesh, easier it is to remove the mesh also, because there is no fibrosis, it's just floating in the seroma and infected material. That is point number 2. Point number 3 is the technique in which the mesh has been placed should be the technique for explantation. So if you have done TEP or TAPP, I think you should go intra-abdominally and remove. That saves lot of, and it should be drained. And many times we have found it atypical mycobacterium. So we will need 3 to 6 months of management. Otherwise, after mesh removal also, they continue to have sinuses. And anti-tubercular treatment has got absolutely no role for such presentation, because we see patients months and months they are taking anti-tubercular treatment, which is of no use. And earlier the implant, otherwise they have tons and tons of antibiotics for 6 months, 7 months, and this is what I would like to conclude.
Thank you, sir. Thank you very much for the wise points. Any other question? Any deliberation? Thank you very much.
May I be allowed to talk a little about it? I somehow have the highest experience of this mesh infections and the port site infection. We used to get very often in our setup. So, and from histopathology also, after even explantation of the mesh or biopsy from the tissues, we found some cases to have AFB and granulomas, exactly akin to the tubercular granulomas. We needed to put them on proper ATT plus the routine therapy that we give to the other patients as well. So it's only my endeavor is to let us know that these things also do occur. Tubercular we have seen. But all said and done, this is a game that's a very tough game, and people, the patients are horrible. As more horrible are you as a surgeon, that you have to put a patient on such nasty antibiotics for a very pretty long time that they drain their pockets, they drain their patients, they put them, I mean, they are all sort of dehydrated always. So I just wanted to take your attention to this kind of thing.
Thank you,
I would just as a gist, just with the experience what we have got, I can tell you honestly, it is better to avoid a mesh salvage. As early as possible, try to remove the mesh. That's the best policy what can be adopted. Thank you very much.
I think we wind up the session. Yes, sir. Thank you so much, esteemed speakers and chairpersons. We now conclude this session, and I'd like to invite Dr. Praveen Bhatia, sir, to kindly come on the stage and felicitate the speakers and the chairpersons. Thank you. Our first speaker of this session, Dr. Harbinder Singh Bali.
Question is not only explanation. Question is the story.
Dr. Vandana Soni.
It is an unending process.
Dr. Arun Prasad. Professor Dr. Ejaz Malik. And now the chairpersons, Professor Dr. Hina Bashir.
We have to follow some guidelines. You don't want to take it.
Professor Dr. Altaf Kausa.
Open mind, yes.
Professor Dr. R.K. Shrungu. Professor Dr. Mushtaq Chalku. Thank you so much, sir. Thank you so much. Thank you. Now for the next session, I'd like to invite the chairpersons, Professor Dr. Munir Khan. Dr. Vijay Bargaonkar. Professor Dr. Rizwana Habib. Professor Dr. Iqbal Salim Mir. Professor Dr. Junaid Ahmed Wani.
इधर आ जाइए
थोड़ा पीछे करो
ठीक है सर इट्स ओके
Over to the chairperson, sir.
Good morning, everybody. Good. We are running short of time, I think 15 minutes late. And with this, we call on the first speaker. This session has four papers, four speakers. We call the Padam Shri Dr. Pradeep Chaube on the dais. He doesn't need any introduction and is known to all. He has been the founder member of IJs and the Hernia Society of India. Also the founder president of the Asia Pacific Society of Laparoscopic Surgeons.
Hey, good morning, everybody. Thank you very much, Munir. And I see the senior surgeons and senior colleagues and dear friends on the dais and off the dais. And it's a pleasure that I've been honored with this request for this particular lecture. My lecture is going to be very, very simple. I know for last 2 days and continuing, you will be seeing a lot of surgical interventions. You will see the technique. What I feel is that what you are going to learn, the technique of a particular type of surgery, which you have witnessed yesterday, and the discussion will continue. My idea of making this presentation is little simple, because once a patient of hernia comes to you, you will find it difficult what procedure is to be given to that. And that is why my choice when we talk about lost for decision making. We know that inguinal hernia is one of the very common hernias. And why I have specifically chosen this is that because this is what I think all the general surgeons will be getting more often with this. If you look at the frequency, you will find that there are 5 to 10% chances of the general population developing inguinal hernia. Of course, males are more prone, indirect hernias are more common, right is more common, and only 33% patient may develop contralateral. And now coming to this concluded slide, that tension-free prosthetic repair. So this is what I would like to emphasize. Yesterday you saw a lot of conventional and as well as the laparoscopic surgery. But the principle, fundamental principle is that the repair should be tension-free and there should be a prosthesis which is ruled, whether you do open or laparoscopic procedures. Now this is exactly what I was telling in this thing. Please do not touch a case of hernia unless you have a proper sterilization system. It is better not to operate patients if you don't have the proper sterilization. Of course, commonly used Sidex and the formalin chambers are absolutely not at all advocated unless you have some facilities like ethylene oxide, ETO, plasma sterilizer, autoclave. Unless you have that facilities, you should not be attempting any hernia surgery because there is a process which is to be used. We talk about anterior approach. I think for decades and decades, anterior approach, that is the Bessinis and Choldice and all those anterior repair of the posterior wall were commonly performed. And now I think gradually they are going into a sort of background, but I would like to mention that anterior approach has got its own advantages and moving on is, of course, the laparoscopy. You have seen the anatomy yesterday. That's why I would not like to go. It's a new anatomy because conventional anatomy is different and new anatomy is different. So it is question whether you should go do the surgery anteriorly or posteriorly. When we talk about the progression today, I think the worldwide it is concluded that Lycostin, TEP, TAPP or ETEP, this is the way forward. Lot of other procedures with a different name are somehow not getting favor in the evidence-based surgical publication. So please remember, whenever you are going to do, most likely These are the 4 procedures you should choose from. Open repair, when you should, quite some time back, it has been the gold standard tension-free mesh repair for inguinal hernia. And as you know, that Lagerstein was the most adopted, and literature shows the best outcome from Lagerstein repair. So, thing is that it is a time-tested technique. It has got a shorter learning curve. So, if you had a learning which was shorter, probably it is better to do this way. Adoptable, like acceptable recurrence. There's a reasonable recurrence rate which is there, and less elaborate technique. You can do in a smaller center, smaller this thing, even where the laparoscopic technique is not used. So, if you are in a situation like this following situation, please do Lagerstein. Patient which is not fit for general anesthesia, recurrence after posterior. So somebody had a laparoscopic surgery done and comes with a recurrence, please do Lagerstein anterior repair. And same way, unilateral repair, you can think about it, and if you are not trained properly. So when not to perform, that is also important. When Lagerstein will not be the right choice. I think it will be in the female, because in a female you are likely to miss femoral hernias. And previous anterior surgery has been done, then the patient should go in for laparoscopic surgery. So now that it is a time when we are moving from anterior repair to the posterior repair, and a big step is to understand the laparoscopic anatomy, and has got a longer learning curve. I will not go into the anatomy. You have seen yesterday TEP and other procedures being done. What is important is to define the myopectineal orifices. All the orifices or the potential area for hernia should be defined, and the basic is creating a bigger space, using a bigger mesh in these cases, because you must understand that all these meshes, they contract, and when they contract, the areas for recurrence are open, and this is important. And most of the literature will say that you should not use less than 15 by 12 mesh for inguinal hernia. It is better to, for a larger hernia, better to use a heavyweight mesh, but for regular hernia you can use a mid-weight 50 gram proline meshes. You need not go in for advanced meshes. Some points to be considered, that most of the time the laparoscopy can be done only with the GA. Regional anesthesia is not very advisable. The previous surgery may make laparoscopic little difficult, and you have the great advantage of using a bilateral inguinal hernia. Gender of the patient will decide. If, as I said, if the female, it is, you will find sometimes obturator hernia and femoral hernias, and which is good that laparoscopically you can cover all these areas. Now, when you do endoscopy, you have the 3 choices: TEP, TAPP, and ETP. And I would like to just discuss just briefly about each technique. But the fundamental is the placement of the mesh is in the pre-peritoneal space. Whether you do transabdominal TAPP or you do extraperitoneal TEP, or ETP, the mesh placement is in the pre-peritoneal space. TEP is little difficult. It takes a little longer curve, and you should be training yourself into a center with doing a large volume center. And here I would extend my invitation to all of you to, at any time, if you want to get into this subject, please come to Max Saket, our institution. We will be too happy and delighted to have you for these courses. TEP and TAPP and ETP, I think, they are different axes, but the placement of the mesh is exactly the same what we talk about. TAPP or TAPP. where you should do. I think some conditions will need a TAPP to be done when there is an obstruction, when there is a strangulation, when there is any situation where you would like to see whether the bowel is gangrene or is congested. So that is, I think, important for all laparoscopic surgeons to have both techniques. They are familiar with both techniques. They are comparable in terms of operating time, in terms of other situations. So I think you can choose TEP and TAPP, and there are surgeons across the globe. Somebody is doing TEP and somebody is doing TAPP. We have seen that if you have a center of excellence, the most likely you will be doing TEP. TAPP has got a great advantage of a diagnostic laparoscopy. You can see other organs, you can see the bowel conditions, and you can see other pathology if available, which is not true, which you can't do with TEP. ETP, I think in a smaller patients, when the area is small, you can extend, you can go away, and you can do ETP. But the only thing which you must consider is that in ETP, the larger area is dissected and exposed. So, compared to TEP. So, when you are thinking about ETP, please consider that ETP, you have to open larger anatomical areas, and in cases of infection of the mesh, could be a problematic as we discussed just now. This is the area you almost dissect in ETP. So this is the reason why I would say that ETP should not be for all the patients. For majority of the inguinal hernias, TEP and TAPP is the preferred choice, and in some selected cases, I would emphasize on that, in some selected cases, you should be doing ETP. So coming to my conclusion here, where do we stand? I think you can go through this logarithm. I would still feel that in emergency situation, there is a possibility of contamination. So you can do a diagnostic laparoscopy for obstructed and strangulated hernia. If the viable bowel is there, you can do TAPP and TEP. And if the bowel is non-viable, gangrenous, then you may do resection and may do anterior approach. It is better to avoid the prosthesis, because when you open the bowel, the chances of mesh infection becomes very high. When you talk about the obvious contamination, I think please don't use the mesh. It is better to come back again after a couple of weeks and months and do the repair. When you are doing elective surgery, if it is a primary hernia, unilateral hernia, you can do for a female TEP and TAPP. For male, still you have a choice of endoscopic as well as conventional anterior approach. And in cases of recurrence, if there is a recurrence after open surgery, it is better to do laparoscopic surgery. And if there is a recurrence after laparoscopic surgery, it is better to do anterior conventional laparoscopy. So what is the best for you? I think, you as a surgeon have to decide what is best, not for you only, but for the patient, what is the best. Any technique which you are using has to be safe. It should be reproducible. Your younger surgeon should be able to do exactly what you are doing. And you should be familiar with technique, and of course, there should be minimal morbidity or mortality of the patients. So now I think with this, we have fortunate a solution, and I bring greetings from Max Institute of Minimal Access Metabolic, Bariatric and Robotic Surgery at New Delhi. We have all our colleagues. Dr. Kullar has been here, Dr. Vanna, you have just heard, and Dr. Manish Bajal and Dr. Anil Sharma is holding the fort in Delhi. So all the best for all of you, and hope you will have a wonderful learning, training and teaching during this period. Thank you very much.
Any questions from the house, please? Any comments? Yeah, Dr. Kumar.
Thank you, sir. Thank you for coming here. Thank you for accepting the invitation of Government Medical College, Srinagar, under the patronage of Professor Ifat, because it's important that I tell you that this is the Department of General Surgery which has put its best efforts to make sure that all of you are hospitably entertained all through this. It's not only a person, it's the whole department, and I must thank my colleagues who have come up to the standard that they're able to look after all of you. Thank you very much for
Thank
coming
you. It
here.
has been pleasure and honor. Thank you very much. Thank you.
Our next presenter, I'd like to invite Dr. Sarfaraz Beg. He's a Secretary, Hernia Society of India, very dynamic secretary. And yesterday he demonstrated us the peritoneal flap techniques. And if you remember, in the initial remarks he said, I will not say anything about the theory. Perhaps he reserved all his remarks for today. So I request Dr. Sarfaraz to give his presentation on peritoneal flaps.
Yeah. Thank you, Mr. President, and thank you, chairpersons, Kashmir Hernia Summit, Government Medical College, Srinagar, so many of you, ladies and gentlemen. It's absolutely a privilege and honor to be here, and we have had a great time since we have landed in Srinagar. And I must say that it is all because of the hospitality and extremely well-arranged academic meeting. And I don't think this can get better in anywhere in India. This is something which I took on the first evening when I came in. And it reminded me of 2 lines I had written about 6 years back. एक वो है जो सारी कायनात बना के चुप है, एक हम है जो खामखा शोर किए जाते हैं. So it's a lesson to myself on humility. Thank you. Thank you. You're kind. Thank you. And very frankly, this is exactly that we need to know and understand that while we're doing hernia surgery, it is not a lesson to become bigger and bigger. It is a lesson to become humbler and humbler. Patients teach you, patients humble you, and that is what science is all made for. It is an understanding of how complex the human body is, how well organized this system is, how intelligent the main system is, and how important it is to be as simple as possible. So before I begin on the peritoneal flap, be a member of Hernia Society of India, be a part of the HSI family. I request you all, Junaid is here, he's going to help you. It's just a click away. I also invite you for HSI Con Indore 26 to 28. He's here again. He will just take your number and name and it will be all done. And there's also World Congress of Abdominal Wall Hernia Surgery in Singapore on 9th and 12th of October. So you can avail these lovely conferences. No disclosures for this. And the reason why I chose peritoneal flap technique, not that that's the only thing we do, but the reason is the entire idea is to make surgery simpler. And it has to be such that everybody can do it. It has to be reproducible. Why? Because hernia is a ubiquitous problem, it's a common problem. And we cannot keep on talking about all the big things like botulinum toxin, robotics, and as well as new adjuvants that are coming in, the fasciotens. We need to live in a real world where we need to make things simpler. Not that there is anything wrong with the bigger things, but it's also important to dwell on the simpler things. Centuries back, we would use twigs, feathers, bones, and quills to brush our teeth. And in 1938, we came up with the simple idea that you can use nylon bristles. So in less than 100 years, all of us have got better teeth, shiny teeth, no bad odor, and we also don't have so much of tooth decay. And the reason is that simple invention, the toothbrush. So simplicity is the ultimate sophistication, as Leonardo da Vinci said. And peritoneal flap is the lesson of simplicity. It is essentially a reeve stopper repair for the hernias, and the hernia sac itself is split into two. One half is kept as an extension of posterior rectus sheath, Other half is an extension of anterior rectus sheath. And when you put in the mesh as a sandwich in the retrorectus space between the two flaps, that is the peritoneal flap technique. Since you saw it yesterday, I am assuming that you have an insight of what I'm saying in these small words. In this first publication, they found that for width of 2 to 25 centimeters hernia in 250 patients, the recurrence rate was only 2.8%. Comes from Edinburgh, Scotland. And imagine, this is a very low recurrence compared to that simple procedure for such complex hernias also. And they said that's probable that the reason why the flap is working is because it doesn't matter how you are trying to bring the tissues together, as long as you can bring the tissue together with any biological tissue. The hernia sac has strength more than we imagine. So the criticism was, well, doesn't look like a true hernia repair. It's not an anterior rectus sheath to anterior rectus sheath. So sorry, this is not a good hernia repair. But we wanted to check this contention, but that's not the only report in the world. So we took, I and Yusuf from Aligarh, we took about 5 cases, very complex cases. The loss of domain was there, wide defects, and we did TAR plus. We did TAR plus the peritoneal flap for 5 very complex cases. And in these 5 cases, we found that none of them, after a follow-up of about 2 years, had a recurrence. The mean setback was 30% and the mean defect was 15 centimeters of these patients. So it worked in our hands. Then we looked at the bulges. So we did the leg rising maneuvers for all those 5 patients to see, well, does it work? And he found, okay. And we did CT scans also. So we wanted to know the reason why it is working. It is not supposed to work. It's just a sac. We looked at the literature, and to a surprise, we found that the first person who actually made a difference on this was Dr. Matupurkar from Maulana Azad Medical College way back in 1990s. And what he showed was there was an inlay mesh. He didn't use a reef stopper mesh or retromuscular, inlay mesh just between the defects, and he used the hernia sac above and below that. And he still showed a 0% recurrence in his 60 cases. He said that he believed that just like the plants, you can break a branch from a plant and put it on another tree, it will still grow. He's thought that the peritoneum is a pluripotent stem cell. It can regrow into many things. He worked on the animals and used it, the peritoneum for ureters in animals. But his main publication, which I think made a difference, was 1999. It was published in World Journal of Surgery. He used 7 dogs and he excised the peritoneum from the peritoneum from one half of the posterior rectus sheath, and he made a hole and he implanted on the hole of the anterior rectus sheath this peritoneum. So from one half he took the peritoneum, and on the opposite side rectus sheath he took out a large chunk of anterior rectus sheath and put in the peritoneum. 3 months later he went to re-explore the dogs. They were all alive. These dogs are all alive. Then when he went in and he took the peritoneum and did the biopsy, he demonstrated that they had collagen tissue just like, a rectus sheath, which means the peritoneum had converted itself into aponeurosis. Now, that is the evidence, the small evidence. So there is probably a metaplasia of peritoneum to aponeurosis, but who knows? So we wanted to do more research. We took about 3 centers from Vikas Singhal's center, Medanta, Aligarh, and ourselves, and we contributed 63 cases till 2023 December. And we looked at these large hernias. They were like 2/3 of them were more than 10 centimeters width. And when we looked at these patients, we found for 17 months recurrence, median, the recurrence was 0. And we looked at all these patients carefully. 1/3 of them were the CT scan as well. And if you see, the necrosis of the peritoneal flap was only in 1 patient. So, what is the advantage? A, hernia sac is cheap. It's free of cost. It's always available. If you're looking at a complex ventral hernia, what you are thinking of so many things, and if you do not have resources, simply think of whether this technique is okay with that patient or not. Number 2, it increases the abdominal domain. A botulinum toxin relaxes the muscle, but here the sac is giving you a wider circumference of the abdomen. It reduces the chance of post-operative intra-abdominal hypertension. There is less chance of post-operative requirement of elective ventilation. You can use this technique for cases with loss of domain, because there the flap is even more. Bigger the hernia, bigger the loss of domain, more the sac. So you can use it. And of course, it brings down your chances of botulinum toxin, pneumoperitoneum, and fasciotens. I think that's a huge, huge thing. Some case examples just to show you. This is an acute pancreatitis patient, had necrosectomy, we did ileostomy, saved the patient, came back with a very bad hernia. We know that the peritoneum is going to be really bad in this patient. The hostile abdomen is going to be there. So what we did, I'll just skip the CT scan. We did this peritoneal flap technique. You can see what we did. We excised, just like yesterday, we excised the skin, bisected it, entered from lower abdomen where we thought there will be less adhesions. Number 3 is the peritoneal flap on one side, made an incision on the posterior rectus sheath, as you see in figure 4, so that the peritoneal flap becomes extension of the anterior rectus sheath. On the other side, did just the reverse. The peritoneal flap was held and the incision was on the anterior rectus sheath, so that this became a continuation of the posterior rectus sheath. Ultimately, we closed the sac in the bottom, and you will see that was used for the anterior rectus sheath. So the final closure is something like this. So this is a very complex case, hostile abdomen. You still can do it with a much less morbidity, much less risk taking. Looks good, decent at about 6 months to 9 months. Now this is a patient where there was a sigmoid cancer. The patients were operated elsewhere. He had a resection and a stoma, and then it went haywire. And there was a devitalized area. The entire area that I'm showing you on the left abdomen was deficient. There's no rectus sheath at all, both anterior and posterior, and there's a huge hernia. So in this patient, how am I going to reconstruct? Again, same thing. If I could take the peritoneal sac on that side, like we are doing it here, and you can see we went on the opposite side as a crossover to do the retromuscular plane on the right side. Now we had peritoneal flap on the left and we had the sheath on the right side, and we could reconstruct. We did a TAR on the left side to get more overlap. So it was from the right linea semilaris to left axillary line, the mesh. And we could put in a huge mesh there. We used the sac to reconstruct, and this is how it looked like. So again, this patient has been followed up for 3 years now. He doesn't have any bulge, no recurrence. So this is how we thought that this contributes. And this is the last example I'll give you. If you have a patient like this, what kind of component separation, what kind of botulinum toxin is going to help you here? If you look at the CT scan, all the lateral muscles are crumpled. The only thing that can be done here is the peritoneal flap. So in this patient, if you had to, we were given a choice, what can you do? Well, that's the only thing you can do. So the take-home message, I think, from this talk should be, it is a useful procedure for incisional hernias. Talking about complex incisional hernias. The larger the defect, the more the need for peritoneal flaps. If you have loss of domain, even more. It reduces the usage of botulinum toxin and post-op ventilation. And I think it's got more strength than we think it has. Thank you very much.
Thank you, Dr. Surfaraz, for the excellent peritoneal flap disposition. Any comments or any questions? Yes.
Thank you, Dr. Sarfraz, first for giving us this chance of organizing the conference here. It was wonderful of you to take out time. I know that you are one of the busiest persons around with so many flapping here and there. And thank you very much. And the wonderful presentation of today's as well as yesterday's surgery. Thank you, sir. Thank you very much.
Thank you very much. Really honored.
Yeah, madam.
For our next presentation, I would like to invite Dr. Praveen Bhatia, and he will be deliberating on what not to do in hernia repair.
It's a homecoming for Dr. Praveen Bhatia, I think.
He is a regular visitor, and he has just visited late, and he didn't have the slightest dyspnea, to our surprise.
Thank you, Dr. Munir Khan, Dr. Vijay, Dr. Iqbal, Dr. Atri, and all of you for remembering us again and again to this beautiful place. And as Sarfraz had started, same way I am going to start with from Mir Khusro's. Agar firdos bare ruh zami ast, ami asto, ami asto, ami asto. Honestly, all my coronaries open up when I come to Srinagar, and we have had so many occasions of operating here in kidney hospital, in SCIMS, and in so many centers that I feel very, very happy from within, not from outside only, but from within. And wisdom is not to be obtained from textbooks, must be coined out of human experience, as Dr. Chirungu had also mentioned when he was chairing the session. And I bring greetings from Sir Gangaram Hospital and Bhatia Global Hospital and Endosurgery Institute. When Dr. Atri phoned me that what should be your topic, and honestly, I told him few topics, he said no, no, no. Then I said, my answer is what not to do in hernia surgery. He says yes, yes, yes. So next 10 minutes, I am just going to tell you 11 lessons which I have learned in these many years of 4 decades. First is that if you're not good in anatomy, please do not do hernia repair. Unlearn, learn, and relearn. And believe me, all of us, when we started from Bassini to Lichtenstein to shoulders to TAPP, TEP, Etep, and so on and so forth, we have been the learners. We have never ever pretended to be the learneds. The day we become the learneds, we are doomed. And second lesson is, please believe within yourself, all recurrences are iatrogenic. Please do not blame the mesh. Please do not blame the patient tissues. Blame yourself. And please do not refer these recurrences to XYZ, or please do not let them go also. If, for example, you had operated a case, and if you had a recurrence, and if you are not interested in knowing your faults also, it is a biggest mistake you are doing for your own learning. So our thinking is, tissue is the main issue. All of us know that. If we respect the tissues, tissues will respect us. If we are extraperitoneal, not extra fascia transversalis. Again and again, I emphasize in all the workshops, please, God has created the planes only for the surgeons, not for anybody else. So please take care that we know our anatomy well, and then fat belongs to the anterior abdominal wall. And please remain extraperitoneal, pre-peritoneal, and then only we will be able to deliver the best. And as I mentioned, please do not send your recurrences. If you send your recurrences somewhere else, then you will not be able to learn. For example, this is the patient in which laparoscopically mesh had been placed, and when the patient comes, you see that the lower margin of the mesh or the lower dissection had never ever been done. The mesh was placed, but never the dissection was done, and that is the cause of recurrence. So when we are doing TAPP or TEP or Etep or any for that kind of surgery for inguinal hernia, we make it a point that the inferior margin of the mesh has to rest comfortably and at the level of the triangle of doom, base of the triangle of doom, and it is not getting folded in, it is not getting rolled in. Then only it will avoid any recurrences. And more important is, as was mentioned by Dr. Professor Chaube also, do the right surgery for the right patient at the right time. And this is very, very important. For example, if the patient is having infection and you start it, then you will have to explant the mesh and you will have to refer the patient to Dr. Azaz. So our thinking is that please do not oversell. Most of the times, most of us are in a habit of overselling our technique. I was discussing with Dr. Sarfraz also, I did not want to say that peritoneal flap is the answer for everything. No, There are situations when you will come to know that the patient needs TAPP, TEP, Etep, TAR, and so on and so forth. So one should always believe on that there are situations, there are complex hernias which will not go to anybody else unless you learn the techniques yourself. And for this, I will urge my younger colleagues, especially sitting at the back, please do not read the CT scan report. Most of us are in a habit of reading the CT scan report and then see the CT scan film. No, we have to learn, we have to unlearn and carry on learning by going to the CT scan department, and then only we will come to know, because we have a privilege. We have a privilege of seeing the CT scan, seeing the patient within, and again seeing the CT scan, so we can correlate it better. So ultimate answer is, please believe this, if you do not know the CT anatomy, you do not know the hernia also. This has been further added. And as we were discussing yesterday also, we are moving. You know what? Life moves on. Initially, nobody had heard of abdominal wall reconstruction. Today we know that functionally we have to give the best possible result. Today we know that linea alba has to be respected. It has to be functional again. And if, for example, if we do not know our steps of surgery, then definitely either we do the complex surgeries or we make them complex also. So our thinking is that when we have started going into the E business, extended or enhanced business, then one should definitely make it a point that we are not abusing is the right word, linea alba or linea simularis. For example, if we cause an injury to the linea alba, we may go into the subcutaneous plane and then the hernia will form. And if we, for example, the linea simularis, then the neurovascular bundle will be damaged, and then again the patient will have lot of challenges. So during the crossover time, one has to be very, very careful that we are not causing any damage to these important structures. I don't think so that I should go into the details of this video, but again and again, we had seen the case yesterday, but our thinking is that please give lot of respect, and as Dr. Chaube also mentioned, please visit those centers which are having large volumes of these kind of advanced surgeries, and then get proctored and then start, rather than repenting and then causing damage to the patient. Our thinking is that there will be many situations in which, for example, you are not able to close the posterior peritoneum or the visceral sac, and then again and again in the back of mind, one should be very, very clear that I should not be responsible for causing a posterior dehiscence. And if the posterior dehiscence occurs, the peritoneum, the intestines can go within, and that can cause damage. And now, again, as we were discussing, there is a role of TAR, transversus abdominis release, or there is no role of TAR. So this is again a gray zone. Please do not believe, carry on thinking, carry on learning, and then only adopt, because there are situations in which TAR will help. There are situations in which modified version of TAR will help. That means we do not cut the muscle, but we go into the pre-peritoneal, pre-transversalis fascia plane and then place in a larger size mesh and ultimately get the best possible result. Our outcome should be our guide, that we have to offer the best to the patient. And in this last decade, all of us have seen that the open complex hernias definitely had a role to play, but now the robotic is picking up very fast, especially in US also. So I would urge my younger colleagues once again, please go for robotic training, go yourself and train yourself for hernia, because robotic companies are also pushing the general surgeons to adopt this kind of technique and then give the best to the patient. And there is a role. For example, there will be some situations in which you are doing laparoscopy, you are not able to progress. So withdrawal is not a defeat. Withdrawal is not a defeat. You can always convert into a hybrid plane and then complete the surgery so that ultimately patient, the beneficiary, is not harmed at all. And as was again presented in mesh infection discussion also, please do not play with antibiotics. Please do not play with anti-tubercular treatment. Explant. If there is a mesh infection, explant the mesh early rather than delaying after so many world-class antibiotics. So it is always better to do your best. And again, we were in the era when we were crows and we had to put the pebble into the pot to get the quench thirst. Then came the era of using the straw, but now you see the cable, the crow, which is absolutely modern, using the AI also, and it wants to quench its stress if you are ready to do it. If you are not ready to do it, then obviously you will carry on sitting and carry on thinking that where should I get the pebbles? Where shall I get the straw? And that will definitely is going to make a difference. And I must, in all humility, thank all my younger colleagues for remembering us here. And I remember when Mother Teresa also blessed us at the time of MBBS degree, we remember that 4 decades have passed, much blood has flown under the bridge. So why not carry on unlearning, learning, and relearning? Thank you very much. Thank you. Any questions, please?
Thank you, Dr. Praveen Bhatia, for an excellent presentation. You are right in saying that an excellent surgeon and a good surgeon should know what to do and what not to do. Thank you again.
So, any deliberations from the audience?
We have already said what we wanted to say. Sir, you are always welcome. Please do grace us frequently and we'll learn what not to do. Thank you very much.
Thanks a lot. Thank you. Thanks a lot. Thank you.
So, I invite Dr. Sumit for his talk on complications of TAR.
Dr. Sumit is the treasurer of HSI and he was one of the persons who was really enthusiastic in coming here.
So first of all, thank you to the Department of General and Minimal Access Surgery, Government Medical College, Srinagar. Thank you to all the organizing chairpersons, Dr. Iqbal, Dr. Atri, organizing secretary, and also to Hernia Society of India. I'm glad that we could all together join our hands together to do all this program, which is benefiting all of us and making learning happen. So the topic given to me was complications, but I thought that, we are still a little way, everybody. There are general surgeons, there are postgraduates, and I thought, let me talk a little bit about the posterior component separation technique, that is the transversus abdominis release. So friends, some of the essentials of the abdominal wall reconstruction have already been outlined by Dr. Bhatia, so that has made my job easier. So the seminal components of what has changed from just being a hernia surgery to what is AWR is midline restoration, restoration of the linea alba. If you have got large defects, then you will need to do anterior or the posterior component separation, use of a large mesh or a prosthetic overlap, which has at least 7 to 9 centimeter away from the edges of the defect. If possible, use an extraperitoneal or a retromuscular placement of the mesh. And if there is a thinned out scar or if there is a fistulous tract, then you need to excise out all the things and give the patient a cosmetic result. Now, in our journey to do this, we have been using many techniques. Till today, the most common technique for the incisional hernia repair in the hands of a general surgeon is the onlay mesh hernioplasty. But we know that the onlay has got its own challenges. So many of the more trained hernia surgeons have moved from onlay to sublay techniques, which is the Reeves-Topa repair. The laparoscopic ventral hernia repair since 1993 brought about a revolution in the incidence of skin and surgical site infections. And therefore, IPOM and IPOM plus I consider a great revolution in the patient outcome. Well, most of these techniques can now also be performed endoscopic, as we saw yesterday. Dr. Bhatia, Dr. Ganesh perform a Etep Reeves Topa and a Etep TAR technique. There is a minimally invasive, less open sublay and a subcutaneous onlay technique. And Dr. Arun Prasad spoke on TAR. And what I showed yesterday was a transabdominal partial extraperitoneal technique. And Dr. Sarfaraz showed a peritoneal flap technique. So you see now there is a plethora of procedures that we can do. But what you should do in which patient depends on essentially three factors: the hernia factor, the patient factor, and the wound factor. And my friend Dr. Sarfaraz came out with this, beautiful algorithm, which I think almost 5-7 years back, which is becoming more relevant by the day. So if you have a small defect, you could, less than 1 centimeter, 1.5 centimeter, probably you could do a suture repair or an IPOM plus if the defect is 2 to 4 centimeter. If the defect is 5 to 7 centimeter, you could do hybrid repairs, Etep Reeves Topa repairs. If the defect becomes even larger or is an atypical site, you could use the Etep TAR technique. And finally, for very large defects, there is the open techniques and as well as, joining hands with your plastic surgeons to do a posterior component separation. Now, when we talk of large abdominal wall reconstruction procedures, we see these kind of large hernias. And therefore, these larger defects need more medialization. Now, the point is how to get these muscles together. They need more medialization, and any defect more than 8 centimeter, it is difficult to get the edges together when you are doing a laparoscopic IPOM plus technique. And therefore, you need to, resort to some kind of component separation, which can allow for medialization by almost 10 centimeters from both the sides. So once you do that medialization, you can recreate the linea alba. Now it is very well known that if the linea alba is recreated, the recurrence is less. So if you have a bridging repair, it leads to more recurrence. Apart from that, the patient breathes better, defecates better, so there is improved functionality. Also, it gives us the opportunity to place a large retromuscular mesh, which is a very vascular plane, and it can be done with clean and clean contaminated repairs. If the defects are only between 8 to 10, you could still do it endoscopically. Now, there is a controversy because actually the component separation techniques were started by plastic surgeons who used to do the anterior component separation. They used to divide the external oblique aponeurosis lateral to the linea seminaris. But you had to create large skin flaps to do that, and there was more incidence of seroma and necrosis of the skin, and it was difficult in patients with stomas. So it did not become very popular amongst general surgeons. But posterior component separation, since the time it has been described, has become very, very popular because of less wound complications, and I said sublay position of the mesh, and you can do a giant prosthetic reinforcement of the visceral sac. Also, it is versatile, right? So all credit to these two pioneers, Dr. Yuri Novitsky, who is the originator of this technique for AWR in a large complex hernia. So I have already said what is the advantages of doing this. And if you do a massive ventral defects, the recurrence rate published in literature are only 4.7%. Also, dynamometric studies showed improved functionality of the abdominal wall following a TAR technique. Very important that we plan these patients well. So anybody with an incisional or a recurrent hernia, CT scan, like it's been said, is absolutely mandatory. And also we need to control their blood sugar. We need to stop smoking, give good chest physiotherapy, and weight loss in case of obesity, or Botox in case of loss of domain. So we need to prepare these patients well. I will just briefly say, if the time permits, the key steps of the posterior component separation technique TAR. There is a long midline laparotomy. Safe entry into the abdomen is very important because the bowel may be adherent, previous mesh may be there. Very careful adhesiolysis because an enterotomy may completely change the picture of what you are trying to do. Assess the bowel, mesentery and the solid organs, and then completely pack it. Now, if you have seen this picture, you can see that the transversus abdominis muscle actually comes on the posterior rectus sheath more medially than it was thought initially. And this is the principle that we use to get into the space beyond the linea seminaris, that we divide the transversus abdominis muscle and get into the pre-peritoneal or the pre-transversalis plane. lateral to the linea seminaris. So this is first we create the Reeves Topa plane, and then you have the posterior rectus sheath at the bottom, on which you will have fleshy fibers of the transversus abdominis muscle, especially in the upper abdomen. So when we say, the classical TAR starts from the top, that is the subxiphoid area, and then we go down as the TA muscle becomes more and more aponeurotic in the lower half of the abdomen. If we say bottoms up TAR, it means we start from below and then go up. So this is the name. This is an operative picture which shows the similar Reeves Topa plane and the neurovascular bundles which are there. The neurovascular bundle are the lateral boundary limit. We cannot go beyond them. If there is damage to linea seminaris, you will create a completely unstable abdominal wall where the medial parts are completely disconnected to the lateral part of the abdominal wall. Again, the subxiphoid dissection is very, very tricky, because if there is the fibers of the diaphragm, and you can create an iatrogenic diaphragmatic hernia if you damage the diaphragmatic fibers. And I'm saying all this to make you understand that the TAR is a complicated technique, and we need to learn it well from the experts. So what are the limits of the dissection? Superiorly, it is the diaphragm and the central tendon. Inferiorly, it is the pubic bone and the space of Retzius, and laterally you can go up to the Girota's fascia also. And then we close all the peritoneal holes, and the minimum size of mesh that you will put is a 30 by 30, but usually we put 50 by 50. And it's a macroporous, medium weight polypropylene mesh. So you can see the extent of the medialization that you can get. So final concluding steps of PCST TAR is the mesh fixation at the Cooper's ligament, closure of the posterior and anterior sheath. We use a small stitch technique with PDS 20. Do not use the loop technique, and preserve the sac till the end, which we saw how we can utilize the sac either on the posterior side or on the anterior side if there is a bridging repair. If there is a redundant sac, you can excise that, and the skin. Retromuscular and subcutaneous drains can be put, and of course always check the peak airway pressure at the end of the surgery to make sure that the patient does not have abdominal compartment syndrome, and followed by skin closure. So what are the general contraindications to TAR? Bleeding disorders, decompensated chronic liver disease, chronic kidney disease, patient who has already got a retroperitoneal surgery like pancreatic necrosectomy, previous periperitoneal or retromuscular repairs, and a need of paniculectomy and abdominoplasty, which we usually do not combine with TAR. Morbid obesity, never attempt a TAR. So I think it is very important that you make sure that these patients get bariatric surgery or something done to come down with the weight. And last but not the least, you can never combine anterior with the posterior component separation, because if you will divide two muscles of the abdomen, the external oblique and the transversus abdominis, you will lead to an unstable abdominal wall. So never combine with the anterior and the posterior component separation techniques. Thank you so much, sir, for giving me this time. I hope I didn't exceed by much.
Thank you, Dr. Smith, for the wonderful presentation. Any comments from the experts?
Should I say? Thank you, sir.
Thank you so
very much.
Thank you so much for this opportunity.
Thank you, esteemed speakers and chairpersons. We'd like to conclude this session. And I'd like to invite Dr. Rajesh Khular to kindly come on the stage and felicitate the speakers and the chairpersons.
Very, very hard.
The first speaker of this session, Padma Shri, Dr. Pradeep Chaube, sir. Dr. Sarfaraz Jalil Beg. Dr. Praveen Bhatia. Dr. Sumit Shah. Thank you so much, sir. Now, we'd like to felicitate the chairpersons now, sir. Okay, sir. Dr. Bargaonkar sir is kindly requested to come on the stage, please. The Hernia Society of India team, could you please come on the stage for a group photograph, please? All the HSI team. Thank you so much. Now, sir, could you please a big clap for the Hernia Society of India. Now, felicitations for the chairpersons of this session. Dr. Vijay Bargaonkar, sir. Professor Dr. Junaid Ahmed Wani. Professor Dr. Rizwana Habib. Professor Dr. Munir Khan. Professor Dr. Iqbal Salim Mir. Okay, sir. Thank you so much. Thank you so much, sir. Now we'd like to start the next session. We'd like to invite the chairpersons of the next session, session number 4, Dr. Sarfaraz Jalil Beg. Kindly chair the session. Dr. Ganesh Shenoy. Professor Dr. Muzaffar Jan. Professor Dr. Manzoor Lattu. Professor Dr. M.R. Atri.
Namaste, sir. Hello, ji. Namaste, sir. Ganesh. Hello, Dr. Manzoor.
Atri sir, please come to dais.
Over to the chairperson, sir, to coordinate the event.
So we'll be starting the session 4 now. It's my privilege to request Dr. Rajesh Kular to come for his presentation on this. His topic is hybrid procedures for complex ventral hernias. Dr. Rajesh Kular.
Good morning. First of all, I must congratulate and thank you, the Hernia Summit organizers, Professor Iqbal, Professor Atri, and the whole of organizing team for coming up with such a wonderful program in a wonderful city of Srinagar. Thank you very much. What I'm going to talk about is a procedure which all of us can do. Every general surgeon who has started doing laparoscopic surgery should be able to do it. And as Sarfraz said in his own presentation, that we have to make it simple, approachable, doable in most of the hernia cases. The big hernia cases which you saw complicated, I think that constitute only 1 or 2% of all the hernias which we see in our practice. So the main goal of ventral incisional hernia repair is that we should be able to reduce the hernia, prevent further herniation, construct the midline linea alba, restore the abdominal wall integrity for a proper functionality. We know that the mesh repair is much better than tissue repair because it causes less recurrence in the cases. So the option available to all of us is the open hernia repair, laparoscopic hernia repair, IPOM, IPOM plus, abdominal wall reconstruction, and I'll add one more to it, the hybrid procedure. Now, open abdominal wall hernia repair, we'll all know that it does have a high morbidity in the form of increased wound infection, pulmonary complication, and long hospitalization stay. And since 1993, the IPOM came to our armamentarium. It totally changed the scenario of abdominal wall hernia. There was ready acceptance, and there was low morbidity, there was minimal wound infection, the pulmonary complications went down, and the patient was able to go back home much earlier with less pain, less wound infection, and less rate of recurrence since we've started doing IPOM plus, closing the defect. We know that the intraperitoneal placement of prosthesis, especially which is produced by the laparoscopic ventral hernia repair, is safe because we have been using it for almost now 30 years. But there are limitations of IPOM, IPOM plus, especially in a large hernia if the defect is more than 6 to 8 centimeter, complex hernias, as well as the hernias with loss of domain. So if there is loss of domain or if there is need to construct abdominal wall, which is required for large complex incisional hernia or loss of domain, you have to do some sort of abdominal wall reconstruction in the form of component separation, anterior or posterior, which can be done open technique or laparoscopic technique. But there are certain limitations of AWR. The most important limitation is that it is a very difficult procedure and proper training is very, very necessary. Unless and until you are properly trained for these procedures, my request to everybody would be that do not attempt doing this procedure just watching 1 or 2 videos. You have to understand the integrity and nitty-gritty of these procedures by visiting the high volume center and then learning the procedure. Because if you have not learned it properly, it can lead to serious complications. And if it is done by the open technique, even the wound complication can increase. So the safe choice of procedure for laparoscopic surgeons in case of large complex abdominal wall hernia can be a hybrid technique. Now this hybrid technique consists of first doing a laparoscopy, assess the abdominal cavity. If there are adhesions, you can do a regiolysis, and then give a limited targeted skin incision, which increases which helps you in doing a safe bowel reduction as well as adhesiolysis. If there is some tear in the bowel or any enterotomy, you can suture it, close the hernia defect under vision from outside, and excise the excessive redundant skin or tissue. And after the airtight skin closure, you can go inside again, put a mesh laparoscopically with or without a drain. The indication of this technique would be excessive redundant abdominal wall, large hernial defects with divarication of recti, dense bowel adhesions, and if there is bowel incarceration. Few videos, large hernia which required excision of the skin. So laparoscopically, you can reduce the omentum, large amount of omentum. And once the whole omentum is reduced, you have a small defect which can be closed laparoscopically. Because you have to excise the skin. There is no harm in excising the skin before. Before you put in the mesh, you must prepare the bed for placement of mesh. And then you excise the whole skin and the excess skin, close the defect, and before completely closing, you can put a trocar, and through this trocar, you put in the large mesh. This helps you in performing this procedure with just 2 or 3 5 mm ports, and the incision for excision of skin is has to be done anyway. And this is the final result. Another hernia with a large defect, you have large sac which needs to be excised. So after reduction, give a skin incision which needs to be excised, close the defect under vision, and then go inside. In lower abdominal wall hernias, we always make a lower abdominal peritoneal flap so that the mesh can be placed up to the pubic symphysis and then put in a large mesh. Another case with dense bowel adhesions, because of the placement of previous mesh to which bowel is adherent, sometimes separation of bowel from these meshes can lead to enterotomy. And you all know that once enterotomy occurs, then you can't complete the procedure. Doubtful serosal tear, which could be sutured laparoscopically. But as the bad skin incision and excess skin had to be excised, one could easily bring the bowel out and made sure that there is no damage to the bowel as such. Close the incision from outside and again go inside after doing a skin tight, watertight closure of the abdominal wall, and then put a mesh from inside. Another bad incision, sometimes it can happen that the bowel is so badly adherent to the mesh and it becomes impossible to separate the bowel from the previous mesh, and you may have to take the mesh along with the bowel wall to prevent injury to the bowel. And in such cases, again, because ultimately you have to excise this excess skin, you open the Take the bowel out, remove the mesh from the bowel under vision, which you can do safely. Safely put serosal sutures. Now, this prevented the enterotomy. If this had been done laparoscopically, there could be a chance of enterotomy. Again, put a trocar to put the large mesh in with a no-touch technique through the trocar. And as the lower abdominal wall hernia, always make a flap and then put a large mesh. Another case with similar large mesh previously placed, bad adhesions, and the same procedure was done in this case also. So friends, this procedure improves safety. It prevents enterotomy, and if there is a bowel injury, you can recognize that, suture the enterotomy, and if the mesh is along with the bowel, you can excise the mesh properly. It serves as a bridge between laparoscopy and open repair in difficult patients. It retains all the advantages of laparoscopic approach. You can see the occult hernias, you can put in a large sublay prosthesis, and it facilitates the closure of large hernial defects also. There are many papers which are there in literature which advise to do this technique with significant benefits. So the hybrid repair in complex abdominal wall hernia, it combines the safety of open surgery with the several advantages of laparoscopic approach with favorable surgical outcome. Thank you.
Thank you, Dr. Kuller. Any questions, please? Thank you, sir.
Thank you.
Thank you. Thank you, Dr. Kuller, sir.
Thank you.
I feel blessed. I have been trained through your legendary hands. And when I requested him for the topic that bails us out in complex situation, so he sent me this topic, hybrid procedures, and it was just a throw and just see. These are the practical solutions we, you see, which is available to all of us in such complex situations when we face, rather than, you see, going to do some more complex procedures. So this is such a simple technique, any one of us can do it. Thank you, sir. Thank you so much.
Thank you very much. Thank you. Thank you.
So let's welcome the President of Hernia Society of India, Dr. Vijay Porgamkar, sir. He'll be speaking on hiatus hernia, recent updates in diagnosis. Sir has a special interest in upper GI endoscopy, both diagnostic as well as therapeutic.
Thank you, chairpersons. Good noon to all of you. Greetings from the Hernia Society of India. And again, big applause and the big appreciation, thanks to Professor Atri, Professor Iqbal, and the entire team of GMC Srinagar for putting up this wonderful show. And we are enjoying this hospitality and also the academic sessions since yesterday. The subject for me is hiatus hernia and the recent updates in the diagnosis. When we talk of diagnosis of any disease and some investigations, it is necessary to know what are the limitations of these investigations. And if the investigation is sensitive in a particular part, whether it has got any clinical application. So unless and until we are through with this concept, then to extract something from the investigation could be a futile thing. The incidence of GRD in India is very high. 15 to 20% of the population suffers from GRD. And incidence of hiatus hernia in general population also is 20%. So 1 out of every 5 person suffers from the GRD. The incidence of hiatus hernia and the GRD increases as the age advances. And 50% of the patients of GRD, they have hiatus hernia. The association of the hiatus hernia and GRD is more of causative and rather than simple coincidence. The diagnosis of the hiatus hernia, there are 4 types as we have seen. And there is type 1 and type 2, 3 and 4. Type 1 I have taken into a different bracket and type 2, 3, 4 are in a different bracket. The simple reason is these type 2, 3 and 4, they contribute to over 10% of the total hernia, hiatus hernia, and type 1 contributes to about 90% of the hiatus hernia. The important thing here to understand is hardly 10% of the cases of type 1, they need surgery, whereas almost all patients in type 2, 3 and 4, they need either elective or an emergency surgery. So we have to be very careful in advising a surgical procedure for type 1 type of a hiatus hernia. And for this purpose, we have got certain set of investigations. One is the endoscopy, which is supposed to be a gold standard. Second is the high resolution manometry, and third is the imaging. Now, endoscopy, though it is taken as a gold standard, it has its own limitations. The fact that we diagnose hiatus hernia on endoscopy by two ways. One is the axial length between the hiatus and this squamocolumnar junction. If it is more than 2 centimeters, then we say it is a hiatus hernia, sliding type of a hiatus hernia. However, the measurements are not very correct or very accurate in reality because patient is reaching and the G junction as such moves at least 3 to 4 centimeters up and down when the endoscopy procedure is going on. So that is why this measurement, it could not be very certain, and just by diagnosis of a hiatus hernia, by saying that it is a 3 centimeters axial length, it is not correct. The another way to diagnose it is a Hill's classification for the hiatus hernia. And here we have got 4 grades, grade 1, 2, 3 and 4. And this depends upon the laxity of the hiatus in relation to the scope that we have passed in, and we do a retroflexion. Important thing here to note is that the type 1 and type 2 or grade 1 and grade 2 are the normal morphology of the hiatus, and only grade 3 and grade 4 are pathological. So if you are writing a report on endoscopy about the hiatus hernia, don't ever write a type or grade 1 Hill's hiatus hernia because it's a normal. It confuses the patient and it can also confuse a clinician who has referred you for the scoping. Just by saying that patient has a grade 3 or a grade 4 Hill's type of morphology or the hiatus hernia, does it become an indication to advise surgery? Not at all, because the patients may not have any symptoms. Rather, the next thing is if we have the esophagitis, which is graded as a Los Angeles from grade A to grade D, then this is the effect of the GRD or the hiatus, and this is the indication, this can be an indication for offering a surgical procedure. For your information, according to the Lyon's guidelines, grade A again is taken as a normal, grade B, C and D are pathological, and if you have grade B and C and D, along with the Hill's type 3 and 4, perhaps you are justified in advising surgery for these patients. The another very important thing is the Barrett's. If the Barrett's patch exceeds more than 3 centimeters, and of course, by narrowband imaging, we have to see whether it is a high grade or the low grade dysplasia. I am not going into the details of this, but then this Barrett's is also one of the indication for going ahead with the surgery. So in nutshell, I can tell that if the patient has got typical symptoms of GRD in the form of a retrosternal burning, pain in chest and the regurgitations, if he has got Hill's type 3 and type 4, and if he has got Los Angeles B, C and D, and if he has got Barrett's more than 3 centimeters, these are the cases who qualify for surgical procedure. Now, the other investigations often, I perform high resolution manometry myself, and I have been referred many cases for doing the HRM, high resolution manometry. And the consultant will simply write that the patient has got a hiatus hernia on endoscopy and do the manometry and the pH metry. Now, we must understand that what this high resolution manometry is, what information it is giving to you. the first thing is, it is the most sensitive and the most accurate in diagnosis of the hiatus hernia. But this virtue of manometry is not utilized in the clinical practice, because even if you diagnose a case of hiatus hernia on manometry, say 3 centimeters, we are not going to offer him surgery at all, because he doesn't have any other complications. So this virtue of manometry, that being most sensitive and most accurate in the diagnosis, is only useful for the research type of a practice and not for the clinical practice. So this is one of the very important thing that we must understand. So never send a patient for the diagnosis of a hiatus hernia for manometry. The second thing is the esophageal peristalsis. And this has certainly, manometry can give a lot of information because it's a dynamic study, and it can give you information whether the patient has got a good motility or there is some motility disorder. I'm going to dilate a little more on this in the next slides. The third thing is a TS-LER, the transient lower esophageal sphincter relaxation. This also I'm going to explain you in brief. And the last thing manometry gives you is the exact location of the LES, or the lower esophageal sphincter. This lower esophageal sphincter level, it can never be assessed by just endoscopy, because it's a hypothetical. If you do an endoscopy, we can never know where the LES starts and where it ends. It is only manometry that can tell you that where is the LES situated, which is required for doing an impedance pHmetry to locate your catheter of the impedance probe. This is the normal high resolution manometry. I will not go into much detail, but the bands that you see and the colors that you see, they speak of the pressures, and the transverse bands, the upper is the upper sphincter, the lower is the lower sphincter, and then you see the bolus going down. Now this is the hiatus hernia. On the left hand side, you see that the crux of the diaphragm and the LEM, or the lower esophageal sphincter, they are in relation to each other, so there is no hiatus. In the next slide, in the next picture, you see that there is a difference, so we can know that this is the hiatus hernia. But this virtue of manometry is not used in clinical practice for the diagnosis of the hiatus hernia. The influence of the HRM on the choice of the surgical procedures. Certainly it is important because it gives you the ineffective esophageal peristalsis, and many surgeons feel that if the motility disorder is there, then they should not do a 360-degree or the Nissen's fundoplication, rather they should do a partial so that the dysphagia is less. This point has to be little understood in a better way, and here I like to draw your attention to the normal swallowing act to understand this ineffective esophageal mobility. The normal swallow, the 70% of the force of the swallow is given by the skeletal muscles. So that when we swallow, the pharyngeal and the constrictor, they push the bolus into the esophagus. The longitudinal, at the same time, the lower esophageal sphincter, it automatically and instantly relaxes. So there is a negative pressure down, there is a positive pressure up. The longitudinal muscles of the esophagus, they contract, so that the taxiing of the food bolus is less, the distance to be traveled by the food bolus is less. The viscosity of the bolus, the fluidity, the density, the posture of the patient at which he is taking this, because gravity also takes a part in the swallowing mechanism. So all these factors, they act for the swallowing. And the last thing is the circular muscles which contract the esophagus, and we say that it's a peristaltic wave. So what we say that the if ineffective esophageal peristalsis, it is one of the factor which contributes to the swallowing. And that is why IM can be diagnosed on the HRM, but ineffective esophageal mobility is observed in 10 to 15% of the normal individuals. The bolus clearance is important and not the IEM that is seen on the HRM. And that is why the threshold of IEM has been revised to 70% in Chicago 4 classification. In Chicago 3 earlier, just 2 years back, the 50% of the bolus, if they are ineffective, it was said to be a failed peristalsis. But now the threshold has raised to 70%, so that even if the patient has got 70% of the failed or the ineffective peristalsis, we can go ahead with a 360 degree of a wrap. The another highlights of the Chicago 4 are, which are very important to understand, is the inclusion of the positional or the postural change. In what position we are, many often the HRM is done in the supine position. Just simply put the patient in the sit-up position and your values will change. And then there are two tests that have been added. These are the provocative tests, and one is the multiple rapid swallows, and second is the RDC. What happens is that after the operation, the patient comes back with the dysphagia. We always blame that the RAP is wrong or the patient has got a motility disorder. We never feel that this could be even a case of an achalasia cardia. So to avoid these fallacies, there are these two tests are very important, and we should always insist your manometrist to report or to say on these two tests in his report. The one is the multiple rapid swallows. On the right hand side, you see the normal swallow, and on the other side, you see that patient has been given multiple quick swallows, and you find that there is an accentuation of the peristaltic wave, and absence of this phenomena after MRS is an indicator of possibility of post-operative dysphagia for the anti-reflux surgery. So if this MRS is absent, if it is present, we can go ahead with the 360-degree wrap. If it is absent, certainly you should avoid doing a 360 wrap and can do a partial toupee. The another thing is very early achalasia can be easily missed on the normal high resolution manometry. It can also never be diagnosed on the endoscopy. So this rapid drink challenge is very important. And we give this patient about 200 ml of clear water to drink and just see the early achalasias. They will be seen very clearly after this RDC. So the MRS and the RDC, these are the two important tests. They should be done before we put this patient for the surgery. A preoperative esophageal motility does not influence a postoperative dysphagia, and there are many articles in the literature about this. But these two tests are the main background behind all this. This transient lower esophageal relaxation is a phenomena, is seen in many normal individuals. And here what happens is that even though there is no swallow, there is intermittent relaxation of the lower esophageal sphincter, which allows regurgitation of the acid. So even if patient doesn't have any other problems of the GI motility, or the patient doesn't have any dysphagia or anything, the patient still, they can have a GRD related problems because of this TS-LER, and this phenomena can be observed during manometry. Only thing is that the manometrist has to give about 3 to 4 minutes to see these patients in the basal state. The imaging becomes important not for type 1 of a hiatus hernia, but type 2, 3, and 4, whether when the other structures are also herniating in the chest, and it is mostly because of the mechanical compression, the imaging has to be done. The role of impedance pH-metry is mostly for the reflux. It is for the reflux disease and not for the hiatus hernia. So it doesn't contribute any significance for hiatus. But if you are investigating the cases of atypical GRD symptoms or the patients who are refractory or some other reasons, then the impedance pH-metry becomes necessary. This is a totally different subject, and this is not the type of discussion today. In conclusions, the diagnostic OGDscopy is a gold standard, though it is not very accurate. HRM is for the selection of the operative procedures. Imaging is necessary for the type 2, 3, and 4 of the hiatus hernia. I request all of you to please join us at Indore for HSICon. It is going to be a very good event. It is apart from the academics, there are so many cultural games and many other things have been planned. So I request all of you to come there. Thank you very much.
So thank you, sir. I think sir has got a special interest in hiatus hernia, and very few people in our country have in-depth knowledge of the medical side of GERD and hiatus hernia as much as him. So we keep on learning. We had a single theme workshop at his place, and it was absolutely amazing. And I was personally there, so I can vouch for it. If there are any questions from the house, we can take it. All right. So, sir, thank you very much. And just to reiterate what sir said, in Indore HSI Con, it's not only about academic event. There is also cricket to be played. There is a fashion show. If you have a body to flaunt like Dr. Atri, please come wearing your t-shirts for the fashion show. And if you are in, watch out for some dancing and musical event. Also, please come in. And there is also a day forest trip. So plenty of things in HSI Con Indore. It's just not a conference. It's more than a conference. This is where we make friends for life. Mushtaq bhai, your mic is not working.
We are honored to have you along with the whole HSI. On behalf of my HOD and the Department of Surgery, we are thankful to you for honoring us with this event, making it a success. Thank you very much.
Thank you. May I call upon Dr. Arshad Rashid from GMC Srinagar and to talk about a very difficult topic, I must say, which is optimization in loss of domain hernia. So, Dr. Arshad Rashid, I will be listening to you intently.
I know, sir, you will be. Thank you so much.
Before Dr. Arshad starts, I would like to say he is an all-rounder. He doesn't only play with the tissues, he also plays with bat and ball, he plays with football, he plays with badminton. I don't know what.
He should come to HSI Con.
Real all-rounder.
Yes, he's all over. Okay. At the outset, I would like to thank you all for coming here and making this summit a success. And I have been interested in a very important topic. And listening to the morning talk of peritoneal flap, I must say some things need to be changed and some things need to be kept there. And we have to see what we can do best for the patient. And I have been interested with the talk of optimization of loss of domain ventral hernia. So what is actually this loss of domain? If we see this one, I guess I'm online, yeah. So, Ghalib said, शोरीदगी के हाथ से है सर वबाल दोष, सहरा में है खुदा कोई दीवार भी नहीं. Well, it's a matter of speculation as to what domains Ghalib was lost in, but this staggered image will get clearer as we will be discussing loss of domain. So, what actually it is? There was a Delphi consensus of experts that defined loss of domain. Well, it's simply a large ventral hernia, a ventral hernia that is so large that it cannot reduce it, that you cannot repose it properly without doing some additional things to the abdominal wall or without any significant risk of intra-abdominal compartment if you do it like that only. And there have been two of the models that have come up on radiological terms, the Sabag index and the Tanaka index, that we frequently refer to. But if we have to sail comfortably through the ocean of loss of domain, we need to use a boat of optimization, a boat of preparation. The surgeon needs to be prepared, the patient needs to be prepared, and the hernia needs to be prepared for the optimization. So how do we prepare the surgeon? The surgeon seems to be prepared from the start, because once he gets the degree, he's started to operate and he's well prepared. So if we have to have the success with us, we have to review the old charts judiciously. Whatever has been done previously, we have to have a thorough physical examination and we have to review the imaging. We have to revisit the radiology suites. We have to be with our radiology friends, looking and re-looking at the CT scans, which has been said since morning. In old charts, we have to pay special details to the type of suture that has been used previously in the surgery, or to the mesh type, the fixation devices, the fixation planes, or any prior components separation that has been used. Again, in physical examination, we have to see the laxity of the abdominal wall, the skin, the scars, what's the context of the skin, and are there any stomas, are there any ulcers there, and is the hernia reducible? And we have to palpate specifically the edges of the rectus abdominis. Again, in imaging, we have to see the quality of the wall. I guess we have to do all these three things in congruence. And that sets the tone for the surgery. Once the surgeon is ready, he will make the patient ready. Now, how do you get the patient ready? There are pointers to it. How do you optimize the patient? First thing is, and first is the foremost thing, that the patient, we have to tell that guy or that woman that you have to stop smoking. At least he has to be tobacco free 1 month prior to the surgery and 2 months after the surgery. Then obviously obesity is a known risk factor for recurrences. If the BMI is more than 35, we have to offer a bariatric program or a weight loss program to the patient, and we need to cut down on the weight. Third thing is diabetes. The target HbA1c in these patients is 7 to 8. Again, cirrhosis, because many of the patients may come with end-stage liver disease. A target MELD is less than 10. Maybe we may need a bridging tips for it or a paracentesis of the ascites. Then, nutritionally, we have to ensure that the patient is optimized. The albumin has to be more than 3.5. We should encourage the patients beforehand to go for an exercise program. And we should encourage them to at least go for an exercise for 30 minutes a day, a walk, a cardiac conditioning, deep breathing exercises, chest physiotherapy, so that their things are optimized. And last thing I have put in here is the age. Can age be optimized? Obviously not. But I have put it here because the studies have shown age less than 60 favors good outcomes, and age more than 60 does not favor a good outcome with this patients. And now, how to optimize the hernia? We have optimized the doctor, we have optimized the surgeon. He has been primed to brace up with the challenge. The patient has been sufficiently optimized. Now, if we have to win this game, we need to have everything on our side once we optimize the hernia. And to optimize the hernia, we need to have some botulinum toxin or the progressive pneumoperitoneums that we use preoperatively for hernia optimization. I'll be talking about these two precisely, what to do and what not to do. So, this is a short journal that I have written on hernia optimization, starting with botulinum toxin A. What is it? It is a neurotoxin which prevents acetylcholine release, causes flaccid paralysis of the muscles. The onset is usually at 2 to 3 days, and the peak of the onset is in 4 to 6 weeks, and the total duration of action remains for 5 to 6 months. We can use 3 or 5 sites, 3 or 2 planes, variously mentioned in literature. Our experience is mostly 3 sites and 3 planes on each side, and usually it's well tolerated, but there are side effects. Cough, sneezing, hypersensitivity are the issues, and there may be occasionally abdominal distension in these patients. So what are the anatomical perspectives? We have to concentrate here. This is the lateral abdominal wall on an ultrasound. You see, these are these white lines, the hyperechoic things. They are the perimycial fibers. So this is the external oblique. This is the external oblique, the external oblique, intra-oblique, and the transversus abdominis muscle. We use 3 points on each side as devised by Smoot et al. So these are our patients. This is the procedural video of our patient. We use an ultrasound guiding. You can see the muscles getting splayed up. We are using Botox, injecting it by the use of an ultrasound. Usually we use 200 units here, sir, and literature mentions 200 to 300 units, but we are confident and comfortable with 200 units only. So pre and post BTA, what happens? This is very important. In morning, though, Sarfaraz showed an interesting CT scan where the lateral muscles were absolutely lost. There was nothing left. And obviously, you cannot have anything of this in that thing. So here you see these muscles. They are initially contracted, retracted, and thickened. So what's your aim? Your aim is to bridge this gap. So the idea is to get these muscles coming forwards. And botulinum toxin is one of the options. They get relaxed, elongated, and thinned out. So is there an evidence for this? There has been a systemic review which was published actually quite late. It was in 2021 this was published, and they showed on each side the gain of around 3.3 to 3.4 centimeters with use of botulinum toxin. So what about preoperative progressive pneumo? It's a very old concept. It was used initially in 1940s. I was actually surprised to hear that. And it was initially used for strangled hernias where they tried to push it in, the irreducible hernias where they tried to push it in by Goni Moreno. Peritoneal dialysis catheters have been used. We at our place use central venous catheters under ultrasonic guidance. Air can be used. Carbon dioxide has been used. Nitrous oxide has been used. We prefer air because it's obviously available everywhere. And daily, we use a daily protocol for 2 weeks. And 500 to 1000 ml is insufflated or whatever is maximal tolerated, because the patient sometimes may develop pain once we are insufflating it. It increases the abdominal cavity volume. Though caveats have been placed to it that it increases the hernia sac volume, but again that is beneficial because it eventually stretches the peritoneum and the peritoneal flap increases. And it also causes pneumatic adhesiolysis, improves diaphragmatic functions, and studies have shown that in long-standing hernias, it may reduce the mesenteric edema. But remember one thing, all these patients, whenever they are with you, they are admitted with us for 2 weeks prior to surgery. We do daily pre-op progressive pneumo, and these have to be put on venous thromboembolic prophylaxis. So this is one of the videos of our, this is in the ward. We have used the central venous line WMIN. Then we use a 3-way cannula and a 50 ml syringe to push in air. So this is the lovely group of people with whom I have the privilege of working here. And we have quite an early experience with the use of botulinum toxin and PPP. We usually do BTA 5 weeks prior to surgery, and we have had 11 patients in whom we have done it. The unilateral length gained has been 3.4 centimeters. We usually do botulinum alone if the Tanaka is more than 25, but again, it's not fixed. It's a matter of seeing the patient and feeling the patient and having a look at the patient. And then PPP is added if the Tanaka is more than 35. PPP we usually do at 2 weeks prior to surgery, and finally we do the surgery 5 weeks post botulinum toxin. This is one of our patients. You can see the hernia. She came to us. She had initially gone for an IPOM plus, had a huge recurrence. You can see the hernia. This is a CT scan. Her Tanaka was 37. And this is her transverse cuts of the CT. So this patient underwent Botox. Here is the patient before and after. You can see we have managed, I think, quite a good result for it. These are 2 other of our patients. These are the before and after pictures in which we have used the pre-operative progressive pneumoperitoneum. But here I would just like to say my key takeaways from this talk are that LOD hernias are definitely challenging, but patience is the key. Optimization is necessary. There are no clear-cut guidelines on BTA plus minus PPP, when to use, when not to use. RCTs are needed, but again, RCTs are difficult to conduct because they are a very small subset of patients. At the end of the day, I would just like to say one thing. A hernia repair cannot be idealized. It needs to be individualized for each of the patients. Thank you.
Dr. Arshad, I must congratulate you. You are doing a great job here.
Thank you, sir.
And you have a fantastic understanding about the subject. So, of course, I would like to open it for the House first before having some comments from this side.
Before that, I would like to congratulate Professor Jalku, Dr. Hamid, and Dr. Arshad. They are basically the backbone of all the scientific content that has been. A big round of applause for them. They have really worked hard for this conference, and they need to be given that stature that they have worked. And of course, Arshad and Hamid, I told you they're the 2 best hernia surgeons we have presently.
Yeah.
I would just add a point. It's an excellent talk. You have given the insight of this complex issue, which is probably very new for many of us. But we are all getting into this, and this makes mandatory for all of us to get into a radiology training about AWR concept of the radiology. One. Second is we should also understand there are many other indices which have come up. One of them is, as you rightly said, Sabat, Tanaka. Third is the component separation index. So when we started this subject in our unit, so what happened that we went to radiology. They said, what is all this? We don't know. We said, we should first teach them to then get bad feedback because the subject is very new. Dr. Sarfraz must be aware that many of people don't venture to look at such patients. And so we had to teach them to get taught. So that is my point, is that it's very important. Dr. Arshid has excellently given it a grasp that, and it is not easy to understand this anatomy. AWR is a newer concept. That's why the hernia has gone to a different dimension. It's a newer horizon. We call it abdominal wall reconstruction. So radiology becomes important as anatomy. So it is important for all of us to revise and relearn the abdominal wall anatomy on radiology. So 6 weeks training, I think, would be enough for all of us to get back to understand and the nuances of the repair. Thank you very much.
Thank you.
Dr.
Arshad Sahab,
Thank you so much. I think that's the reason he is called as essay node of the department. Right. So all activity starts with him. And as our HOD has put it, Professor Chalku and Dr. Arshad, Dr. Rajan, Dr. Arshad, they have all come together and you see drafted this whole scientific program which you are witnessing here.
Thank you, sir.
Thank you.
Thank you.
So I must add only one thing for your loss of domain. In our own experience, we've realized that many of these cases, we will have to say, no, we can't do it. That's one. And two is, many of these patients will have a staged procedure despite all optimization, which would mean I go in, I resect the bowel and the omentum, I do abdominal wall closure, come back later to put in a mesh. So this is something that I would share with you based on our experience, that this is something that you can consider in situations where it's inevitable that nothing is going in and you've already taken the challenge.
Thank you, sir. Thank you.
Thank you.
Thank you, Dr. Arshid. Now we come to the last speaker of this session, that is Dr. Tarun Mittal. He is talking about redo fundoplication.
Good afternoon, everybody. At the onset, I would like to thank Dr. Iqbal, Dr. Atri, and his whole team for inviting me for this. My topic is redo fundoplication tips and trick. I bring greetings from Sir Gangaram Hospital. From patient's perspective of failure to provide a durable symptom control or occurrence of an undesirable symptom is considered a failure. Approximately, we will have radiological recurrence in tune of 50%. But out of those, only 3 to 6% patients require revision, either because of severe symptoms or because of mechanical wrap complications, which will require a redo surgery. So there are 3 factors which are reason for failure. Either it can be a patient factor, or it can be tension, or it can be technical factor. Patient factor can be like patient is a morbid obese patient, and one of the most important thing which is there is one has to control the nausea, post-operatively retching, coughing. If these are not done, or heavy lifting, the patient can have whole of the wrap can migrate into the thorax because of increased intra-abdominal pressure. One should avoid the use of nasogastric tube. One should avoid the use of opioids because they can create issue of nausea and vomiting. We can pre-medicate this patient with steroids and antiemetics to reduce the vomiting incidences. So this is one of the most important factor. There is an axial tension is there, which is parallel to the esophagus, causing cephalad migration of the GE junction. Normal physiologically, there is approximately 2.5 centimeter migration. It happens because of elastic recoil of nasovascular membrane. But if patient has chronic esophagitis or has a large hiatus, can have a short esophagus. So this will be the factor for axial tension and can result in wrap migration. The other factor would be a radial tension, which is because we are at the continuous stress because of the continuous respiratory movements and the diaphragm moves, and this can also be the reasons for the crura repair giving way and causing the wrap migration. So other can be technical factor. If you have a misplaced wrap, incomplete hiatal dissection, misidentification of G junctions, whether you have divided the short gastrics, and most importantly, how trained is a surgeon, how well trained is his team, and how gel as a unit they are. If there is not adequate training, this can be one of the most important factor for complications post fundoplication. So this is the types of failure. After that, I will be showing you 3 videos which I have operated. This is classified as type 1A, in which the G junction and the fundoplication both has migrated above the hiatus. It is both because of increased radial and axial tension, and it is the most common redo fundoplication which will be required, and most common type of a recurrence. The second is a type 1B slip fundoplication, in which the G junction is above the hiatus, above the diaphragm, and the fundoplication is below the diaphragm. So this is because of you have misjudged the location of G junction and placed the wrap below the cardia instead of ficus, and also because of increased axial tension. The type 2 is the paraesophageal hernia, in which G junction and the wrap is below, but you have a paraesophageal hernia which is there. And type 3 is when you have utilized the body of the stomach for fundoplication instead of the fundus. So you have to tailor based on the what was the reason for failure, how much is the esophageal length, what is the peristaltic reserve. You would have to do a partial if there is no reserve. What is the status of esophagitis, Barrett's esophagus, and what is concomitant gastric pathology. So I will just show you the first video. This is my first video. In this patient had undergone a fundoplication 2 months back at some other center, and then just wait, don't play. So this patient had undergone fundoplication at 2 months back at some center. Post-operatively, patient had nausea, vomiting, and was given some medication. And after that, patient started having dysphagia and abdominal pain. And then he was investigated by CT scan, endoscopy, and was found that whole of the wrap has migrated into the thorax, and this patient is having symptoms because of that. So I'll just show you the CT scan. Thank you. So this whole of the wrap has migrated. We got the endoscopy done, which showed a volvulus. Always manometry is required in all these patients to see that the how much is the peristaltic result. This patient had a normal manometry. So here we can see whole of the wrap has migrated into the mediastinum. Whole of the stomach is above, and lot of momentum is there. So by slow and steadily, we were able to reduce this stomach with the help of non-traumatic bowel forceps by traction and pull, and with reduction of momentum. We should be very careful that we do not injure the stomach at this point of time. Now you would see this whole of paraesophageal hernia with sac is there, and the wrap is above the G junction and in the mediastinum. So with the help of the energy source, we started dissecting the sac, started mobilizing the crura, first the left crura, then the right crura. These are the typical steps which are there, so that you dissect the sac. So by slowly and steadily, we were able to dissect this area from the left crura area. Then we went into the right crura, and you would see that we are not able to see the esophagus till now, because whole of the wrap is causing this. We are not able to see the esophagus because of the wrap. So now we were now started seeing the right crura, and now there were a lot of adhesions which were there with the wrap and the pleura, and in both sides the pleura got opened. You will see here just now that when we are dissecting this wrap which is there above, we had to, this is, see, you can see the lung here. So this was densely adhered. So that is not a problem if you injure this pleura also. If it is small injury, you do not require anything. Main thing is you should not injure the lungs. So as you would see, you can see the sutures which have been taken previously of the previous wrap, and this whole of the wrap is above the in the mediastinum. By slowly we have mobilized the right crura, we have mobilized the left crura. Now we are mobilizing anteriorly, and we can see whole of this wrap is above and dissecting this wrap. Now after this, we could see these sutures. We have to unwrap the fundoplication always, so that we know what is the exact anatomy is there. Always undo the wrap and then do the new fundoplication has to be done. So this, after this sutures have been taken, there were some adhesions posteriorly between the esophagus and the wrap that are being divided, and between the tip of the wrap and the esophagus. This hole is being dissected, and whole of this wrap is being put into the intra-abdominal area. So here you would see this is the left lung, which was also pleura was injured. We could see this whole of the lung. So we thought that we should place a rise tube because it was a big rent in the peritoneum. So bilateral chest tube was placed. Now you would see that whole of our wrap has come down and our esophagus is well mobilized, and our anatomy is clear. You can always sometime do an intraoperative endoscopy in these patients to identify the G junction if you feel that there is a problem in identification of anatomy. Now we have started using a braided suture for closure of these hiatus. Because of its being a very large hiatus, we placed a mesh also by the normal 3-layered mesh, so that we do not have a lot of adhesion. Proline should not be placed, and we placed the mesh and it was fine and patient is doing well. So this is the second video which I will be playing. This patient had post-operative dysphagia right after the surgery. It was operated in some other center. They did a balloon dilatation also in this patient, and it was not successful. Patient lost approximately I think 7-8 kgs in 6 weeks, and patient came to us, and then we did the CT scan of this patient. Video देखना. Yeah. So you would see when we got the CT scan done, we also got the 3-dimensional image also. So there was narrowing at the level of the fundoplication. So it was a tight wrap had been created. The other thing can be a tight hiatus closure also, but according to them, it was a tight wrap, which was the reason. So we did not had any other option to do a redo fundoplication. So there were a lot of adhesions between the liver, but somehow we were able, you can see previous suture, we were able to mobilize a tunnel between the fundoplication, and we could divide this fundoplication. There are a lot of techniques of dividing. You can use a sharp scissor, or you can use a stapler also to divide this fundoplication. So after this fundoplication, we have to undo whole of the fundoplication. So here we are dividing all the adhesion between the esophagus and the fundoplication. Left crura had been mobilized, but could be seen, but right was not. So we are dissecting this area, and we could mobilize the right crura also, and we could create a tunnel also. And here we can see the sutures which have been taken between the crura and the fundoplication, which are taken to prevent the wrap migration. So which slowly, with blunt dissection and sharp dissection, we were able to create a window here, and our whole of the anatomy was well defined. This is the wrap of the right sided, which is adhered to the esophagus. There was some, I felt that this area was not looking healthy. So I divided this also with the failure. So we had well-defined anatomy, G junction, fundoplication was unwrapped, and we did an intraoperative endoscopy to see if it's not a tight hiatus closure, which can also be the reason. So it was very easily passing. So we were comfortable, and patient has now gained approximately 7-8 kgs of his lost weight and is doing very well. The third video is of a patient who had undergone a fundoplication at some periphery center, not in NCR region. Patient had post-operative dysphagia, and when we got the manometry done of this patient, patient had an absent peristalsis. So in that center, they had not done a manometry before doing a surgery, and because of which patient was having dysphagia. Also, when we got the CT scan done, the wrap was above the hiatus, and which we had to undo, and which we did in this patient. So here, this is a little bit older video, 4.5 years back. So after this, all these steps are almost same. After the azizolysis, you have to mobilize the right crura and left crura. Here we are dividing the short gastrics and mobilizing the left crura. In this, you will see that whole of the fundoplication has disrupted and was into the thorax. So here you can see this fundoplication, and we are mobilizing the left crura here. So you should be very gentle. You should be very patient when you are doing these complex surgery, because your one step can create a complication which will be very devastating for the patient, like a esophageal injury or an aortic injury. So we have mobilized this left crura. Now we are mobilizing this right crura. With the help, I feel that ligashore is a very good instrument for dissecting also. You do not require frequent change of instruments. So here we are mobilizing this right crura, and now you will see the fundoplication which is disrupted, and you will see some sutures which were there, which were just there at the level of crura and some esophagus, but fundoplication was disrupted. So here, these are the sutures you can see at the level of the crura. So now we have created that retroesophageal window, and now we are dissecting into the mediastinum to mobilize the intrathoracic esophagus, and we require at least 2 to 3. So here you can see this whole of this fundoplication has disrupted, and there was no sutures at the level of the esophagus which we had to divide. So, and these are the sutures which were there at the level of the hiatus only. So we are done. Some right crura mobilization was pending. So we are doing this. After this, we close the suture hiatus and did the mesh fundoplication. So these are the steps. The most important thing is you have to take the you have to identify the vagus nerves after the hiatal dissection, and you should take down the previous fundoplication, because if you are not taking down the previous fundoplication, your anatomy will not be clear, and you might require a intraoperative endoscopy and assessment of esophageal length. If it is very short, you might have to do a Colles gastroplasty. Thank you. It's a teamwork. Thank you.
Thank you, sir, for a wonderful talk. Any questions? Since this session is concluding now, we have a request from Dr. Sarfraz Jalil. He has a flight in the afternoon, so he wants to prepone his lecture. I request all of you to stay back. I know this is odd time because lunch is coming, but I just request you for 10 minutes more. Because Dr. Sarfraz has a flight. He has to.
Oh, Tarun, excellent videos, by the way. It was fantastic. Thank you, sir.
His talk is on ventral hernia repair in India, Delphi Consensus.
Yeah, sorry about preponing it, but I have a flight to catch and I may get late. So, yeah. So I bring greetings from Digestive Surgery Clinic, my hospital in Kolkata. So I'll be talking about the ventral hernia repair in India. This is a Delphi consensus, and I will go about this because I think a lot of us now are talking about how do we choose procedures for ventral hernia. And when it comes to minimal access, we see so many kinds of procedures. Rather than getting clarity, we are getting confused. So that is the idea about doing this, what procedure to use. And this was funded by Medtronic, so you can factor that in while taking my lecture. I can just say that you don't judge this entire decision making and the outcomes of it based on this slide, but it's my duty to let you know. The methodology of this Delphi consensus like this. We recognize experts in the country who do enough minimal access repair of ventral hernia, and we send out to them. Those who agree, they become experts. And how do we choose experts? We choose them based on their volume of work, the publications, the positions they occupy in a society. And the questions were framed by searching the literature and seeing what questions are relevant to be asked. And then we make the first round. None of the experts know each other. So it's anonymized, and their response is coming only to us. So they can't influence each other, right? Instead of a meeting like this, it's all anonymized. And when we see more than 75% consensus on a particular topic, we say, yes, this is agreed by most of the people. Also, we find that some of these questions do not reach consensus as is expected. Then we make second round of questions to do so. And then we have a consensus process. So more than 75% was consensus, and low consensus, if it is less than 60%, that's not a consensus. So these are the names that I would like to spell out so that you realize that this was a very important document for our country. Dr. Pradeep Chaube, Dr. Randeep Badhavan, Deepak Subramaniam, Dr. Deepraj Bhandarkar, Jignesh Gandhi, Lakshmi Kona Kumari, Manish Baijal, Mukund Khetan, Kathalguri, Dr. Pankaj Khandelwal, Pavindra Lal, Pinag Dasgupta, P. Balachandran, Sandeep Dave, myself, and Vandana Soni. So we had a lot of people on this who had good amount of exposure with minimal access. And we wanted consensus on what are the options which are acceptable, to which is the preferred procedure for primary midline hernia, then which is the procedure preferred for midline incisional hernia, lateral incisional hernia, and then what is the consensus on the pain, injuries, additions, Seromas after extraperitoneal repair versus intraperitoneal repair. And then what are the factors on affecting decision making? You can recognize that we have kept primary hernia and incisional hernia differently. Why? Because primary hernia is a different disease than incisional hernia, and that's very important to recognize. So what about the first thing? What are the MAS procedures which are acceptable? So IPOM plus, TARM, Etep, MyLoss, TAPP, TAPE, SCOLA, LIRA, all are valid options. And apart from, I think, just one procedure, you saw everything yesterday. So what are the options and where are you going to use them in MAS? Are you going to use them for all big hernias? No. Up till about 8 centimeters. Now, this is not a Lakshman Rekha. It's not something which is, absolute, but just an approximate guesswork. Till about 8 centimeters width, you could use these options. What about primary ventral hernia? Now, everything works in primary ventral hernia. Umbilical hernia, epigastric hernia. You do open surgery, it works. You do laparoscopy, endoscopy, everything works. What did the consensus say? It said that if you had a small, less than 4 centimeters primary umbilical hernia without diastasis, intraperitoneal repair like an IPOM plus is the preferred MAS procedure. So now we are getting somewhere where there is so much of noise about extraperitoneal repair, but the consensus was in favor of the intraperitoneal repair. There was 79% expert agreement. Whereas when it came to umbilical hernia with diastasis, which was still a moderate diastasis, not a severe diastasis, where you can have plastic surgeons talking about open surgery, there the consensus was not there. So we did not know whether we should do intraperitoneal or extraperitoneal repair. So I think there is still fluidity in that area. It's a gray area. What about epigastric hernia? Again, more than 70% agreed that IPOM plus is the preferred modality if you are doing an MAS procedure. What about incisional hernia if it is in the midline? Then, in the incisional hernia for an M5 extraperitoneal repair, for a subxiphoid, there was no consensus. We were divided between intraperitoneal and extraperitoneal repairs. Whereas if it's a midline incision and it's just one single midline incision and you have an incisional hernia, then intraperitoneal repair was preferred. So this was the agreement, and it was a high agreement, 79%. Whereas if again the incisional hernia was a smaller hernia, this agreement went up to 93%. So if it is an incisional hernia and if it is small, more people agreed on IPOM plus. Wherever it was getting bigger and bigger, then the agreement reduced, but it was still in favor of IPOM plus. What about less than 8 centimeters of multiple defects? Okay, where you would say, okay, I could do a Etep RS and you can prevent the herniation of the entire thing. You can just with one shot cover everything. Again, the agreement fell down. So it is showing a shift of our opinions. When you make it into smaller incisional hernias, IPOM plus. And as soon as you add complications like multiplicity, bigger diameters, then people are divided and there is a little bit of a favor of extraperitoneal, but still majority feel it's the IPOM plus. What about lateral hernias? Now this is where it gets very interesting. If it is a subcostal repair and you want to go do minimal access, the preferred repair was extraperitoneal. So here we are seeing now changes from what we learned in the past, but this is in sync with EHS guidelines also. If there is an atypical location like close to the iliac bone, close to the costal margin, any bony landmarks, there the extraperitoneal repair is superior to the intraperitoneal repairs. What about right iliac fossa, left iliac fossa hernia? Again, extraperitoneal repair. So doing a TARM, a TAPP approach or Etep approach is more in sync with what the consensus is saying. So the experts are agreeing on that. What about complications? So what have we got till now? We have got that intraperitoneal repairs and extraperitoneal repairs are accepted. Less than 8, better. For midline, largely we see intraperitoneal repairs, IPOMs are scoring more. For lateral hernias, we are seeing extraperitoneal repairs are scoring more. And there was an opinion, a floating opinion, usually in the social media, that the pain is higher with IPOM plus, the pains go down with extraperitoneal repairs. There's more adhesions with intraperitoneal repairs. So we wanted to put that to test with the experts and the high volume centers with their experience. Bowel injuries, do they occur more in intraperitoneal repairs compared to extraperitoneal? There was a 77% agreement that the injuries would be identical whether you do extraperitoneal or intraperitoneal, because after all, even in so-called extraperitoneal repairs, you are going intraperitoneally to do the adhesiolisis. In terms of neurovascular injuries, there would be more in extraperitoneal repairs. So that's common sense, and people agreed, 100% agreement that there would be more neurovascular injuries in extraperitoneal repairs like Etep, TAM, and TAPPs. What about pain? This is interesting. We had to rephrase this to get a consensus. This was divided opinion initially. When we made the statement that if you were doing IPOM plus with a TAP block, and you compared it with ETAPs or TAMs, which one would be more painful? And people said 77% said, then it becomes identical. So if you do IPOM plus without the TAP block, it's probably painful in the short term. But if you add TAP block, it's going to be identically same as far as pain scores are concerned in the short term. What about hematomas and vascular injuries? Again, more common in extraperitoneal repairs compared to intraperitoneal repairs. So that's again common sense, but it had to come out. What about adhesions? There's so much of literature coming about coated mesh having adhesions. 92% agreed that there are adhesions with coated meshes as used in IPOM and IPOM plus, but they are largely clinically insignificant. So that is what the consensus came up with. So that was the meat of the matter. And the final point was, what should you consider in choosing the procedure? And people said, mainly hernia width, hernia location, and the BMI of the patient. That is what everybody agreed on. And this, therefore, is the algorithm that we got as a summary from this study of Delphi consensus made with exporting experts from the country. And in general, I would again just summarize it for you. There are many options, IPOM plus, Etep, TAM, TAPP. For midline hernia, seems to be that IPOM plus is still favored. Seems to us that lateral hernias, the extraperitoneal repairs are more favored, and people are moving in that direction. And it also looks to us that as far as complications are concerned, if you use IPOM plus with the TAP block, the pain scores are identical in short term. Long term, of course, is going to be identical. And the neurovascular injuries and hematomas are going to be commoner in extraperitoneal repairs. So that was what was found in this Delphi study. I hope this helps you. It did help all of us in having a direction in this very important and confusing area in our country at the moment, and probably globally also. So I think congratulations to all the experts who made this happen. Congratulations to and kudos to the company and industry which came out to fund this. And of course, the writing of the paper, and ultimately it got accepted in the most impactful journal, that's Hernia, and it was published in May 2024. So thank you very much for this opportunity, sirs.
Thank you, sir. Thank you so much. A big round of applause for sir. He has been instrumental in organizing this event. Basically, he is the chief organizing chairman and head. So I appreciate your organizational activities as a Secretary Hernia Society of India, and we feel very proud to be associated with such a body, a national body, which gave us this opportunity to organize this event here. Thank you, and for this crystal clear concepts and making our youngsters who have to start their hernia journey. I think these instructions will be very, very important for them to follow. Thank you again. Thank you so much. We feel please forgive us for any lacunas we have in this event, and I hope you will ignore them.
Now you're outdoing yourself, Dr. Atri. It has been a brilliant 2 days that we've had here. I must say that this has been the finest meeting that I have attended in this year. And congratulations and kudos to the entire Government Medical College Srinagar, Dr. Atri, Dr. Iqbal, Dr. Chaku, and Dr. Hamid. And I've met so many of you here. And I was impressed so much by the quality of work that's being done here. I'm so happy that our president has conferred an honorary center of excellence from Hernia Society of India to this institute. It's an honor
Thank you.
to us to be associated with you all. I come only with this plea that please become member of Hernia Society of India. It's like a family. We want to expand this family, and do come to HSICon in September 26 to 28 at Indore so that we can cement this relationship with you all. Thank you very much.
Thank you so much, sir. Thank you so much. Thank you so much, sir. Thank you so much.
Thank you so much, speakers and chairpersons of this session. We now conclude this session, and I'd like to invite Professor Shakil Ahmed Mir, sir, to kindly felicitate the speakers of this session. The first speaker of this session, Dr. Rajesh Kullar. Dr. Vijay Bargaonkar. Dr. Arshad Rashid. Dr. Tarun Mittal.
Thank you, Dr. Tarun, for accepting our invitation at, in such a short notice and making this your talk so wonderful. Thank you so much.
Dr. Sarfaraz Beg.
Yes.
Thank you so much. Thank you, Professor Shakil, sir. Now I'd like to invite President HSI, Dr. Vijay Bargaonkar, to kindly felicitate the chairpersons. Dr. Ganesh Shenoy. Professor Dr. Muzaffar Jan. Professor Dr. Manzoor Lattu. Professor Dr. M.R. Atri. Thank you so much, sir. We'll continue session number 5 after lunch. Thank you.
Over to you, chairpersons. I would congratulate Department of Surgery for having the excellent this workshop and scientific sessions regarding the Hernia Summit 2024. So I express my all thanks for giving me opportunity for sharing the session. So this is session 5, post-lunch session. So hope I request speakers to make it lively so that post-lunch sleep is gone. So may I request the first speaker, Dr. Talib Hussain, Department of Surgery, GMC Jammu. He will be talking about open posterior component separation with bilateral transverse abdominis release. Welcome, Doctor.
Very good afternoon to all of you. My sincere thanks to the organizers and HSI for giving this opportunity. I'm going to present a video on open posterior component separation with bilateral transverse abdominis muscle release. I think much has been said about the management of complex ventral hernia in terms of hybrid procedures for the treatment of LODH and for various bailout procedures including peritoneal flap, hernioplasty as described yesterday by Dr. Sarfraz sir. This is a 48 years old male presented with history of swelling in central and lower abdomen. He underwent exploratory laparotomy with omental pedicle closure of DO perforation 4 years back. Patient developed surgical site infection post-operatively that time. General physical examination is unremarkable. BMI is 27.7. He is ASA class 2. On clinical examination, there is a large reducible midline incisional hernia. Cuff impulse was present. There was a previous scar with thinning of the overlying skin. There was a single defect measuring 10 by 8 centimeters in size. As per EHS classification, it was M24W3R0. It was stage 2 as per ventral hernia staging system classification and grade 1 as per ventral hernia working group classification. NCCT abdomen was done, which showed a single large midline incisional hernia defect measuring 10 by 8 centimeters in size. Thickness of right rectus abdominis muscle was 1.2 centimeters and left was 1.3 centimeter. The rectus to defect ratio, that is the carbonyl index, it was 0.9. The Tanaka index was 0.1 and the Sabag index was 9.4%. So decision was taken to perform posterior component separation by open technique. Skin incision was made in such a way that the previous scar was incorporated. It was further deepened using electrocautery. Care was taken not to injure any underlying adhered bowel loops. All necessary dissolution is done. The bowel loops which are adhered to the underside of hernia sac and the parietal wall, they are separated. It's not necessary to perform the interlobe dissolution. It was the lever which was adhered to the undersurface of the parietal wall on the right side, which was taken down. The adhesions from the lower part of the wound. After that, laparotomy sponge was placed so as to protect the bowel from any injury. The posterior rectus sheath on the left side was identified at its medial border with the rectus abdominis muscle, and it was incised. The incision of posterior rectus sheath starts from above downwards. After incision of this posterior rectus sheath, it was dissected away from the rectus abdominis muscle. Utmost care should be taken to prevent any injury to rectus abdominis muscle and posterior rectus sheath as well, because any buttonhole, if at all develops, they have to be later on repaired with using absorbable sutures, or at least one has to put then the composite mesh. So here you can see the rectus abdominis muscle being separated away from the posterior rectus sheath, preventing injury to the neurovascular bundle. After that, the posterior lamina of internal oblique aponeurosis was incised so as to expose the underlying transversus abdominis muscle. This division begins around 0.5 to 1 centimeter medial to the this linea semilunaris, so as to prevent the injury to this neurovascular bundle. After that, the transversus abdominis muscle fibers, they are lifted on a Kelly's clamp or a right angle forceps, and then they are divided. And then the dissection of this transversus abdominis muscle from underlying fascia transversalis in upper part and then downwards. Then the retropubic area is dissected so as to expose the both corpus ligament. The few remaining fibers of transversus abdominis muscle being divided. The muscle fibers, they are swept away laterally from underlying fascia transversalis towards the psoas muscle. And then you can see the posterior rectus sheath has come closer to the midline for its later approximation. Bluntly, the muscle is being swept away. Then attention was paid towards the right side. The right posterior rectus sheath was incised all along its course. Then it was dissected away from the rectus abdominis muscle. Preventing injury to both of these structures. Muscle is being separated. Now this dissection area meets with the previously made dissection in the retropubic space of Ritzius. The middle and upper part of the posterior rectus sheath is now being divided. Right angle forceps can be used to lift the PRS and then can be divided. There is always a plane between rectus abdominis muscle and posterior rectus sheath until and unless it is violated previously, and it's the most suitable place to put in a mesh in retro-rectus sublay position as devised by Reeves-Topper, because this position of placing a mesh has got several advantages. The bone-related complications, they are very less, and the risk of hernia recurrence is also less in this position as compared to the other like onlay, inlay, intraperitoneal or preperitoneal. So this is the most ideal position to put in a mesh retromuscular sublay position. Here the muscle is being separated away from the posterior rectus sheath, preserving the neurovascular bundle. So last part of dissection inferiorly. Hemostasis has to be achieved so as to prevent the development of postoperatively hematoma and seroma. After that, the posterior lamina of internal oblique aponeurosis is divided in a top-down manner or a bottom-up manner. It's always good to start from top-down manner because the transversus abdominis muscle fibers in the superior part, they are well developed, they are wider, they can be easily lifted and divided. The muscle fibers, they are being divided. After that, bluntly, muscle is separated, it is dissected away from the underlying fascia transversalis. Gauze piece can be helpful in achieving this dissection, and it can also help as hemostasis. Transversus abdominis release, actually it's an extension of the Reeves-Topper repair. When one is not able to close the hernia defect in the midline, it was devised by Nowitzki et al. So it can help achieving about 20 centimeters of midline, this shifting of posterior rectus sheath, so that it can be closed nicely without tension, which is an important aspect in hernia surgery. So repair should be tensionless. So last part of dissection on the right side, inferiorly. This is the mobilized posterior rectus sheath as well as fascia transversalis on the right side. Then both the posterior rectus sheath are now being closed in the midline using long-term absorbable suture. You can see they are approximated to each other without any tension. Sponge has been placed underneath to prevent any injury to the bowel by any needle prick. So it was a tension-free closure of posterior rectus sheath in the midline. After closure of posterior rectus sheath, it should look like a zip manner, that it should be very lax without any tension. This is the final stitch being applied to the upper end of posterior rectus sheath closure. After that, some subcutaneous dissection was performed so as to bring anterior rectus sheath in the midline. Just a few seconds. After this, a large piece of polypropylene mesh was placed over the closed posterior rectus sheath, and it was fixed. It was fixed with at least it should be fixed with the corpus ligament below. Other point of fixation may not be required in case of adequate overlap laterally and spirally. Here you can see this stitch being taken on the left-sided corpus ligament and this on the right-sided corpus ligament to fix the mesh in place. After this, the anterior rectus sheath is closed over this mesh and then skin is closed. Suction drain was placed over mesh and over subcutaneous tissue because some dissection was performed in front of anterior rectus sheath. This was a photograph obtained around 6 weeks following surgery. Thank you very much. Thank you.
Taleb.
Thank you, sir.
Very nice to see open surgery being done meticulously.
Thank you, sir.
Questions from the audience?
The rectus sheath is not coming in between.
Sir, first is we have to ensure the adequate adequate release of transversus abdominis muscle up to laterally up to the psoas muscle, because it's a corset, so it has to be released so that it comes in the midline. Number one. Number two, if even after that one is not able to close the anterior rectus sheath, one can use bridging repair. The edge of mesh can be sutured to the edges of anterior rectus sheath, and then it can be covered with the peritoneal flap, which can be preserved on the one side of anterior rectus sheath. So bridging repair can be there, and stage repair, or controversial is the addition of anterior component separation with this.
That should not be done.
Yeah, that should not be done. It should not be encouraged. Yes.
Yeah. Thank you, Dr. Talib.
Thank you, sir.
One of the caveats for any successful hernia surgery is, first you have to identify what is the defect, study it, and then meticulously plan it, and then it's the execution.
Yes, sir.
You have very well and nicely planned the patient, and you have demonstrated your skill very nicely. It was a broadless field, meticulous dissection. That is very important, especially for an open hernia repair. We have also done a couple of cases like this, which you have demonstrated with very good results. So one has to be very meticulous about the dissection, judicious use of cautery, and knowing the anatomy. That is the basic. We should know the anatomy and going through the proper planes. That is essential for a successful hernia repair.
Thank you, sir.
Thank you.
Thank you for your encouraging words, sir. Thank you.
May I now call upon Dr. G.M. Naiku from the Department of Surgery. His topic is laparoscopic intracorporeal rectus aponeuroplasty. The GMC Srinagar experience.
Assalamu alaikum, respected chairpersons and their seniors and colleagues. Before starting the presentation, I'll just give a brief gist of how I started this presentation. It was at around 5:30 that I received a call from my worthy HOD that you have to come back to my office immediately. I was leaving 5. Everyone is waiting eagerly for 5. And I reached back, and in a stern warning that he told me you have to present. This is how leadership works. A big round. This is how they groom the juniors and force them to do the work and present their work. Thank you, sir. Thank you for giving this opportunity. A big round of applause for our HOD. So I'll be presenting. I'll give the credits, due credits to Dr. Arshid for this presentation, and the video credits also go to him. So this topic is, my topic is laparoscopic intracorporeal rectus aponeuroplasty. It's a novel approach, as Dr. Sarfaraz was saying, that we have to make it, the hernia surgery has to be made easy. We don't have to complicate the surgery. There are many surgeries, and nowadays it is becoming more and more confusing. Since this laparoscopic ventral hernia was reported by Lee Blank and Booth in 1993, a myriad of procedures have been invented. And every now and then, every day, we are seeing new and newer approaches being adopted. Almost less than 500,000 of surgeries, hernia surgeries, are being done every year in the United States. So when we are at crossroads, what to do? You have all these: anterior component separation, posterior component separation, you have Etep, Stopa, you have TAM, you have TAPP, you have SCOLA, and many things, IPOM, I+. And to add confusion to the story, we are presenting this laparoscopic intracorporeal rectus aponeuroplasty. So why is the need? Why should we go for this thing? IPOM, as you know, that there may be a central mesh failure. There may be a pseudo recurrence. IPOM plus, the closure is difficult. There sometimes the defect is big, and when you are doing an IPOM plus, there is a lot of tension on the defect, and you are closing it. It may result in the recurrences. It may result in the more pain. So this was a gentleman from Spain, J. Gomes, who came up with the concept of this laparoscopic intracorporeal rectus aponeuroplasty. A brief account of these procedures. Etep, Stopa. You need support initially. You need to watch the stalwarts of the field to do this surgery. You need their guidance. And then you need help. You need to operate under their guidance. And then you need a proper assistance. You see, when you are doing Stopa, there is a seroma formation of 5%. Most of these seromas do not need any treatment, as has been classified that class 1, 2, 3 seromas usually do not need any surgical intervention. But it's class 4 where there is an infection and you may need to remove the seroma. And then it is associated with the complications. The complications, the more dreaded complication, the Cleveland Dindo 3rd and 4th complications, which need an intervention, and where there may be an organ failure, there may be a multi-organ failure. These have to be treated. And the incidence of these in this procedure is 1%. Intraoperative complications range up to 2%, conversion rate is 1%, mean hospital stay is around 1.7%, and recurrence at 6 months is 1%. So this is the technique. What we are doing in this. This is a small video. This is not my own video. This is from the Department of Surgery. The credit goes to Dr. Arshid and Dr. Hamid. So after entering the peritoneal cavity, you see there are multiple adhesions. You have to take down these adhesions slowly and securing the gut if the gut is adherent, and you have to delineate the defect. After the delineation of the defect, you can do the measurements, whether you do it preoperatively, you do it intraoperatively, and defects up to even 8 to 10 centimeters can be dealt with this technique. You are raising the flaps, you are making a longitudinal incision almost 1 to 2 centimeters away from the defect. This is for midline hernias, but this same concept can be extended to the lateral hernias, or even this concept can be extended to the M5 hernias. This usually we are doing for M2, M3, and M4 hernias. So after doing this, raising these flaps all around the defect, as being beautifully demonstrated here, there are multiple techniques of suturing it. Here what we are doing a loop technique. We are just keeping the thread suture outside and only inserting the needle inside. And starting, we are looping, we are using a loop suture. The needle is passed through the loop to anchor it, and then the medial edges of this flap are with the pressure here. The pressure has to be maintained at the same. We are using a 15 millimeters of mercury pressure. You have to keep the same, and you start suturing the lateral edges of the this flap. Go on suturing it using horizontal metal sutures. From below upwards, whatever it is easy. It can be used by, it can be sutured by other methods also, like you are using the barbed sutures, V-lock sutures, and many other techniques. But the problem with those sutures is that you have to pass in the whole suture into the peritoneal cavity and then handling becomes little difficult. But whatever way is easy to you, you can do that. After completing this suturing, you can lower the pressure. You can decrease the intra-abdominal pressure to 6 to 8 millimeters of the mercury. You take one end of the needle out and pull it. So here is this defect being closed in front of you without much of the dissection, without much of the this complications of seroma, bleeding, and other things. And then conventionally, what you are doing in an IPOM, you put in a mesh and secure it in place. This is a simpler technique, as Dr. Sarfaraz was saying, that you have to simplify the procedure. You don't have to make it more and more complicated. Now, giving the little bit of the data from our Department of the Surgery. This is the mesh being fixed by the tackers. So this is the data from our department. Till now, 37 patients have been operated. And this is an old data. By now, the score is more than this. But this we have analyzed it. These were M2 and M3, M2, M3, and M4. Defect size was 4 to 7 centimeters. Mean defect is 5.2 centimeters. Operative time, mean operative time was 67 minutes, means around 1 hour. Seroma formation was there in the 4 patients which were managed conservatively. Hospital stay, mean hospital stay is 1.3 days. So you can discharge these patients on first or the second post-operative day. 1 year follow-up of 15 patients, there is no recurrence. So the results, initial results are very encouraging. And I think we should go on continuing with this procedure. This is a new addition to the already existing hernia condom. Familiarity with the anatomy, closure without tension are the main benefits. Evidence is accumulating and we are all still at the crossroads. So the crux is that we have to focus. If we are lost, we have to focus, rethink, and redo the things. Thank you very much.
Very nice presentation, Michael. I have 2 questions. One is, what is the level of the depth of the incision which is made all around the defect? And the second question, after applying the trackers, there is still a potential space left between the mesh and the edge.
Mesh and the?
Can be done between the edge of the mesh
and
the peritoneum. There is still a space left.
No, there is no space left. Basically, what you are approximating, the incision which you are giving around, the mesh covers that incision wholly. So there is no space left between that. So regarding the depth of this is the peritoneum and the posterior rectus sheath. As I am saying, that the concept same, although we are not using it for M5 hernias or the L hernias, the lateral hernias, but the concept then can be later on extended to those M5 and the L lateral hernias also. I hope this answers your question.
Some studies in which people have tried the glue, the space which is left between the trackers, the edge of the mesh and the peritoneum. After applying the trackers, one can apply glue to close that space.
Maybe it is a personal preference of the surgeon that time. You can do that.
What are the advantages of this procedure? Versus
Advantages
IPOM
are
plus?
that it is easy to do. It has made it simpler. The seroma formation is less. The bleeding is less, and it has an easy learning curve also.
Versus IPOM plus, why seroma formation will be less?
Yeah, IPOM. Yeah, it is up to 10 centimeters of the hernia. You can
so
do it. Yes,
less than 5, there would not be much tension with IPOM plus. Also.
Yeah, that is true.
So
that is true.
Then it will be.
That is true. Yeah.
Sir, the concept here is the role of relaxing incisions, which you give at the lateral edges, so that the tension at the defect is
Pardon,
less.
I couldn't get you. Pardon. I couldn't get you. I
Sir,
couldn't get you.
Sir, where you are giving the relaxation incisions
Yeah.
at the lateral edges, so that the effect on the midline defect is less.
Yes, and the rectus muscle is also being approximated because of that. Thank you.
Thank you, sir.
Hello, with the permission of the chairpersons. This is a wonderful presentation. I know you were not willing to present it, but unless I push you people, unless I make you come out of the nest, you will not fly. So it is my job as the mother bird to make sure that these eaglets, which I proudly call you, that I push you out of the nest and make you fly. Thank you very much.
Thank you very much, sir.
Wonderful.
Thank you. So nice.
Thank you. Now I call upon the dais Dr. Nazir Ahmed Wani from the Department of Surgery, GMC Anantnag. He will be presenting HIG guidelines for the management of ventral hernias and our initial experience at GMC Anantnag.
Respected chairpersons, dear colleagues in the auditorium, my friends, my seniors, it's an honor that I have been invited by the organizing committee. I am thankful to them for this hospitality and honor. So it is a great event. I want to congratulate the organizers for this. So my topic is basically two components. One is what are the guidelines. Second is what we are doing in our place, which is a small place, GMC Anantnag. The only thing is why I have chosen these South Africa guidelines is that there is still a confusion about guidelines. We have guidelines from AHS, EHS, and many people. These are the recently revised guidelines. I just want to go through, but it's a big book. I pardon that if I'll overshoot the time, because guidelines are so big that I cannot do justice with this topic. But I'll try to just rush through the slides because many of the things have been covered during the discussions by our stalwarts since morning. So what has happened that recently in South Africa, most of the high-end centers have come together under review audit, and they have formulated the guidelines after going through the evidence-based medicine and their work, and they have put it in the form of a big book which starts from the introduction up to the conclusions and the techniques. We will not go through all these things. Definition everybody knows, it's a facial defect, and presentation can be asymptomatic, loss of domain, which has been discussed. You will be surprised to see that 20 million patients are being operated for hernia worldwide per year, and of that 30% are ventral hernias. And incidence varies right from 10 to 15%, can go up to 69% in high risk patients. So what they have done, they have put some recommendations, evidence based. It is grade A is strong recommendation, what you should do. It's a research based evidence. Grade 2 is moderate, fair research. Grade 3 is symposia and consensus various conferences. And grade 3 is what you should not do, grade X. So I will not go through these. You have already come up, we know AHS, midline, lateral hernias. These all have been, everybody is familiar with this, how to see length, width, and how to grade these, how to make a nomenclature as per AHS. AHS is the classification which is adopted worldwide, easy, and you can easily follow that. Now coming to the incidence, we have around 71% out of primary ventral hernias, umbilical hernias, and second is epigastric hernias. Incisional hernias, we come across around 90% are laparotomy incisions, and now we have quite big number, about 5% port site hernias because the minimus exit being done. And then you have parastomal, which is a quite large number, 6%. Now the question is, if a patient comes to you with a hernia, whether it is ventral or incisional, should you offer surgery if patient is asymptomatic? We are always tempted. Patient comes with some complaint to us, we see his abdomen, he is operated, he has an incisional hernia, is asymptomatic, and patient will tell you, this is not bothering me. Should we offer him a surgery or not? That is the question which is always dilemma for the herniologists. Now as far as literature is concerned, acuity of symptoms, if a patient is asymptomatic, Data says, Danish data, that 10% of these patients will land in complications even if they are asymptomatic in future. So that is in favor that we should go for surgery in these patients. Now what are the factors to consider? One is umbilical hernias have 5 times incidence of in primary hernias to get complications. So such patients should be offered surgery. And we have seen if they are not treating them, they get complications, you increase the morbidity and mortality. Some of these have gone into the incarceration, strangulation, and it is why we can say that first opportunity is the best opportunity. So the recommendation from HIGSA is that these patients asymptomatic should be offered repair. There must be individualized based on patient risk, comorbidities, life expectancy, and type of hernia. It's a strong recommendation. Then second is symptomatic hernias. Of course, when they are symptomatic, you have to offer them surgery. So they usually have pain, discomfort, skin complication, irreducibility. Then it's a strong recommendation that such. Also, emergency patients, they also have recommended that they should be operated, but operation should be without delay, with the simplest procedure, which is best with the expertise of the surgeon, with the lowest complication rate. There is a strong recommendation. Then coming to surgical expertise, in hernia, it's the only surgery where expertise is very important. Herniologists should know A to Z of the surgery before operating a patient. Outcome of surgery depends on that, experience of the surgeon, volume of the cases done. Simple ventral hernias in our centers, we are doing it day in and day out. If you are doing it regularly, you can operate them. If you have complex hernias, they usually should be referred to the high-end centers where these facilities, we have expertise available and infrastructure available. This is a moderate recommendation. Then there are various special scenarios where guidelines are clear that if it is an obese patient with a ventral hernia, you can take both together, you have a strong recommendation. In case of strangulated and incarcerated hernia, recommendation is that you can take it this recommendation is moderate. Similarly, concurrent umbilical hernia, lap chole, we are regularly doing. Again, it's a moderate this. And prophylaxis as far as concerned, hernia it is same as in general surgeries. Then coming to the risk factors or optimization of the patient. My friend Dr. Arshad explained it very nicely. I don't need to dwell on this slide because he made my job easier. So we have to make them morbidity and mortality of these patients decrease. Outcome is good if we optimize them properly. Then meshes, again the big confusion. We have a lot of plethora of meshes, composite meshes, absorbable, non-absorbable, lot of debate on this. I will not go through these things. Just I will give what consensus was that most effective product that is available should be used for the appropriate indication. That's a strong recommendation. And extraperitoneal repair should be done where ventral hernia, old group class 1 and 2 should be performed with plain large polypropylene meshes. Then intracorporeal meshes should be Intraperitoneal meshes should be usually composite, which we are using moderate recommendation. And there is a lot of confusion about clean contaminated wounds, but evidence is very weak. Biological meshes have come up, but still evidence is very weak whether we should use them in effective conditions or not. Then suture repair role is very limited. Role is limited to those patients who have less than 2 centimeters and who have more than 2 centimeters. You should go for mesh. So I'll rush through the slides because we are going short of time. So mesh fixation, again a confusion, tacker, all the things have been tried. Fixation, lying of the mesh should be retrorectus. Then mesh position, techniques I will not delve with. Now coming to our own experience at Department of Surgery, GMC Anantnag, we did a retrospective observation study of March 2020 to 2023. We operated 104 patients, out of which 61 were primary ventral hernias and 43 were incisional hernias. Age was more younger in this ventral hernias, older patients were in the incisional hernia. The type of hernias, again umbilical and epigastric in ventral hernias, and we had in incisional hernias, we have lower midline were more common, and lateral hernias were also a few cases, 6 cases. So we again categorized them as per the defects. In ventral hernias, defect size was in majority of the patients was less than 2 centimeters, it was in the range of 3 to 4 in maximum patients. Then contents of hernia sac, omentum was the most important content. Then coming to the laparoscopic procedures, 33 patients underwent laparoscopy. Most of the patients we did laparoscopically with a mesh. Only few small hernias, ventral hernias, we could do suture repair. To be more precise, 2 cases only. So operating time was at par, there was not much difference except in IPOM plus we had more time. Then coming to complications, we had very few complications as far as the bleeding is concerned, few SSI infections, but no mesh infection we could see, no bowel injury in the ventral hernias, but in case of incisional hernias, we had a one bowel injury, which patient has to be admitted in ICU and we have to explore him and we have to plant the mesh because we missed it, second day we could note it. Then coming to the conclusion, laparoscopic management of ventral hernia has gained popularity in early 90s with some early enthusiasm, lost later in the time. Open hernia repair is still widely performed procedure worldwide. Reviewing the current status, one has to specifically look at the patient and hernia defect factors, technical considerations, and surgical expertise. Patient is best suited for laparoscopy or obese, diabetic, with a defect size of less than 10 centimeters and with Swiss cheese defects. The overlap of mesh should be 4 centimeters. And complications related to the surgical side favor the laparoscopic approach. Recurrence rate, satisfaction, health rated, quality are almost at par in both cases. Recommendation like type of mesh, fixation of mesh still not clear. Silver lining visible in the future is that we are getting more and more studies to elevate the evolving practices regarding laparoscopic management of ventral hernias. Thank you. One more slide. Yes, that I wanted to put question to all HSI people that why don't we come with the Indian classification guidelines? That should have been, by now there should have been a consensus what we should do in our patients. The topic is so confusing. वो उसमें दिया था ना वो इसके बाद ही होगा ये दूसरा कौन सा इसमें नहीं है यार वो दाव उसको दावर को दिया I just want to show you one slide that we are organizing with the patronage and permission of our chairman Jakasi Professor Iqbal and our executive committee. Yesterday we are organizing the annual conference of Jakasi J&K chapter association of surgeons of India next year in May 23rd to 25th. It will be an honor to host you at Pahalgam Club and Convention Center, and very shortly we are starting registrations, and I hope we can give a lot of academic material, hospitality and serenity of the land of shepherds, Pahalgam. So I invite you all. Before that we are doing one more event, a medical camp and this one day CME at SDH Kupwara and a free medical camp at Bangas Valley.
Sir.
Once we wait, yes. About what? Sorry? Yes, there are definitely guidelines. Patients, it is why I am saying that patients who have, suppose post-op, they had some surgery has been done, they had infection, they had a wound dehiscence. Those patients, once you give them surgery, you have to take care that guidelines are that mesh, most of the times we should not use mesh, preferably we should not use mesh. If it is in the setting that it is a contaminated wound, it's a dirty wound, or suppose there is an enterotomy during surgery, then that time you should avoid mesh. And biological meshes have been tried, but results are not good. Guidelines in South Africa are clear that even biological mesh has not proved fruitful. But there are some weak recommendations that in these patients where you have a very less contamination or clean contaminated wound, you may close it and you may put an extra mesh retrorectus after this cleaning, and you can put it extraperitoneal mesh. You should not put it in the, you should not do IPOM and other things in those patients. Yes, where optimization role comes. Dr. Arshad already talked about this. Which class of patients with cirrhosis, ascites, what should be the criteria and when you should take them for surgery. Optimization is very important. Such patients with comorbidities, diabetes, other things, see chronic liver disease. You have to optimize them before for getting better outcomes.
Thank you, Dr. Nazir. It was wonderful to have you here. And I'm quite sure the
Thank you, sir.
conference that you're going to organize is certainly going to be a wonderful event. Especially, it's going to be in Pahalgam. So, something really great. Wonderful.
Dr. Ahmed, Department of Surgery, GMC Baramulla, ETP inguinal lessons learned. Dr. Waqar Ahmed.
Anyone presenting on behalf of Dr. H. Waqar? Okay. So with this, we conclude the session. Now I request Dr. Bashir Ahmed Makhdoumi, sir, to kindly come on the stage and felicitate our speakers and chairpersons. Professor Abdul Rashid. Our first speaker, Dr. Talib Hussain, sir. Dr. G.M. Naiku, sir. Dr. Nazir Wani, sir. Thank you, sir. Now our chairperson is Professor Sheikh Bilal, sir. So kindly.
They have been class for us.
Professor Mushtaq Mir, sir. Dr. Tarun Mittal, sir. Dr. Kulwant, sir.
This is pediatric hug.
Thank you, sir. Dr. Manmohan, sir.
और डॉक्टर राजऋषि शर्मा HOD तो ठीक है सर और प्रोफेसर इकबाल सर।
Thank you, sir. Thank you. ये रखा है, sir, शाम से. Thank you, sir. Thank you, sir.
Thank you.
Thank you so much. Sir, please take your seats, chairpersons.
और कौन है सर?
नवीद sir हैं.
है ना? आधे नजदीक क्या हो गया ये लोग बैठे हैं सर. सर वेट कर रहे हैं. क्या हो गया?
ये
सभी को
पहले
राज ऋषि है,
कोई नहीं आया
नवीद है,
तो इनमें से बुलाऊंगा. अगर इनमें से कोई आया नहीं होगा ना, क्योंकि एचवकार सर नहीं आए.
नहीं आए.
इनमें से
ये
बदले
आया
शाम
है,
से
ये आया
बारी
है,
बुलाएंगे.
ये आया है,
नवीद सर भी आए.
नवीद सर भी आया है, फरूक भी आया है, आकाशदीप का कोई पता नहीं है, राजनदीप सिंह, राजन को बैठा हुआ रहता है, कार को पूरा बन जाएगा.
ठीक है. Now for the next session, I would like to request our chairpersons to come on the stage. Professor Raj Rishi, sir. Professor Naveed Nazir Shah, sir. Dr. Syed Javed, sir. Dr. Rajandeep, sir. Dr. Barinder Kumar, sir. So over to chairpersons.
For the organizing committee for allowing us to chair this session. First, I would like to invite the first speaker, Dr. Sarfraz.
वो हो गया है. उन्होंने वो कर दिया था. कौन सा? अभी तो ये हुआ ना. वाली ये तो चला हो गया.
Dr. Mohammad Yaqub Bhatt from the Department of Surgery, GMC Srinagar. He will speak on the topic combined laparoscopic and thoracoscopic approach for idiopathic incapsulated diaphragmatic hernia.
Respected chairpersons, esteemed audience, Assalamu alaikum. I am presenting an interesting case of combined laparoscopic and thoracoscopic approach for an idiopathic diaphragmatic hernia.
Please be closer to the mic. Be closer to the mic. You're away from the mic. Huh? Be closer to it.
As we all know, diaphragmatic hernia is the protrusion of abdominal contents into the thoracic cavity through a defect within diaphragm. It's most commonly congenital due to developmental defect leading to lung aplasia, hypoplasia of the lung, and fetal and neonatal complications. Or rarely it can be occurred due to blunt or penetrating trauma. And also case reports of iatrogenic and spontaneous diaphragmatic perforations have been reported. Diaphragmatic hernia is a life-threatening condition because of the propensity to cause incarceration of the abdominal contents in the thoracic with the resulting gangrene and leading to overall mortality of 30%. Optimal surgical repair along with sound perioperative care is essential for the successful management of this condition. Now coming to our case, she was a 27-year-old lactating mother, non-specific complaints of pain upper abdomen with 5 days history of nausea and shortness of breath. There was no underlying history of trauma. On chest X-ray, you can see the presence of gastric bubble in the left thoracic. Again, contrast enhanced CT was done, which again shows presence of stomach in the contents in the left thoracic cavity with moderate left side pleural effusion and left lower lung collapse. On preoperative optimization, after preoperative optimization, patient was taken for surgery, laparoscopic surgery. We used a total of 7 ports. Initially, abdominal 4 ports, and 3 thoracoscopic ports because this was combined procedure. This is the OT setup. We have used 2 monitors. After creating pneumoperitoneum and introduction of trocars, we have done this quick diagnostic lab which revealed the herniation of stomach and omentum in the diaphragmatic hernia, in the diaphragmatic defect. It was incarcerated. We tried to reduce, but because of the dense adhesions, we are not able to do so. So we widened the hernial ring by using energy source and again tried to reduce the contents. There's a cerebropurulent fluid which is coming from the thorax into the abdominal cavity. So even after widening the defect, we were only able to partially reduce the omentum. And this is we have introduced the camera into the thoracic cavity. You can see a lot of purulent fluid and flecks of pus inside the thorax cavity. And meanwhile, we try to reduce the content. But because of the dense adhesions, we find difficulty in doing so. So we decided to do combined approach of thoracoscopy. We are introducing the trocar into thorax and 2 working ports. And you can see the picture, thoracoscopy picture. This gives assessment of the contamination in the thorax, the pus flakes on lung and pericardium. So using the combined approach to reduce the contents, both laparoscopic and thoracoscopic, we were finally able to deliver the contents which is stomach in this case, into the abdomen. So what we find here is a big perforation in the greater curvature of the stomach. So we reposition under vision the Riley's tube across the perforation, and we decide to resect the perforated part of the stomach by using a endolinear stapler. 60 mm cartridge, green cartridge. We fired 3 staplers. So at the end, this is the simultaneous view from the thoracoscopy to ensure the adequate resection of the perforated part. So after resecting the perforated part, we do peritoneal lavage again of the thorax, the generous lavage, which is necessary because of the infected material, and aspirate the contents. Now we introduce needle because we had only put 5 mm working ports in the thorax, so we introduce needle to the abdomen and take it through the diaphragmatic defect in the thorax. After doing devitalization of the edges, we do primary repair by using 2-0 V-lock suture, which is a barbered suture, and do continuous suturing. We have avoided putting mesh because of the gross contamination. Here, while suturing, we ensure we take care not to injure the spleen, which is seen. So at the end, we take the needle, last 5 sutures through the abdominal side. These are the last 5 sutures from the abdominal side, and we secure the suture by placing a clip at the end. We again use gauze in the thorax to do the final dry mopping, and we ask the anesthesia because we have done single lung ventilation. We ask the anesthesia to inflate the lung, and there is expansion, good expansion of the lung. Sorry. Hashmat. Sorry. Forward कर थोड़ा कर. Then we are placing chest tube through one of the thoracoscopic ports, and now we do the final abdominal lavage and dry mopping, and then we take the specimen out And in the post-op, patient behaved well. This is the post-op chest X-ray. Initially, she needed intensive care for 1 or 2 days. And then the regular inpatient, she was shipped to the inpatient ward. In the post-op course, Riley's tube, intercostal tube drainage and drain were removed up to day 7. And on the day 7, patient was discharged. So the post-op course was uneventful. She's on regular follow-up and she's doing well. We summarize by saying, though diaphragmatic hernia can be repaired by either laparoscopic or thoracoscopic approach. However, we believe in acquired chronic diaphragmatic hernia where we expect a lot of adhesions. Combined laparoscopic thoracoscopic procedure is advantageous because there's provision of adequate adhesolysis and easy reduction of the contents, proper lavage, and more ergonomic repair from the thoracoscope by the combined approach. Thank you.
Thank you, Dr. Bhatt. It was a beautiful video presentation of this complicated case and beautifully managed. And we should also thank the anesthetist who allowed you to do this over and over. Thank you. Beautiful presentation.
Thank you, sir.
Any comment from the audience?
Thank you.
Mr. Bowden.
Dr. Jacob. Hello, Dr. Jacob. Thank you so much. It was such a wonderful presentation by you. And I must congratulate your operating surgeon for such a, taking such a bold step and doing it flawlessly. I must congratulate the operating surgeon. And it's I think this is the paper and video which deserves to be presented in some national event.
Thank you, sir.
Thank you so much.
Thank you.
And
oh yes, it has been. I think this is the paper which was accepted by SAGES.
Yes, sir. It has been.
Our postgraduate presented there. So
look, it's too scary
I must
to
congratulate.
Heart is beating so close to here, and spleen is there. It's too scary. Very good. Yes, beautiful presentation. Beautifully done. Thank you, sir.
Thank you, sir. Actually, we never have a postgraduate exam until we have an X-ray which was similar to this, either a hiatus hernia or a diaphragmatic hernia or an eventration of diaphragm. So no exam is complete without that X-ray in our exam.
Was it a planned procedure?
No, not this one. I'm not talking about this one. I'm just.
Okay.
Now I invite Dr. Razia Banu. She's a FNB candidate in our department, and she'll be presenting a talk on laparoscopic Etep technique for ventral hernias.
Respected chairpersons, dignitaries in the audience, and my dear friends, a very warm good morning, good afternoon to all of you. I'm Dr. Razia, FNB scholar. I'll be presenting laparoscopic Etep RS in ventral wall hernia. So the incidence of ventral wall hernia is roughly 10 to 20% post-open surgery, and the incidence increases up to 40% if the patient develops a post-operative complication in the form of wound dehiscence or wound infection. So the management of hernia has come a long way, from primary suture repair to open mesh hernioplasties, followed by introduction of laparoscopy in the form of IPOM in 1993 by Lee Blanc. So then in 2012, Horg Days, he described the Etep approach for complex inguinal hernias. And in 2016, Igor Balansky and his associate, they followed the same principle for Etep in the management of ventral wall hernia. So the concept in Etep RS is to create a large wide area for the placement of mesh by connecting both the retrorectus space and the space of ridges and the preperitoneal area in the falciform ligament. So what Etep RS has to offer? So as there is a wide area is made, a large mesh is placed, so there is low recurrence. As it's a highly vascular space, low mesh infection, as we have to place the mesh in a retrorectal space, so no intraperitoneal processes, so fewer adhesions and other complications. Minimal or no fixation, so low post-operative pain, and we use a non-corded mesh and no fixation device is needed, so low cost. And if there is complication and we cannot close the difficult posterior closure or less space for mesh, we can also add a TAR. So after history, clinical examination, investigation, the patients who are planned for Etep should be primary midline ventral wall hernias, especially for surgeons who have started their Etep journey recently. And incisional hernias with defect size up to 10 centimeter. There are a few contraindications like active skin infection, loss of domain, ulcerated skin, intercutaneous fistulas. So coming to the steps, first of all, the patient should be placed in a supine position with both arms tucked, and the table can be break in between to increase the distance between the xiphisternum and the pubic symphysis. So first of all, the primary access or the safe access, it can be open access or we can use an OptiView. So, and the port positions, usually in infraumbilical hernias or M3 hernias and M4 hernias, the port position can be like this. So first port we make in the this left subcostal region, 3 to 4 centimeter beneath the costal region and medial to the linea semilunaris. However, if the patient is having a M2 hernia or M1 hernia, we can make the port position like this also. So after first making the first axis, we have to dissect the retrorectus space. Here in this picture, we can see the posterior rectus sheath, and on the roof, this is the rectus abdominis muscle. After creating the retrorectus tunnel, we have to do the crossover, which is the most difficult part of the surgery. So in a superior crossover, we have to make an incision roughly 5 mm to 1 centimeter lateral to the linea alba so as to prevent injury to the linea alba. Here in this picture, we can see the falciform ligament and that identifies that we are in the right plane. Then the contralateral PRS should be identified. There are small tricks here. First of all, the linea alba is pearly white in color, and the posterior rectus sheath, it's usually pinkish or brownish in color. Another method to identify the posterior rectus sheath is we can use small energy burst. So, and if it is the posterior rectus sheath and there is the rectus muscle, we can see a small twitch of the rectus abdominis muscle. Then in this picture, we can see that we have identified the this posterior rectus sheath and the longitudinal fibers of the rectus abdominis muscle is visible. Then after creating the other space, we have to connect both this space. After dissecting, after complete dissection, this is the volcano sign, which is where the hernia actually is. So this is the right posterior rectus sheath, this is the left, and this is the linea alba, and this is the site of the hernia. Here we can injure the peritoneum sometimes, but that can be beneficial also sometimes because we can reduce the hernia under vision. So after completely joining this both retrorectus spaces, we have to close the posterior rectus sheath complex. If it is difficult to join both the posterior rectus sheath, we can just disclose the rents in the peritoneum also. So followed by closure of the linea alba and the defect on the anterior abdominal wall. This is followed by placement of the mesh, which is wider, and it should be properly placed without any crumples and without any this. So a laparoscopic, the thesis has already been conducted in our department as laparoscopic Etep technique for ventral wall hernia, in which we included 25 patients. Out of these 25 patients, 23 were females and 2 were males with a BMI of 31.4 and approximately 46 was the mean age. Though the patients which were included 12 patients at M4 hernia, 8 patients at M3, 4 patients at M2, and 1 patient at M1 hernia. So the observation and results were like operative time was roughly 178 minutes. Post-operative complication, there was seroma formation in 1 patient, which was managed conservatively, and the hospital stay was roughly 2.9. Post-operative pain based on visual analog scale was 1.2, and recurrence is not seen in any patient so far. So Etep RS is a safe alternative to open ventral wall hernia in selected cases and allows placement of a larger mesh and can be performed by surgeons familiar with the ventral wall anatomy and laparoscopic technique for groin and ventral wall hernias with satisfactory result. But as it's a new approach, requires further analysis. Thank you.
So good presentation, actually a new approach for the management of ventral hernias. Anyone from the floor or senior people want to comment on this? Dr. Chalku, sir, please.
Wonderful presentation, Dr. Reza, as always. I would like to make a comment regarding these procedures. They should be a very good exercise for the surgeon to take these procedures. And the incisions have to be respected, as we said other day during the daytime, that Etep RS or TAR or whatever these advanced procedures, they take almost around a decade to grapple and do a foreplay to become trained for this, because the concern of the mesh infections and all that, and then entering into the true planes takes a lot of time. So the message is that they are very advanced procedures and should be taken by the highly skilled and experienced surgeons. Thank you.
Okay. Thank you so much.
Thank you, sir.
Now we call upon the next speaker, Dr. Mudassir Habib, who will be presenting his paper on laparoscopic ventral hernia repair by IPOM plastic.
Respected chairpersons, respected audience, I am very thankful to organizing committee for giving me the opportunity to present. I am going to present laparoscopic IPOM plus repair in ventral hernias. As we all know, the incisional hernia is the most common surgical procedure performed by the general surgeons. Because the incidence of incisional hernia post-laparotomy ranges from 20 to 20%, and its incidence of the port side ranges from 0.2 to 2%. Overall prevalence of ventral hernias, including primary as well as incisional hernias, is 4% in adult population. Worldwide, approximately 20 million patients with hernia are treated each year. It was Carl LeBlanc in 1993 who introduced the IPOM technique, and it became the well-accepted minimally invasive technique for ventral hernia repair because of its advantages like shorter hospital stay, decreased bone infection, better cosmetic outcome, and early return to work. The basic principles of IPOM. The basic principle of IPOM. I'm not going to pictures in this diagram.
So basic principle of IPOM depends upon the Pascal's principle of hydrostatics, which states that equal forces in an enclosed fluid space act equally at all points. So when we apply a wide mesh overlap of the defect, distributes pressure equally over a large surface area that is responsible to secure the mesh in place. Why IPOM plus? There were certain complications with the IPOM, that was increased incidence of seroma, increased incidence of recurrence and pseudo-recurrence, and most importantly, non-restoration of the abdominal wall function. To minimize these issues, Franklin advocated defect closure that was known as IPOM plus or modified IPOM technique. What are the advantages of IPOM plus? There was a restoration of abdominal wall function that increased the respiratory capacity and defecation in these patients. It reduces seroma formation by decreasing the subcutaneous dead space. It provides surface upon which mesh can be placed, hence reduces bulging, mesh indentation, and pseudo recurrence. IPOM plus is a good option in obese patients, also in recurrent hernias, in difficult hernias, as well as in incarcerated hernias. We have been doing IPOM plus here from more than a decade, but I will share experience of 5 years from May 2018 to May 2023. In this period, we operated 89 patients, and 58% of these patients were females and 42% males. And average age of our patients was 44 years. Out of 89 patients, 39% of the patients operated via primary hernia, in which majority of the patients had umbilical hernia. 51% of the patients operated had incisional hernia, and 9% of the patients had recurrent hernia. We operated patients with defect size ranging from 2 to 6 centimeters. 73% of the patients had defect size ranging from 2 to 4 centimeter, and 27% of the patients had defect size 4 to 6 centimeters. Our average operative time was 92 minutes, and average hospital stay 1.5 days. We had complications. We had seroma in 3 patients that was managed conservatively. Port site infections we encountered in 1 patient that was managed by antibiotics. We had mesh infection in 1 patient, and that was managed by explantation of the mesh. And recurrence we found in 2 patients. We do not had any intestinal obstruction, and we had chronic pain in 3 patients. Now, the surgical technique, the IPOM plus technique is done in general anesthesia. Rayleigh's tube insertion is done. Patient is put in the supine cushion with arms by the side. Pneumoperitoneum is preferably created by a varus needle at Palmer's point to avoid the adhesions. For successful surgery, we should place ports as far as away possible from the defect, and we should keep the intra-abdominal pressure high during dissection and low during mesh fixation. This picture depicts that we can address any hernia at any quadrant of the abdomen as long as we can put the ports about 10 centimeters from the defect size and place a wide mesh. So all of we know that mesh infections can be devastating. We should give less environmental exposure to this mesh. That means mesh should be taken out from the envelope when the surgeon is fully ready to put the mesh inside the abdominal cavity. We should change the gloves before touching the mesh and avoid the contact between mesh and the skin. Now, what are the concerns of the IPOM plus? We have to use we are using this composite mesh. The cost of the mesh and tackers is a concern, but luckily in our hospital it is in our hospital supply free of cost. And there's a concept of we are putting the mesh in the abdominal cavity, so it's an intraperitoneal foreign body. But with the advent of recent advances in the mesh technology, these have been mitigated. And the future surgery in this patient is a difficult part. And these future surgery can be done in this patient, but this should be done by experienced surgeons. It's a video of a patient who had undergone open cholecystectomy by subcostal incision, and he had an incisional hernia. Then we are doing the erythrolysis here by using the harmonic. Care is to be taken at this point that gut can be in the, as a content we have to avoid. At this, we are defattening the margins. We are defattening the margins of the edge so that make a this ground for mesh placement. At this point, we are now suturing the defect by using a non-absorbable barbed suture. We can use proline suture as well, but the barbed suture, it becomes easy to suture the defect. At this point, we have to decrease the intra-abdominal pressure to 7 to 8 mmHg so that this defect can be sutured nicely. We can suture, we can close the defect by other techniques as well, like transfacial sutures, but that causes increased chance of infection. Now we are placing the mesh. This central suture, this serves two purposes. First, it helps us to identify the surface of the mesh, which one is the peritoneal side and the other visceral side, and another, it helps us to centralize the mesh. Centralization of mesh is very important to reduce the recurrence. Now we have applied tackers. Now we are giving the sutures, intracorporeal sutures, by using the PDS suture at the corners. We believe that using this transfacial sutures increase the pain incidence of because of nerve entrapment. It is a difficult, but once surgeon is experienced, he can suture it very well. With introduction of newer techniques of extraperitoneal mesh placement, retromuscular or periperitoneal, there has been resizing in the IPOM technique. Despite this, it is one of the most widely adopted technique because it is safe, it is reproducible, it is technically simple, it is time-tested technique, almost there for 3 decades now. There is less soft tissue dissection. There is an advantage of diagnostic laparoscopy by which we can identify occult hernias, and that helps in reducing the chance of recurrence. So take-home message is IPOM Plus has a satisfactory outcome if done in proper patient, if complete precautions are taken for asepsis and correct size of mesh is used with correct adequate mesh fixation. We have already a publication. Thank you very much.
Thank you very much. Any questions from the floor? Thank you very much.
Thank you.
So next speaker will be Dr. Safura Wani from the Department of Surgery, GMC Srinagar, and she will be presenting laparoscopic transabdominal preperitoneal mesh hernioplasty.
Assalamu alaikum and a very good afternoon to esteemed chairpersons, faculty, senior, juniors, and my dear colleagues. I, Dr. Safura Wani from Department of General and Minimal Access Surgery from Government Medical College, Srinagar, welcome you all for my presentation on laparoscopic transabdominal preperitoneal mesh hernioplasty, how we do it. As we all know, inguinal hernias account for 75% of all the abdominal wall hernias, with a lifetime risk of 27% in men and 3% in women. Minimally invasive surgery was added to the procedural armamentarium in the early 1990s. Definitely being more demanding than the open counterpart, has a long learning curve. The main aims and the objectives of the study was to determine the feasibility and the patient's outcome. All the patients above 18 years of age group with the uncomplicated inguinal hernias were taken into the study. However, the patients with the complicated hernias not fit for the general surgery, having the previous abdominal or pelvic surgery, were excluded from the study. Patients were followed up over a period of 2 years, and the data was collected prospectively in terms of age, gender, duration of study, any intra or post-op complications, hospital stay, and the recurrence. I'd like to share a small video of a patient who presented to us as a case of left-sided direct inguinal hernia, and he was planned for the left-sided TAPP. One can appreciate in a picture there are previous scar marks of the previous surgery he had undergone, again for the right-sided direct inguinal hernia managed by the right side TAPP. Pneumoperitoneum was created using the various needle. One can appreciate a direct inguinal hernia defect. The vas can be identified, gonadal vessels, external iliac vessels are identified in this video. Rather than carrying out the normal incision of 3.5 centimeter, a small incision is being carried out and the inferior peritoneal flap is being raised. The main aim of creating is that the fat, the vessels, they should be lying towards the abdominal wall and only the peritoneum should be reflected. And the dissection should be carried out not crossing the medial umbilical ligament. Once we are in the proper plane, one will appreciate the seroside being dissected out towards the abdominal wall and the peritoneum being deflected downwards. And once reaching the inferior side, one can identify the lighthouse sign, which is the Cooper's ligament, and the end point of the dissection is 1.5 to 2 centimeters up to the subcubic area. After the inferior dissection, the lateral dissection is being carried out so that 5 centimeters of the overlap is being carried out, and it will cover the direct inguinal hernia defect as well, indirect as well. Following the inferior dissection, medial dissection, lateral dissection, the superior flaps are being raised, which will cover up the superior margin of the mesh. Now the cord structures are being held by using the grasper, and the medialization of the cord is being carried out. Medialization of the cord, once we carry out the medialization of the cord, you will see the tenting of the cord once it turns out medially. That is because it goes just beneath the fold of, that's the preperitoneal fold of Schrodel, and it is to be dissected so that there is no tenting of the mesh once we place the mesh over it. The sac is being pulled and is being attached to the Cooper's ligament. Mesh is being placed and fixed using a tacker. Now one can appreciate the disparity between the size of the superior and the inferior flap. This disparity of the size is being covered by suturing, which is a 1:4 suturing technique, which involves a 1 suture from the superior flap and 3 to 4 sutures from the inferior flap. Once we tighten the suture, one can appreciate there's a loss of the disparity. This is corrected almost. Now the remaining of the defect is closed by a 360-degree stitch. And the advantage of this 360-degree stitch is so that the inferior flap, which has been raised, it will not remain saggy again, and no more of the dead space which has been created during the time of the dissection, that does not remain there, and which will lead to the less seroma formation, the less chances of the post-operative infections. So the majority of the patients who reported to us as a case of direct inguinal hernia, they were account 33% were of the age group of 40 to 49 years, and 32% of the patients had the right-sided indirect inguinal hernia. 9% of the patients had the post-operative complication, most commonly as a pain, and only 4% because of this technique had the seroma formation. And post-operative site infection was encountered in 1% of the patients, with recurrence seen in almost 0.7%, that is one patient only, and scrotal hematoma was seen in none of the patients. Thus, I would like to conclude by saying, for the direct inguinal hernias, less of the lateral dissection should be carried out, less creating of the buttonhole, that is creating smoothly the inferior flap. Medialization of the vas should be carried out by cutting the preperitoneal fold of Schrodels, and 1:4 suturing technique should be followed, and 360-degree stitching, it prevents the seroma formation. Thank you.
Thank you, Dr. Sasura. It was a beautiful lecture.
Thank you, sir.
One point which is very common to all type of hernia surgeries, knowledge of anatomy,
जी sir.
and that too predictive anatomy. You
Ji,
must
sir.
expect what is coming next.
जी sir.
That will save many complications. Thank you.
Thank you, sir. Hmm. Can I go from the backstage? Let me go from the backstage.
So we started hernias. We was in fact the very after gallbladder we probably go to hernia. So we have all the people, senior people here who are into this job for last I think 10, 15 years now. So I would like to just make a few comments regarding how we do it. Sure. We put a title, how we do it. That goes to say that you have to listen to us. I'm sorry. Sure. Because this is how we have learned over the period of time to make this technique foolproof. As other day in the morning, we had a lot of discussions over mesh infections, seroma, recurrence, and all that. In the first go, I would like to make it do it as it is to be described. So how we find it and our thought process is that the incision that we place in the peritoneum should be minimal. What happens in the beginning, you make a lot of incision, big incision, it takes a lot of time, a lot of dissection, seroma formation is more, pain is more, and then it takes more time. So we take the less, if you could have observed the video. Second is we do not believe in making much of the lateral preperitoneal pocket, unnecessary dangling those sleeping nerves there, which is a problem, unless there is an indirect hernia. If it's purely an direct hernia, we concentrate more on the medial preperitoneal pocket. Second to that is our observation is that we probably all will agree, the upper flap is thin, lower flap is broader, redundant, and it is more fatty, thick. So as you go on making the reperitonealization, it creates a hole in the upper flap. And then there is a disparity. In the video, it was beautifully shown, there's a very saggy lower flap. And that goes to say that there is a big space left between the mesh and the saggy flap. Upper flap is very adherent to the abdominal wall. Now coming to this thought process, this took our observation that how could we obliterate this lower saggy and baggy space was that what we do, we get into seeing that before placing the mesh, the teaching, conventional teaching in the literature is that vas should be medialized via returns to the medium. We go a little ahead with that understanding. Looking at the evidence we had of the seroma and all that, we believe the preperitoneal fold of Schroedel, which probably many of us do not pay attention to, which I was saying other day also, needs to be cut. What happens when you cut this preperitoneal fold of Schroedel? The vas falls down. When vas falls down, the mesh does not stand on the vas. What does that mean? That means it is sleeping without wrinkles on that space destined for it. Coming to this point of putting the mesh plainly down, reperitonealization, how we have tackled that part, saggy part, we take one suture in the upper flap and 4 sutures in the flap. It just takes care. And then tightening of the lower flap, we take 360-degree rotation. It is just to take, it's nothing great, it's just an art in the wrist. You just move it to another thing that takes the saggy flap down and it marries the peritoneum closely to the mesh so that that baggy space is left over. This was another point. And the less, incision makes it easy. It takes just 5 minutes with the experience to close it back. Thank you very much. I think she has done excellent. Professor Iqbal was telling me she should be the next candidate for FNV. She is one of our best postgraduates.
Thank you. Thank you.
Sorry, registrars.
Now I would like to call Dr. Dawar Maksud Bhatt for his presentation, a meta-analysis of open versus lap approach for repair of paraesophageal hernia.
Good afternoon, esteemed chairpersons, dignitaries, faculty, my seniors, juniors, and my dear friends. I'm Dr. Dawar Maksud Bhatt, senior resident in the postgraduate department of minimal access and general surgery, and I'm presenting a meta-analysis of open versus laparoscopic approach for the repair of paraesophageal hernias. Going by the definition, hiatal hernia has been defined as a hernia which occurs when there are defects in diaphragm, allowing varying degrees of abdominal contents to herniate cephalad into the mediastinum. So it encompasses a wide variety of conditions. Most commonly, it is of type 1 classification of Sweet and Allison, in which the gastroesophageal junction herniates above the diaphragmatic hiatus. It's more than 85 to 90%, it's type 1. But the true paraesophageal hernias are where the part of stomach herniates cephalad into the mediastinum, which includes type 2, 3, and 4. In type 2, there's only the herniation of most commonly the stomach. The fundus of the stomach herniates in type 2, and the gastroesophageal junction, it remains below the esophageal hiatus. But in type 3, it's a compound hernia where the gastroesophageal junction as well as the gastroesophageal junction herniates above, as well as there is a paraesophageal hernia of the fundus. Then there is a complex type 4 in which there are other viscera which also herniate, like stomach, intestines, colon, and other contents. This classification was given by Sweet and Allison. In this analysis, we have used the search engines of PubMed, Medline, and Cochrane databases, which were searched using the terms paraesophageal hernia, treatment, laparoscopy, and open surgery. These are the terms which were used. And by using them, we have searched about 155 articles, of which 30 we found relevant articles for our study, and 9 manually searched articles were also included, which makes it a total of 39 articles. But the issues in this study, why we have chosen to do this study was already there's a very low level of evidence, and there are no level 1 randomized control trials on this subject. So we have, that's why we are taking this study. And in the articles which we have searched up to 2012, we have found level 2C evidence in 16 of those articles and level 4 evidence in 23 of them. These are some of the direct comparative studies which have focused on laparoscopic versus open approach, and starting right from 1993 by Kuster et al. We have taken the operative time, morbidity, and recurrence in this study. And most of the articles have shown that the operative time, as we can see, it is more in laparoscopic approach, except one, that is the first one, which has shown that the operative time in laparoscopic approach is less. The morbidity percentage also is more in the laparoscopic, in the open group, but the recurrence, which is a matter of debate, has traditionally been found more in the laparoscopic group as compared to the open one. Some the articles, the studies which we have seen regarding the direct laparoscopic approach only, we have found level 4 evidences, and the total number of these studies, the study sample is usually less in these series. That's why we have compiled them. And usually the morbidity in these laparoscopic approaches ranges from about 3 to 7%. And the recurrence in these articles ranges from 0 to 22.7% in this group. And we have included a few more laparoscopic approach which has shown similar numbers. The biggest one of these has included 166 patients of Andujar et al. In 2004, which has shown a morbidity of 2.4% in the laparoscopic group and a recurrence percentage of about 8%. These are all the articles which we have included. And in the open approach also, we have studied and reviewed the articles which have grade 4 evidence. And these are larger studies than the laparoscopic ones, with patients ranging more than 200, and more than 240 patients are there in the Patel et al. Study, which has also shown that the morbidity percentage in open approach is it's slightly less than the other comparative studies. It's about 6.7%. Whereas some studies have even documented 27 or 23% morbidities. And the recurrence which we have seen in these open studies is usually lesser than those of the laparoscopic approaches, ranging from 0 to about 12%. So, compiling this all this evidence, we have seen that we have compiled the evidence mostly in two categories of 2C and 4. Level 2C evidence, we have seen that laparoscopic approach has less complication rate but a higher recurrence rate, and the operative time in conventional open surgery is less. A level 4 evidence, we can say that the laparoscopic approach has less complications but a higher recurrence. So overall, reviewing all these articles, our study, we can give a grade C recommendation that laparoscopic approach can be used but depends on the expertise of the surgeon. Now, there are no randomized control trials, so we can't give a higher grade recommendation. However, more and more studies are being published, and soon in the latest articles, we can maybe upgrade this recommendation, and which will help us further in this study. Thank you.
Thank you, Dr. Bhatt. Any comment from the audience?
Now it is working.
No, it's not.
I'm just this that he is true son of his father. It's all medicine, what we have seen there, and less of surgery. Congratulations, Davar. Thank you. Sir.
I would like to make a comment. Am I audible with the mic?
Yes, sir, you're audible.
Okay. I'm not. Hello. Okay, I would like to make a comment. Dr. Dawar is compiling this meta-analysis. He has compiled the data till 2012. Now 12 years more, and we'll be publishing the data soon. Thank you, Dawar.
Thank you. By this, we conclude our session.
With this, we will conclude the session of this second day of the conference. Now, I would like to request Professor M.R. Atri sir to kindly come on the stage and felicitate the speakers and the chairpersons of this session. M.R. Atri sir. First, we will felicitate our speakers. Dr. Mohammad Yaqub Bhatt. हाँ राजन, ये तो ग्रुप में डाल देंगे ना सारे फोटोग्राफ्स. हाँ नहीं हाँ लाइट फोन से अच्छे आएंगे नहीं फोटोग्राफ प्लान दो. Dr. Razia Banu. इसमें से दोनों ले लेना. आईफोन पे दे दो. ये तो है आजकल. आपके बादशाह. Dr. Mudassir Habib. Dr. Safur Awani. Dr. Davar Masood. We will felicitate our chairpersons now. Professor Raj Rishi, sir. Professor Naveed Nazir, sir. Dr. Syed Javed, sir. Dr. Rajandeep, sir. Dr. Barinder Kumar, sir. Okay, with this, we conclude the final session of this wonderful day. Please stay for the valedictory functions. I would like to call upon the stage Dr. Arshid Rashid, sir, for the valedictory function.
Davar ko bola, Yasir ko bola. Till we get our bearings right, we'll take some time for that. Surprise that is there. Posters we are getting. Yasir, can I have you here? So at the end of the day, I would like to thank you all for this wonderful Hernia Summit 2024. Okay, not an issue. So please, I would request everyone to come to the front. Okay, I would request all the postgraduates and every student to come to the front, please. Occupy the chairs that are lying vacant in the front. There is a session going on. The last paper is being presented across in Hall B. So I guess there'll be a delay of 4 or 5 minutes for the presentation. And the scores of the poster presentations are being compiled. So we would definitely wait for that. It was a summit, a two-day summit with live operative workshop yesterday, and in all, around 60 posters were presented by undergraduates and postgraduates. 42 papers were presented, and there were 16 guest lectures. There were 3 competitions that were held here. One was exclusively for undergraduates. There was a quiz competition that we took on hernia yesterday after the inaugural for undergraduates. In that hernia quiz, we had 8 teams that were there. Let me see the teams if I have them here. All of the quiz players are here or only the winners are here? Okay, they are here. That is good. So there was an interesting scorecard in the quiz competition yesterday. I would not reveal that. I will wait for that because I want some tempo here. There is no tempo as of yet. And till we get our bearing set, as I said, if anyone has any queries regarding to the events that took place during these 2 days, and we have had so much of hernia, there are so many learned people that you could ask from. You could route the questions through me and I can ask anyone who you want me to ask. I'm your moderator to ask the questions. Yes, please. Can we have a mic? Mic there, please. Can we have in that order sitting there from Biru, as we call him, Biru, he is known as Dr. Barinder, but I still call him Biru. Your comments, sir. उठना खड़ा हो बैठ के रहा है इधर आ
Thank you, sir. Thank you.
चलो आगे
I'm coming there.
आजा इधर क्या उधर नहीं
Thank you. It's an honor to be here. I am Dr. Barinder. I am this undergraduate from this college. Now I am working as assistant professor in Department of Surgery in GMC Rajouri. I am very thankful to all of you that I am here because of you, and I learned lot of things here. And it will be a privilege for me and persons like me who has come from far places, and we have learned a lot of things, and that will change our ideology toward hernias. We can shift from open to lap and extended and so far, and we will be progressive from there. And thanks, Dr. Arshid, and being my senior. I used to call him when I am stuck in some surgery till now, and we are having good relation. And thank you, sir. All, thank you, you all. Thanks.
Please pass on the mic to Zohur sir. Let us hear from Zohur sir. Sir, your comments, please. Sir, khade hoke.
Hello, everyone. I entered late. What is the? I mean, is there a specific
Comments about the conference, sir.
Okay. So thank you. I am Dr. Zahoor. I am working in the Department of Surgery as professor in Jammu Medical College. And besides this, the people of the surgical department of Government Medical College Srinagar has become a headache for us. Sir, for God's sake, please, decrease your speed. We can't cope up, the road, across the tunnel is very bad. So, I am, I would not say envy, I would say I am jealous of you. And I am, it was such an amazing event. We have been attending, we have been traveling to, the far end of the country. India is such a big country, so it was a great pleasure to have this. And I really congratulate you for getting this event here. It is not an, it is not a small thing to get a conference of this level. So it was, really a pleasure, and the variety of, the cases, the live operative workshop. So hands off. And then the academic event and other things, and the hospitality. So all this we enjoyed, all of us, and we were having summer breaks. All we met after a long time in Kashmir, and we are having full masti, all my colleagues. And we were moved by all of me and my colleagues were moved by the invitation and suggestion of Dr. Iqbal Salim that you can come over anytime, we can interact, and he also. So that will be a great thing. So all the best, and thank you for having us making us enjoy for these 2 days here. Thank you, Arshad.
Thank you, sir. Satish, sir.
And I was judging. We were judging the postgraduate work. So you all are doing fantastic work. Congratulations again.
Thank you. I am Dr. Satish Parihar, Professor in Department of Surgery. Dr. Zuhur Soriki. We have the extra one. We are jealous of you because of all this. Definitely. But thank you very much for calling us. I am overwhelmed by the hospitality of all of you and the warmth by you. Thank you very much. And congratulations for the one of the best meet. Thank you very much, sir. आजा यार ज़हूर आजा अरे ऐसी थी तैसी तू भी तो था आजा वीरू आजा वीरू गोपाल अभी भी सर आओ मैं यहाँ पे मशहूर शायद नागिन डांस की वजह से हूँ और मुझे खबर मिली कि कहा गया कि सतीश परिहार को नाचने नहीं देना
he was quite upset. He was not
not at all. We enjoyed a lot.
So I encourage you to show your talent, and that was the talent from the.
तालिब का भी सुनना है अभी तेरी तो गर्दन
Thank you very much.
You know, it's words like these that make me think, no, we are on the right path. Okay? So please don't be jealous. Walk with us and we'll make sure that together we can do something great. Dr. Raj Rishi.
Oh, sir, can we have Dr. Talib? Hear from Dr. Talib.
Yeah, I would like to congratulate the entire Department of General and Minimal Access Surgery, especially led by Dr. Iqbal Salim sir, Dr. Atri, and entire organizing team for conducting such a beautiful this live operative workshop come conference. Yeah. I would like to congratulate each and every member of this department and this team. Yeah, definitely. And I would like to thanks to the entire organizing team for giving us the opportunity to be a part of this scientific event. Thank you very much, sir. Thank you.
Raj Rishi, sir.
Sir, I am Dr. Rishi. I joined in SMHS in 1989 as a PG in the Department of ENT. ENT, sir. Dr. Makbul was here. So after 1 month, I shifted to Jammu, and then I did surgery there. Dr. Atri was there. We were in Unit 2. And then later on, I am professor working there at GMC Kathua. And in between, for 6 or 7 months, I worked at Baramulla also. So Kashmir is a special place in my heart for you. And hospitality, working culture, everything is tremendous. Thank you, sir. So nice.
Can you have Naveed, sir? Naveed, sir.
Thank you very much. I'm not sure whether I'm being called here as a pulmonologist or husband of a surgeon. So I'm connected to the department of whatever you call. I have been associated with the Department of Surgery since I got married, because after married I was not working anywhere here. So my job was to drop my wife, who was a postgraduate in the Department of Surgery, and I think way back in 2007, I think when I came back. So the department has been growing leaps and bounds every year. And I think I must acknowledge the Department of Surgery and Department of Orthopedics were the only two departments which came to our help during COVID, because we had a shortage of staff in our department where we had the sole hospital which was working for COVID at that time, and I think we had residents from all the departments. I would not say that they were not the departments who were not helping us, but the true help which I must acknowledge was from the Department of Surgery and Orthopedics, where the doctors or the residents, whosoever was posted there, was truly working as a physician with us shoulder to shoulder. So thank you very much, sir, and thank you very much for calling me, and I hope the department continues to grow and make us proud all over the country and all over the world. Thank you.
Dr. Gopal.
Thank you, Arshad sir. I feel myself highly honored and privileged to be here. I was a student of this college from 2002 to 2008, and I have learned from this college only. After attending this conference, I feel myself so much motivated that I have already booked my place with Iqbal sir, that I will be coming here for at least 10 to 15 days to learn the skills of laparoscopy. So I would like to thank you for organizing such a wonderful event. Thank you, sir. Thank you very much.
Thank you, dear. Thank you. Can we have anyone from senior residents to speak? Department of Surgery. Or I will call anyone then. Bilal. Yours was the head that was the most down. So come, get up, get up, get up, get up. Oh, get up. No, get up. Yunus. Yunus, come here. We have to compliment Yunus. He held camera for very difficult cases in the OT. And he should be complimented for some other things also, which I cannot tell you here, which I cannot make public. Can you
Assalamu alaikum. I'm Dr. Yunus. I'm working as SR in Surgical Unit 1 with Iqbal. I feel very privileged and lucky to be in the Unit 1. I'm getting adequate exposure, and I think I can do basic laparoscopic procedures that I need to do in the private. And I hope I can do risk-free surgeries in future, inshallah. Thank you so much.
Okay, from third year postgraduates. Who is here from third year postgraduates? Light is in my face. I can't see anyone. Please shift the light. Shift the camera. I don't want the camera. From third years? Postgraduates, anyone? Whom do I see? Okay, can we have Anjali coming up here? Anjali, come here. You are the live wire, first year PG. Come here. वो लाइट मेरी आंखों में है भाई, मेरे को कुछ नहीं दिख रहा है, मेरे को नहीं चाहिए. डोंट शो दिस कैमरा, इधर ले ले. हाँ ठीक है. नाउ आई कैन सी पीपल. फाइव मिनट्स. चल ले बात कर.
Good afternoon, everyone. I'm Dr. Anjali, first year postgraduate scholar in the department. So it's been just 9 months in the department, but it feels like a family to me. And there's a lot to learn from such a great surgeon here. So thank you so much.
Well, there were UG participation also. Can I have undergraduates to come up? Anush, come up here. Tell us about your experience. What do you want in future in conferences?
Assalamualaikum everyone. I'm Anush and I'm from final year MBBS. And I just have to say one thing, that this department has made me passionate about what I have to do in future, irrespective of how draining it is. Since I had chosen electives in Unit 1 surgery, then I had my posting under Dr. 3 in Unit 4. This is the only thing that I like and the only thing that makes me come to college, and I wait for every posting to get over to get back to surgery. Thank you so much.
Okay, thank you. So, as I said, we had 3 sets of competitions. For the felicitation and valediction, I would like to call upon stage Professor Zuhur sir. Zuhur sir. Professor Naveed sir. First the undergraduates. Yasir. Wherever Yasir, please come to the backstage. Yasir. Iqbal sir. For the UG quiz. This is UG quiz. Dawar. Can I have you here? मुझे पता है. For UG quiz, we had 8 teams, and it was a very, very tough competition yesterday. And there is one special award in the quiz, I must say, because I announced it yesterday. Because there was one question that only one candidate answered, so I would call her first. Can I have Liba here? Sir, she answered one question that not even postgraduates answered. So I promised her yesterday that I'll give you a special memento. Peristomal hernias. She's our extern. There was no match fixing. बेटा आगे आ जाओ फोटो ले लो इधर. So then the third prize was for team Cooper, Suhail, Tawheed and Hamid. Do we have them here? नहीं आए. कोई बात नहीं. On behalf कोई extra ना जाओ. Anush, can you come up and collect their certificates? उनके certificates. इसमें है. Yes sir. So the third prize, उधर जाओ बेटा, मेरे पास नहीं आना है. So the third prize is for cash prize of 2,000 rupees, certificates and cash. Please go. Take her. यहाँ से है ना. Third prize. Second prize was for team Gimbernot, Sakina, Anush and Uruma. Do we have them here? There was a cash prize of 3,000 rupees for it. All 3 are present. Certificates एक एक करके आओ बेटा. Sakina, she was your group captain, sir. No, individually, sir. Uruma. For Anush, we can skip the photograph. Anush. The certificate of this. And the toppers were, the first prize was the team McWay. They get a cash prize of 5,000 rupees. Liba, Humaira and Madiha. Can we have them? Liba. Madiha. And you sit back. Madiha, Humaira. Humaira, please come. Please come. Quicker. There is also a memento for the first prize. So please hand it over to all three. Check and memento. लाओ. Get mementos. बेटा वेट करो, एक और ले लो आपके mementos. Thank you. So after this, I would like to go for the award ceremonies of posters and papers. But before that, I'd like to honor the judges. So for the free papers, the judges were Satish Parihar sir. Please come. Satish sir. Dr. Mujtaba, Dr. Zahid, I guess they have left. For the posters, the judges were Professor Roof sir, Professor Zohur sir, he is there only. Professor Zohur sir, sir, please felicitate Zohur sir also. He was one of the judges. Dr. Abdul Hamid sir. So now the winner, first the third prize for the paper. Third prize? Third prize goes to, any guesses? Okay, Jamil, come. Jamil got 65 points. Jamil was presenting a talk on fundoplication, a paper on fundoplication. He receives a cash prize of 2,000 again. First, chal. Second prize goes to Dr. Rahil from SKIMS. Is he around? Dr. Rahil, on behalf of Dr. Rahil, sir, Dr. Rahil, I'll request Dr. Roof sir to please collect it on his behalf. The certificate and cash prize of 3,000 rupees. His talk was on diaphragmatic hernia. And who gets the first prize? Okay, how can you be wrong? KD. She presented a topic on a paper on loss of domain hernia. She has got 70 points. Rahil from SKIMS had 67 points. Okay. Okay, I would like to thank you all, sir. Thank you so much. Thank you so much. I would like to call on Professor Shakil, sir. Professor Chalku, sir. For the posters, we have the third prize. Mushtaq, Dr. Mushtaq. What was the topic? I don't know the topic. What was your poster title, beta? Okay, his topic was impact of laparoscopy on testicular perfusion. Laparoscopic repairs on testicular perfusion. He receives a cash prize again of 2,000. Thank you, Dr. Mushtaq. Second prize goes to, any guesses? Mahima. Where is Mahima? She had an interesting paper on retrograde jugulogastric intersusception. She receives a cash prize of 3,000. And first prize? Okay, come up. Rishabh. He receives a cash prize of 5,000 and a memento and a certificate. What was your topic, Rishabh? Progressive preoperative pneumoperitoneum. हो गया? 1 customer. So there should be. Then there is felicitation of the organizing committee of the event. Could I request Professor Iqbal sir to, okay, I'll wait, not an issue. Sir, kindly receive your felicitation as organizing chairman of Hernia Summit 2024. Can I have please and round loud applause? Sir, please stay there. You can hand over the memento. Can I have Professor M.R. Atri, the organizing secretary of Hernia Summit? Sir, stay back. Sir, please, I request Professor Mushtaq Chalku, sir, the chairman scientific committee, to receive the felicitation. No, sir. Sir, please. I'd like to request Dr. Abdul Hamid Samoon, again, scientific committee of the organizing committee. Stay back, sir. Sir, organizing committee, scientific. I would like to request myself also to go there.
We did a wonderful job. Always behind the stage is there. The smile, and that is the most important thing, that he has to show that he's interested in doing the job. That's what we want. Thank you very much.
There is a very important person here again, Dr. Mohsin. Unfortunately, Dr. Mohsin is not well. He is the joint organizing secretary of the conference. Believe me, it is his hard work that we are seeing today. It is his hard work that we are. I want at least claps for him. Can I have Dr. Irfan, the treasurer of the conference? Now his headache is going to start. Claps for him, please. So, if we faculty members were involved in the conference, but it was not possible, we were just directing the workforce. The workforce are the residents. And if we do not applaud their effort, we fail in actually conducting the conference. So, 3 cheers for you all.
Good afternoon. It's only because of you people, the guests from outside, but the workforce was from you. And I'm proud of being the part of this workforce. Maybe I was not working that much as you, but my brain was always in a swivel. 3 cheers for you. Can we have hip hip? Hip hip? Hip hip?
I would like to invite Dr. Moeed first. Moeed, is Moeed here? Moeed was in charge of registrations, the QR codes and all the designing he has done very meticulously. Moeed has lost more weight. बीच में आ जा बेटा. यार क्लैप्स तो करो, क्या कर रहे हो? Dr. Safura, where is she? The lady who organized everything on the stage. She is the mistress of the stage. सर इसको और छोटा कर रहे हो मार मार के. My most important person, as I was interested with halls, my most important person, Dr. Afshan. Where is Afshan? He is the person, if you see this hall clean, if you see this hall organized, it's only because of him. For the past 2 days, he has been coming up at 5 a.m. in the morning. Both these days, he has come morning at 5 a.m. बीच में जा. Oh, yaar. Dr. Yasir, who has micromanaged rather everything. Everything means everything. Silently working without any fuss, working. Do I have Dr. Anis here? Dr. Anis is actually responsible for designing of all the pictures and the logos and the designs of the conference flyers and brochures. Dr. Dawar. Dr. Asim, again, very important in hall committee, managing everything backstage. This is the workforce that we have created. Can I have Dr. Yunus to receive the award? He was responsible for managing the OT. Ya da treba stop, treba sponsor ne bakan. Yaman dimo ke na. Aman da tempo sobre PG ko pat. Dr. Salma, Dr. Afnan, be ready. Afnan, Salma, जल्दी आ जाओ. सलमा, कोई तो आओ यार. चलो एक एक करके. अफनान, फास्टर. पहले आप स्पॉन्सर्स को बोलो. सर इसका कुछ नहीं करने में ही अच्छा था. अगर ये कुछ करती तो फिर कुछ नहीं होता. नहीं आई नो. फोटो गोवा. चलो डॉक्टर सलमा. PGs will have to wait. So thank you the organizing committee. Thank you. अभी नहीं हाँ अभी सर वो इतना OT sponsors PG sponsors PG sponsors ये वाला ना इनके जो यूज को कर दो ना ये सारे साइंटिफिक एक्चुअली यूज इतने भी बोलो सर कमिटीज के हेड को कर लो सर मोमेंटोस हैं हां तो सर है ना हां तो करना ठीक I would now like to request Professor Iqbal sir again. And Professor Shakil sir. ठीक है सर. कौन है जो भी है ये तो हो गया सर. आगे बढ़ो. सर मेरे को यहाँ पे इसके नाम नहीं है ना हेड का अवांसर तो नहीं है ना नाइकू सर. From the souvenir committee, do we have Avancer is not here. Is Dr. Naiku here? Dr. Kulwant? Dr. Sir? Dr. Mukhtar? ठीक है. Dr. Mukhtar? Where is he? ठीक. कितने? Where is he? He was in that house. Dr. Mukhtar? Hanif? Dr. Hanif है ना? सर नहीं सर ये एक्चुअल प्रोसेस ये नहीं है सर ये कमेटी है ना सर. हाँ ये कमेटी है इनके एक्चुअल सोविनियर में डॉक्टर नायकू नहीं है. डॉक्टर मुख्तार इज हियर. इज डॉक्टर मुख्तार हियर? नो. रजिस्ट्रेशन कमेटी शकील सर. प्लीज फेलिसिटेट शकील सर. इनको मिल गया ना शकील सर. मंजूर सर कैन डॉक्टर मंजूर कम. डॉक्टर मंजूर चालकू. ठीक है सीधे कौन जावेद साहब. वर्कशॉप कमेटी राजन. डॉक्टर राजनदीप. डॉक्टर जावेद और राजन दोनों को दोनों डॉक्टर जावेद कादरी. डॉक्टर हनीफ. Hanif? Scientific committee is done. Workshop committee. Hall committee. From hall committee, do we have Dr. Kulwant? Sir, please come up. Sir, please. Do we have Dr. Khurshid? Hello. From the catering committee, do you have Dr. Mushtaq sir? Sir, committee. Do we have Mushtaq sir here? Dr. Zafar sir? Dr. Mukhtar? Dr. Tahir is not here. From the hospitality committee, Rashid sir has not. Dr. Rifat is here?
Rifat is there.
Dr. Rifat.
Claps for our, come on. He is the unsung hero of our department.
Where's the mask? Thank you. सर मैं वो बोल रहा हूँ आगे मैंने बोला था डॉक्टर खुर्शीद is here? No. Okay. Can we have Mr. Javed Shola from MRD section? Is he here? Dr. Mr. Javed, please come up to receive your memento. Fast, fast, fast. Do we have Mr. Rasid Dar Saab, PA to the PMC? Do you have Mr. Javed, estate officers? From photographic section, you have done an amazing job. Shahnawaz. Nazir Ahmad. Nazir Ahmad is here? Nazir, Kachwi. Shahnawaz, आप ही ले लो यार. हाँ नजीर नजीर. को बोलो जावेद को सर सर अदरी सर जावेद को भी फोन करो जावेद एस्टेट No, I called this. Do we have Zohur Saab, electrician? Zohur Saab, please come up. Please. Please, he's a wonderful guy. I need louder claps for him. Ashraf Kachhi. From the auditorium, do we have Tahir here? Mr. Tahir, please come fast. Tahir, come fast. Do we have from the audiovisual committee, from the audiovisual team that is here? अच्छा सफर साहब आ रहे हैं जब आएंगे मुझे बोलना Firdos from AV team. Where is Makbul? Is Makbul here? Adnan. तू आना तेरा नाम बुला रहा हूँ ना. Adnan. Mahfouz. Mahfouz. Do we have Mr. Ashraf from parking section? Please, Ashraf Saab. Oh, cheers for this guy. He always manages the traffic. Ashraf Saab, Ashraf Saab.
Somebody will collect on
Do you have Maqsood Saab from gate? Gatekeeper, Maqsood Saab. Maqsood, fast, fast. Do you have Rashid here? Staff of Iqbal Saab. Rashid. Rashid. Jaldi aaja beta. Asifa ji. Is Asifa ji around? Rashid. Asifa. Is Afshan here? Afshan Saab. Acha, Pruswas na. Okay, from OT. Nothing could have been done without OT. Can we have chairs for the OT staff, please? Tariq. Tariq Saab. कहाँ हो तारिक साहब ओटी तारिक जावेद समी शाजिया बिलाल इकबाल मुजम्मिल no one is here from our office Fayaz Bilal Fayaz is here okay can Manzoor Ahmed gatekeeper come and receive the memento please Jaldi. Sponsors. Such as sponsors. Sponsor page. Nah. So this conference would not have been possible without our sponsors. But before that has Mr. Rasid come to this place? So, anyone from J&J? Surjit is here? Is Surjit here? Surjit, come up. Surjit. Sir, इनको अलग-अलग Surjit और Nasir को अलग. Surjit. Surjit, come up. Even though it is not his forte, a big round of applause for Johnson. That is why we have given a memento before Nasir, because its hernia division is Nasir's prerogative. Nasir. जल्दी जल्दी Nazim from Metronics. हमने तो लिया अब हम कितना लेंगे Narinder from first striker people anyone from striker Rupesh is here. बोलो ना हमने बोला हाल का उनको जावेद सबको बोलो बोलो जावेद सबको Narinder Merrill. Is Narinder here from Merrill? Merrill, anyone from Merrill? Anyone from Elcom? Elcom, fast, please. McLeods. Okay, I can see Irshad here running up. Aristo, anyone from Aristo? Fast, please. Aristo. Anyone from IPCA? Okay, Shaukat is here. Shaukat, rush. Anyone from Abbott? Is Tariq here or Fahim? Tariq, fast. Sir, Aristo बुलाया उसमें एक आगे GSK, Glaxo. Anyone from Glaxo? Anyone from Glaxo? Heldium? Torrent? Okay, Irfan is coming. Irfan, rush. Anyone from Sun Pharma? From Sun Pharma, do we have anyone here? From Carl Stores? SR Technomed. SR Technomed. Sir, we have given. We have called them on this call. Important. Yaqub ji na wo kuch auditorium mein chauथा usi kahir. Yaqub from auditorium can come up and collect his memento. He was always here cleaning the auditorium and doing all the wonderful job. Claps for him. Has anyone from Merrill come? Merrill guy, kindly faster. No. Bus. PGs? So, on behalf of Rasid, Dar Sahab, Saqib has come up. Can I request him to collect the memento? Saqib, please come fast to receive the memento. On behalf of Rasid Sahab. Sir, we have PGs and SRs. Dr. Haris. Can I request Chalku sir to come up on the stage? So, Iqbal sir, you please rest for the time. Haris, you seem to be busy on phone. Can we have Sadat here? Sadat. Can we have Sadat? Sadat, you wait there. Absolutely, sir. No, sir, I am nowhere. I am nowhere. So, Sadat, you stay back, you stay back. Javed sir, please felicitate her with a shawl. Sadat has become synonymous with the voice of surgery department, if I may put it like that. By now, she must be having good collection of shawls at home. She is collecting. Dr. Sadat, I want your comments. Sir, what's your comments? It should start with
अभी राह तो शुरू हुई है, मंजिल बैठी दूर है, उजियाली महलों में छाई हर दीपक मजबूर है. Thank you.
So I guess the poetic taste still continues. Hashmat, hash. So he is the real hash of the department. He's hashtag, hash, whatever you call him. An excellent job by him operating all the presentations. Hina, are you here? Hina, jaldi, jaldi, jaldi, beta. Can we have Rishabh? Rishabh. Ashik. Where is Ashik? So, oh, we have an entry of the great man. We always wanted him here. He is now here. I need everyone to clap for him. Tariq Saab. Tariq Saab, Zindabad. वो जोर से clap करो यार. He is the soul of OTs of GMC Srinagar. Backbone, absolutely. इकबाल सर आप भी आ जाइए एक सेकंड. तारिक stay back. Sir, you take a pic with him and then you can sit down back. Beauty.
You will have to excuse me. I recently had a severe low backache, and I think it has started to give trouble again. That's why I'm not able to stand here. Otherwise, I love my postgraduates, and I would never miss a chance like this. Okay, so never think like that.
Ashik has received his felicitation. Ashik? Okay, Waseeb. Wasim. Imtiaz. Imtiaz. Khujdil. Razak. Is Razak here? Mahak. Is Mahak here? Mahak. खुद ही ला और खुद ही महक अंजलि उसको जो उसको भी अंजलि महिमा महिमा he deserves one more for serving all the mementos. Lokendra. Lokendra. Gurveen. Riyan. Dr. Sajjad Malla. Sadbir. Jamil. Faster, Dr. Bisma. Fast. Bisma, faster. Riyan. Riyan, faster. Ishtiyaq is here. Ankit, fast. Sadbir. My favorite PG. Who is my favorite PG? Jamil, my favorite PG. Dr. Firdos, senior resident. Wonderful guy. Bilal. Ashutosh. Is he around? Ashutosh. He has recently joined us as a fellow. Ashutosh. Haris Khurshid. Dr. Rishita. Dr. Veera, where are you? Veera Krishnan. Veera or Veera? Veera Krishnan. नाम चाहिए मेरे को पीजीज के, मुझे नहीं पता है ना, मैं जानता नहीं हूँ. Feroz. Vamsi. Shahzeb. Vikas. Ashik. Where were you? Loud claps for this guy. He managed all the posters and everything. Dr. Anna. Ibrahim. Mustafa. Yes, from hall committee. Sohail. Yunus, please collect on behalf of Sohail. On behalf of Sohail, please collect a memento. Nasir. Nasir. Is Nasir here? Ashik, please collect for Nasir. Pass. And on behalf of Ranjit, I would like to ask Dawar to collect the memento. Ranjit is not here this time. Please claps for him. He was instrumental in getting this thing done. Saad. Anyone collect on behalf of Saad? Rishabh. Yaqub, please receive a memento for contributing to this conference. Yaqub. Razia. मैं stop कर रहा था. I guess Razia has to carry a truckload of mementos home. Mudassir. एक second. On behalf of Jaiparam, Dawar, please again. Ramesh. Is Ramesh here? Anyone from Ramesh's unit? Anyone from Ramesh's unit? Shahid? Anyone from Ramesh's unit? Ramesh? Shahid? Shahid is here? Shahid, anyone please, Gurveen, come collect for Shahid. Saurav? Is Saurav here? On behalf of Saurav, Ashik. Raj? Where is Raj? Vamshi, collect on behalf of Raj. Miss one copy. Have I missed anyone who has not received in a single memento? Please, PGs.
PGs. Among PGs. Anybody who has missed?
Vivek.
Vivek. Where is he?
Sadbir. Vivek ke behalf pe. Vivek ke liye le. Rahul. I had asked their name. We called them. How much else we can bid from them? How much else bid from them? Surya Rakya. अच्छा फर्स्ट ईयर के नहीं दोनों शकतो सूर्या राकिब is one or not? Surya Rakib. Surya or Rakib? Rakib is here? Surya? Umar Mukhtar.
Any PG level. Any PG who has not received.
Any PG who has not received any memento, please collect it from organizing committee after the valedictory. If anyone has not received it. That Muzaffar, is Muzaffar here?
Any SR left?
Any SR? Iram, third year, is she here? Fatima? So those in those auditorium. I think I conclude the valedictory function. Thank you all. Thank you all. I would also like to mention here the role of Rizwan. Rizwan, is he here? No, Rizwan. Thank you all. Thank you all. Do you like to say something?
Thank you so much. Thank you so much, all of you. It was all a collective effort by everybody from the Department of Surgery, led by the chairman and head of the department, Professor Iqbal sir, and we all followed him in this whole exercise. And this is how it has shaped up. So it is a team which matters. You were all there. That's why how this HOD and I could deliver it. Such a wonderful event, and I thank you, I congratulate you on behalf of HOD and myself that keep growing. This is the time when you should have some positive vibes from here, and whenever now you go to OT or go for rounds, carry these positive vibes with you. Try to develop such type of attitude that tomorrow you can be one of those legends who delivered the great lectures here. Thank you so much.
आपका है शुक्रिया